Macam mana nak fokuskan ni? Okay, alright. Okay, alright. Alright. Welcome everyone. Alright.
Recording in progress. Glorious panelists, Encik Masni, pasukan IT atas, tolong glorious panelists. Streaming is good. Yes, we are live.
Good morning. Good morning, ladies and gentlemen. I'm Dr. Tanis. Welcome again to the 12th Biennial PGMES Scientific Meeting 2022. After all the impressive and mind-stimulating lectures yesterday, I'm sure you must be eager for more today. The first speaker for today's plenary is Dr. Aravindran Alaga. Dr. Aravind is a young, brilliant, talented, and skillful pulmonologist. He is the current consultant and department head of respiratory medicine in Sultanah Bahiyah Hospital, and also serves as associate consultant for respiratory services. Dr. Arvind graduated from Malacca Manipal College in the year 2007 and obtained his MRCP in 2014. He then pursued his interest in respiratory medicine and obtained his International Pulmonology Fellowship from Nagoya, Japan in 2020. Hence, being the first Malaysian to receive this prestigious Harasawa Fellowship from the Japanese Respiratory Society. He was also the first Malaysian trainee to receive the APSR Training Award in the same year. Apart from that, Dr. Arvind is a Fellow of the Royal College of Physicians, Edinburgh 2020, Fellow of the Asian Pacific Society of Respirology 2021, and Fellow of Respiratory Medicine Malaysia 2021. He also holds a European Diploma in Adult Respiratory Medicine 2021. Dr. Arvind is actively involved in SCOMOS and MMA and has held important positions in both. The Japanese Society of Respiratory Endoscopy invited him as a speaker for their 44th annual scientific meeting last year, where he was the only Malaysian speaker who was invited. And not to forget his active participation in academic research and journal publications. Dr. Arvind has brought a lot of changes to the Department of Respiratory Medicine and has upgraded its services. He has initiated daycare bronchoscopy services and also performed advanced interventional pulmonology services in the state of Kedah and North Malaysia. And now, with pleasure, I invite Dr. Arvind to speak on post-HIV experience. Thank you.
Thank you for a kind introduction. A very good morning to all the participants. I'm Arvindran here. I feel privileged to be part of this update, which is organized by an esteemed organization. My topic today is post-COVID lung diseases, Hospital Sultanah Bahiyah experience. So this will be outline of my topic today. Terms which we need to know: COVID-19 and lung, what COVID-19 does to the lung, post-COVID-19 lung, and data from chest allostaff. A bit on background. COVID-19 first detected in December 2019 in Wuhan, China. It's a seventh coronavirus known to infect humans. The lack of pre-virus immunity has led to an exponential increase in infected patients worldwide. As of now, we have more than 433 million cases worldwide, with almost 6 million deaths. How about Malaysia? We can get all this data from COVID Now website, which have a total active 19 cases and also total cases so far. The website also contains data regarding the death rate, patients ventilated, and also patient in ICU. We shall move on to the terms. The impact of COVID-19 thus far has been unparalleled, and long-term symptoms could have a further devastating effect. Recent evidence shows that a range of symptoms can remain after the clearance of acute infection in many people who have had COVID-19, and this condition is known as long COVID. So acute COVID-19 is a sign and symptoms of COVID-19 up to 4 weeks. Ongoing symptomatic COVID-19 is sign and symptoms COVID-19 from 4 weeks up to 12 weeks. And post-COVID-19 syndrome, sign and symptom that develop during or after infection of COVID-19 and continue for more than 12 weeks and not explained by any other alternative diagnosis. Usually present with cluster of symptoms, often overlapping, which can fluctuate and change over time. Long COVID gained a widespread attention following an account published on 5th May 2020 in BMJ Opinion, where an infectious disease professor shared his experience of 7 weeks on a roller coaster of ill health following COVID-19. So long COVID defined as both ongoing symptomatic COVID-19 from 4 to 12 weeks and post-COVID-19 syndrome 12 weeks or more. We shall move on to COVID-19 and lung. I'm sure by now all of you are expert in these phases of COVID-19 infection, which include early infection phase up to 5 days, pulmonary phase up to 10 days, and hyperinflammation phase more than 10 days. If you notice, this will be the viral response, which is reducing in trend, whereas post-inflammatory response will be increasing in trend. And early infection phase include symptoms such as fever, cough, myalgia. Pulmonary phase include the respiratory failure symptoms, and hyperinflammation phase includes the ARDS, shock, and multi-organ failure. The timeline for acute and post-acute 19 described in this particular diagram. So this phase is where we are exposed to the COVID-19 virus, and virus replicate in our body and detected by the nasopharyngeal swab test, and subsequently viral load reducing in trend. After 4 weeks, there will be a post-COVID-19 symptoms, which include fatigue, persistent oxygen requirement, palpitation, chest pain. It can last up to 12 weeks or even up to 6 months. From our observation, the spectrum of disease which range from acute infection up to post-COVID-19 syndromes have many other comorbidities such as secondary infection, post-intubation complication, pulmonary embolism, reactive airway disease, and also interstitial hyperinflammation. During post-COVID-19 phase, we also see patients can present with acute exacerbation of interstitial lung disease and also lung fibrosis. So multi-organ complication of COVID-19 and long COVID are due to COVID-19 virus which gain entry into the cells of multiple organs via ACE2 receptors. Once these cells have been invaded, the virus can cause a multitude of damage, ultimately leading to numerous persistent symptoms, some of which are outlined in this particular diagram, including brain fog, liver injury, kidney injury, pancreatic injury, and also various symptoms of lungs. What COVID-19 does to the lung? A bit on a pathophysiology of lung involvement. This is based on the report from China and also reports from Italy, the two countries severely affected by COVID during the early phase of pandemic. So the risk factors associated with severe COVID-19 are also shared with patients with idiopathic pulmonary fibrosis, which are advanced age group, male gender, and also comorbidities like diabetes, hypertension, and smoking. And this COVID-19 induced abnormal immune mechanism, including cytokine storm, which lead to pathological proliferation of extracellular matrix. If our body managed to resolve the extracellular matrix, there will be resolution without any sequelae. But if lack of resorption or removal, ECM will lead to residual fibrosis with pulmonary dysfunction. And for information, almost 40% of COVID-19 patients develop ARDS. And another important term is organizing pneumonia. So those who are in charge of COVID-19 wards or patients are well aware of this particular term. So organizing pneumonia is a form of diffuse parenchymal lung disease. It's a distinct clinical pathological entity that may occur as a pulmonary reaction to various injuries, including ARDS. If you notice in my previous slide, almost 40% of COVID-19 patients can develop ARDS. It's a process of lung tissue repair, maybe due to cryptogenic cause or secondary to lung injury, including bacterial, viral, and also fungal infection, plus malignancy as well. It can be diagnosed based on the biopsy or radiological appearance. And steroid therapy is the first line treatment for organizing pneumonia. And viral-induced organized pneumonia has been observed in previous pandemic, like such as SARS and also MERS-CoV. And if not mistaken, during the SARS, organized pneumonia was reported in almost 30% to 60% of patients were admitted into ICU care. So this is a guideline from NIH as well as the IDSA. You notice both also advocate the usage of steroids in COVID-19 patients. I would like to share some cases we have managed here during this presentation. This patient is 37-year-old woman with COVID-19 requiring high flow nasal cannula. If you notice, this is 6 days after the onset of symptom, then we given a pulse methylprednisolone. Subsequently, after discharge, her CT scan show remarkable improvement. So this is the some literature regarding 239 COVID-19 patients with pulmonary fibrosis. If you notice, those patients with critical COVID-19 cases have more severe pulmonary fibrosis rather than those having a moderate COVID-19 illness. So COVID-19 pneumonia and the typical CT findings. So most often we come across ground glass opacity, which typically with a peripheral and subpleural distribution, which involve multiple lobes, particularly lower lobes. And also the area of ground glass opacity can mix with focal consolidation associated with superimposed intralobular reticulation, which called as a crazy paving pattern. And they also can present with linear consolidation, which frequently observed mostly in patients several days after the onset of disease. So initial CT findings on CT scan was small subpleural ground glass opacity, then grew larger with crazy paving pattern and consolidation. The lung involvement typically increased to consolidation after 2 weeks, and after 2 weeks, the lesion will gradually absorb. And based on the CT scan findings, we can even classify the patient into the stages of COVID-19. If you notice, based on this particular ultra early stage, the CT scan can demonstrate bilateral subpleural multiple scattered ground glass opacity. In early stage, it can show multiple bilateral ground glass opacity with irregular interlobular septum. And rapid progression stage will have subpleural posterior consolidation, dispersed air bronchograms, and consolidation stage will have a decreasing size and density of consolidation. Dissipation stage will have patchy consolidation, reticular opacity, bronchial and interlobular septothecany. And we also grade the lobar involvement based on this particular score. If 5% or less will be a score 1, if more than 70% will be the score 5. And also if total score, if let's say 7 or less, will go to mild category, and 18 or more will be a severe category. Some other interesting terminology in CT scan of COVID-19 patients are, beside the ground glass opacity, atoll sign, perilobular pattern, is a perilobular pattern, fibrotic pattern, band-like opacities, nodular pattern, and also parenchymal consolidation. A typical pattern will involve a peripheral bilateral ground glass opacity with or without consolidation, can have a multifocal ground glass opacity, and also reverse halo sign and other findings of organizing pneumonia. If patient have or there's a presence of discrete lung nodules or lung cavitation, we need to investigate for other causes. Again, these are the patient CT scan from our follow-up. You can see various kind of organizing pneumonia presentation in the CT scan. Another case, 56-year-old male, intubated within 8 hours of admissions. And if you notice, the chest X-ray changes resolved at 12 weeks. So we have seen about the interstitial involvement. How about pleural involvement? So this particular data shows that roughly around 1% of patients admitted with COVID-19 develop pneumothorax, and this can occur without any pre-existing lung disease or mechanical ventilation. 2/3 of patients survive but age more than 70 years, and acidosis are associated with poor prognosis. So this is the multicenter retrospective case series. Another trial or survey is called a supportive survey, done from September 2020 to February 2021 in UK, involving 53 hospitals. The primary outcome was to determine the incidence of pneumomediastinum in COVID-19 and to investigate risk factors associated with patients' mortality. What they found is the incidence of pneumomediastinum in COVID-19 is around 0.64%, and 120-day mortality in COVID-19 pneumomediastinum was around 51.7%. So pneumomediastinum appears to be a marker of severe COVID-19 pneumonitis. The majority of patients in whom pneumomediastinum was identified had not been mechanically ventilated at the point of diagnosis. We have seen a couple of cases here. Patient with COVID-19 developed pneumomediastinum in Alostar as well. Now we move on to the post-COVID-19 lung. The golden question is, who gets the long COVID? So based on our data, between 2.5 to 15% of people still symptomatic more than 12 weeks. The factors that appear to be associated with greater risk of suffering from long COVID appear to be advanced age, excess weight or obesity, female gender, patient with pre-morbidities like even asthma, and multiple symptoms during the presentation. So now, based on many available literature, advanced age with a critical illness in patients with underlying comorbid conditions like cardiovascular disease, diabetes, respiratory ailments, and cancer noted to be the risk factors for long COVID. Another literature or article from this particular group documented that elderly male more than 50 years and more than 3 comorbidities are as a risk of long COVID. If you notice, there are multiple studies involved regarding the potential long-term complication after COVID-19, and with a particular interest in lung disease and also neurological disease, especially stroke, embolism, and also thrombosis. So what we learned from the past. So this is a long-term clinical outcome in survivors of severe acute respiratory syndrome and MERS outbreak after hospitalization or ICU admission. So this particular data shows that lung function abnormalities, psychological impairment, and reduced exercise capacity were common in SARS and MERS-CoV survivors. So clinicians should anticipate and investigate similar long-term outcome in COVID-19 survivors as well. So this is the data showing that lung function outcomes at 6 months, there's abnormalities in DLCO, FVC, and total lung capacity. After 6 months, the DLCO impairment remained considerably high, whereas other parameters improved. So this is a summary of post-acute COVID-19 by organ system. So it can involve from pulmonary up to dermatology, but my interest will be more on a pulmonary system. What about the local data? If you notice, this is the largest study presented by our Malaysian team in Lancet, involved 5,889 cases from 1st Feb up to 30th May 2020. So around 3.5% progress to severe disease, 3.3% require intensive care. Common complications were acute liver injury and kidney injury, plus ARDS. Factors which associate severe diseases are age more than 51, comorbidities, presence of multiple symptoms, chest X-ray abnormalities, and raised CRP. And 2/3 of adults still have some symptoms like anosmia, dyspnea, and asthenia. So this data also shows that male gender are predominantly involved in this particular COVID-19 illness. So what COVID-19 can cause the complication towards the small airways? We notice that there's a high prevalence of long-lasting air trapping by imaging, regardless of initial severity of infection. However, long-term complications still unknown. So we need to wait and observe this kind of patients. So what about interstitial lung disease before and after COVID-19? Are patients with pre-existing ILD at higher risk of pulmonary complication? Do survivors of COVID-19 without known pre-existing ILD manifest pulmonary fibrosis? And what is the appropriate management of post-COVID-19 interstitial lung changes? So from available literature and findings suggest that patients with ILD are at higher risk of both acquiring COVID-19 and having a worse outcome during COVID-19 illnesses. And survival of COVID-19 without known pre-existing ILD can manifest pulmonary fibrosis. So what we suspect is this particular COVID-19 will kick in the pulmonary fibrosis in this patient, which have all the predisposing risk factors. So actually the pulmonary fibrosis or idiopathic pulmonary fibrosis can manifest earlier than it's supposed to be in these patients. And do we use antifibrotics in these kind of patients? And there are many studies ongoing at this point of time, especially in US and Europe, regarding the usage of antifibrotics in post-COVID-19 fibrosis patients. So high dose versus low dose prednisolone, interesting study, coastal trial. So usually if you notice those patients who are having organizing pneumonia usually refer to respiratory physician for the tapering dose of prednisolone. So in Malaysia, management of acute COVID-19 is being handled by general medical and ID team, whereas post-COVID-19 cases taken over by respiratory physicians, and also we co-manage the patients with organizing pneumonia in ICU. So this particular trial shows that they randomized the group into high-dose prednisolone, like 40 mg per day for 1 week, followed by 30 mg and 20 mg and also 10 mg, versus the low-dose prednisolone, 10 mg per day for 6 weeks. In conclusion, they found that there's no difference between high-dose prednisolone and low-dose prednisolone in improving the clinical, radiological, physiological outcome. So maybe from now onwards, we may need to give a low-dose prednisolone for those patients who are having the organizing pneumonia in ICU setting. So follow-up of post-COVID-19 cases. I like this particular advertisement, which I found from the Google. So they divide into basic care package, advanced care package, and also supreme care package. So again, another golden question or statement, post-COVID-19 lung fibrosis, the tsunami that will follow the earthquake. So this is a natural history of post-COVID fibrosis. Majority will stabilize or improve over the time, although some patients will progress to advanced lung fibrosis or post-COVID-19 interstitial lung disease. So this particular study shows that at 12 months, only 22.9 patients were completely free of symptoms, and most frequent symptoms are reduced exercise capacity. And females show significantly more neurocognitive symptoms than males. So what we need to have is an interdisciplinary management in COVID-19 clinics, especially led by respiratory physician or pulmonologists, supported by our rehab colleagues. And also we may need support from neuropsychiatry, hematology, or nephrologists, and also primary care physicians. So these are the guidelines from British Thoracic Society. For those with severe COVID-19 cases which managed in ICU or ECW, within 4 to 6 weeks of discharge, there will be a telephone consultation and there will be a face-to-face examination in 12 weeks after discharge. If normal, we can discharge them. If there's evidence of interstitial lung disease or vascular disease, we need to refer to the respective colleagues. Whereas for the mild cases like COVID-19 category 3 and below, there'll be a TCA after 12 weeks after discharge. If normal, we can discharge them. If abnormal, we should follow as per previous algorithm. So another guideline from Ganesh Raghu and his team. So this particular guideline shows a very frequent follow-up and also with frequent HRCT scan as well. So this also from the NICE Rapid Communications, which combine both previous guidelines. So what we worry is in future, do we need to include or create a post-COVID-19 fibrosis in this particular column? So if you notice this, how we divide interstitial lung disease with major, unclassifiable, and rare diseases, do we need to add on another column here? So only time can answer it. So we also came up with our own post-COVID-19 management protocol for MOH. So we have a algorithm for post-COVID-19 stage 3 and also stage 4 and 5. It's almost similar to what BTS guideline. And we move on to chest allosta data. So I'm proud to say that we have managed almost 1,000 patients so far. Our first patients from November 2020, majority are males, and we are one of the first center to come up with the post-COVID-19 guidelines, far ahead from the national guidelines itself. We published our guidelines somewhere in October 2020, and we improvised over the period of time. So these guidelines, post-COVID-19 follow-up guidelines for POCADA. So category 3 will be followed up in primary care. Category 4 and 5 should be followed up by respiratory and general medical clinic. So these are what we need to ask and document here. And I would like to emphasize a bit on LTOT. There are indications for LTOT such as SpO2 less than 88%, and from ABG, PO2 is less than 55, and also in the presence of core pulmonale. This is similar to our COPD guidelines. And another important factor is short-term oxygen therapy. If SpO2 is between 88 to 93, if SpO2 can be stabilized with low flow nasal cannula, these patients are eligible for SDOT, and usually we can titrate it and follow them up in our respiratory clinic. So far, in a month, we may have around 5 patients which we need to give short-term oxygen therapy, and eventually they'll recover within 1 to 3 months' time. Some of the interesting data which we submitted to international conferences. So this particular data we submitted to upcoming ERS conference. So clinical characteristic and the long-term post-recovery manifestation of the COVID-19 patient, a retrospective series from North Malaysia. So we analyzed 199 patients with category 3 onwards from November 2020 to March 2021. 70.9 patients falls into category 4, and mean age was around 52.1 plus minus 14.6 years. 1/3 of patients has underlying diabetes and hypertension. Median length of hospitalization was significantly prolonged in category 5. Our conclusion, post-COVID-19 persisting symptoms can cause a significant burden to healthcare system. Periodic follow-up should be scheduled accordingly to prevent future comorbidity in patients with post-COVID-19 syndrome. So another interesting study, tuberculosis and COVID-19. So we analyzed from January 2021 to September 2021, total 12 patients of COVID-19 patients who were diagnosed with TB during their admission. And mean age of these patients was 59.6 plus minus 10.6 years, and majority of them were male, and 2/3 of them had a history of smoking. Use of corticosteroid in treatment of COVID-19 infected patients who required oxygen supplementation further complicated the underlying TB infection. So our conclusion, male patients with history of smoking were likely to have higher risk to get both COVID-19 and TB infection. And a routine screening for TB is therefore recommended among suspected or confirmed cases of COVID-19, category 3 and above in countries with high TB burden. So with that conclusion, COVID-19 can cause long-term sequelae in a relevant number of patients. Dyspnea, fatigue, anxiety, depression seem to be the most frequent symptoms. Severity of post-COVID-19 sequelae are usually related to the severity of the manifestation during the active phase. Need to set up a post-COVID-19 clinic, which already have in many places, led by respiratory physicians while collaborating with other respective multidisciplinary teams, especially from rehab. And definitely we need more budget to run this clinic and more manpower to run this clinic. Huge burden on healthcare system due to the post-COVID-19 patients. With that, I would like to thank all of you for your attention. And this is my team, my MS team in Intervention Pulmonary Suite, my MO team, and also Chest Alosta is our official Facebook. Thank you very much.
Thank you very much, Dr. Arvind, for that very interesting talk. Since we are a little bit ahead of time, I think we can give about 2 questions to be answered by Dr. Arvind.
Sure, Dr. Tanis. Can I answer the questions or?
This one's
What COVID-19 does to the lung, post-COVID-19 and data from the
Hello. Good morning. I think, am I
So
audible?
the first question is on pneumomedia's dynamic COVID. So one of the audience was asking about a personal observation in pneumomedia's dynamic COVID that is often associated with poor prognosis, especially in the ICU setting. Does chest tube or picture insertion improve outcome in such patients?
Okay, thank you very much for the question. I think it's a very good observation and questions. Okay, if you notice, pneumomediastinum is an abnormal air or gas in mediastinum per se. So a pneumomediastinum in a patient without increasing requirement of ventilation support, I think we just manage conservatively. But if pneumothorax together with subcutaneous emphysema, pneumomediastinum together with subcutaneous emphysema or pneumomediastinum together with pneumothorax, we need to insert the chest tube or pigtail. But if you notice that there's a role even tension pneumomediastinum, we can insert a mediastinal brain straight away. So again, I would say that each patient we need to analyze individually, and we need to have a CT scan and also clinical judgment before we proceed with any intercostal drainage. That will be my answer for the first question.
And for the second question. Okay, Dr. Arvind, could you share with us your steroid tapering strategy when deciding between 2 weeks versus a prolonged 4 to 6 weeks tapering duration? Do we look at just severity, or do we also consider the highest steroid dose required? That is, if given high dose Dexa, stroke NTP, we should taper slower.
Okay, thank you very much, Dr. Tanis. It's again a good question. Okay, if you notice, the 2 weeks regime usually decided during the acute management of COVID-19. Normally, they give around 10 to maximum 14 days of the steroid regime. But the 4 to 6 weeks of tapering dose is usually given to those who develop organizing pneumonia, especially category 3 onwards, where there's evidence of organizing pneumonia. We should start gradual tapering dose of steroid. Usually, we try to taper down around 4 to 6 weeks. So usually, I'll go through the severity of the organizing pneumonia in patients, and also what's the highest current dose of the steroid. Then we have a steroid conversion chart where we can convert the dose of Dexa to prednisolone or dose of methylprednisolone to Dexa per se. Then from there, we started tapering down slowly. So my idea would be around 4 to 6 weeks, and then we totally wean off from the prednisolone or steroid regime. So usually we can go with a 0.5 mg per kg. But again, if you notice the latest trial, like poster trial, shows that low dose is equally, give the same effect like a high dose steroids. So I haven't started this poster regime in our organizing pneumonia. If you notice, the reason is last year I used to see almost a 5 to 10 organizing pneumonia daily basis. Right now, around maybe 2 or 3 per week. So when the numbers are increasing or what, maybe I may need to consider changing this regime into like low dose regime, because steroid per se can have a multiple adverse outcome in a long-term usage.
All right. Thank you very much, Dr. Arvind. Okay,
thank you very much.
Dr. Nurul, to chair the next plenary. Thank you.
Thank you, Dr. Tanis. Okay, so we have come to plenary 5, The topic today is long COVID rehabilitation and discharge to community. May I introduce our speaker for plenary 5. Dr. Akmal Hafizah Zamli is currently the consultant rehabilitation physician and head of rehabilitation medicine department, Hospital Sungai Buloh, Selangor, Malaysia. She received her MBBS from the University of Malaya in 1998 and later graduated from Masters in Rehabilitation Medicine from her alma mater in 2006. Dr. Akmal held certificates in spinal cord injury and brain injury rehabilitation from Hampstead Rehabilitation Centre, South Australia in 2010. She later qualified as a certified medical impairment assessor of the National Institute of Occupational Safety and Health, Malaysia. In 2011, she served as a clinical fellow in spinal cord medicine and rehabilitation at Burwood Hospital Unit, New Zealand. Since the unprecedented global pandemic, Hospital Sungai Buloh, being the upfront and one of the designated center for COVID-19, resulted in a rapid shift of the profile demand for clinical services, hence her active involvement in providing post-COVID-19 rehabilitation. We are incredibly honored to have Dr. Akmal Hafizah take time off her busy schedule to join us. The floor is yours.
Rahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you for the very kind introduction. I'm very honored to be able to share with you on this topic entitled Long COVID Rehabilitation and Discharge to Community. This will be the highlight of this session and I declare no competing interests. After more than 2 years, the whole globe is fighting COVID-19. I believe this disease requires no further introductions. The magnitude of COVID-19 pandemic is highly tremendous. By now in Malaysia, we have recorded more than 3.6 million cases, beyond 33,000 fatalities, while more than 3.1 million survivors have recovered from COVID-19. However, not all COVID-19 survivors' recovery are the same. Typically, people recover from COVID-19 between 2 to 6 weeks. However, for some, while they survived the fatal outcome, they continue to suffer from cluster of lingering symptoms. Hence, surviving COVID-19 may just be their first battle among many of their long and winding road to recovery. Risk factors for long COVID are not yet well fully understood. However, early studies in the UK has highlighted age, particularly more than 50 years old, sex. While women are less likely to develop severe COVID-19, they are found to be more likely to become long haulers, reporting more than 5 symptoms at the initial acute presentation. Excessive weight as well as underlying asthma are identified to be potential risk factors. UK NICE guideline has published clinical categorization for long COVID that comprises of ongoing symptomatic COVID-19, that is sign and symptoms of COVID-19 between 4 to 12 weeks, and post-COVID-19 syndrome, that is sign and symptoms that develop during or after an infection consistent with COVID-19 that continue for more than 12 weeks and are not able to be explained by any alternative diagnosis. In October 2021, the WHO has come up with a more specific definition of long COVID, termed as post-COVID-19 condition. It occurs in individuals with history of probable or confirmed SARS-CoV infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months. These cannot be explained by any alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others that generally have an impact on everyday functioning. Symptoms may be new onset following initial recovery from an acute COVID-19 episode or persist from the initial illness. Symptoms may also fluctuate or relapse over time. The pathophysiological mechanism of post-COVID-19 condition is still yet defined. WHO, however, has considered at least 7 potential pathophysiological causes, but it is believed to be likely multifactorial in nature. Leading hypotheses are inflammatory or hyperinflammatory state, immune dysregulation or autoimmune, coagulopathy, and vasculopathy. And these lead to multi-organ system involvement in long COVID. Commonest being respiratory system, other systems such as musculoskeletal, cardiovascular, neurological, and others may also be involved. Multi-countries prevalence and primary reported symptoms has reported the lowest prevalence of 32.6% in the American study and highest of 87.4% in Italy study. The spectrum of symptoms are highly variable, commonest being a general sequelae, that is fatigue, respiratory sequelae, dyspnea and cough, and neuropsychiatry sequelae, that is insomnia. It is interesting to note that Huang et al. In his study involving 1,733 COVID-19 survivors reported a prevalence of 76% even after more than 6 months upon initial COVID-19 infections. Looking at the current data and situations, if we are to apply the lowest reported prevalence of 10% of long COVID, our country may now have more than 300,000 individuals at risk of these consequences. Long COVID, if not treated, may lead to serious implications such as morbidity, disability, decreased productivity, loss of work and source of income, hence financial burden, not only to the sufferers, but also to their families, communities, and the overall Malaysian economy. The WHO has highlighted the 3R strategies in long COVID management that comprises of recognition of long COVID, research conducted systematically, and rehabilitation provision. In line with this, the post-COVID-19 management protocol by the Ministry of Health has enabled a barrier-free access for long haulers to seek treatment in more than 2,800 primary care clinics nationwide. And this national protocol had also facilitated the post-COVID-19 condition rehab medicine services, and presently more than 40 facilities in Ministry of Health, Ministry of Education, private facilities, and as well as PGMES are able to provide rehab medicine services for the long haulers. Rehabilitation can be defined as a set of interventions designed to optimize functioning and reduce disability in individuals with health condition in interaction with their environment. Acknowledging the multi-system impact of COVID-19, integration of care between multidisciplinary medical specialties with the interdisciplinary rehabilitation team members are desirable. The core rehabilitation team members comprises, but not limited to, rehab physician, medical officers, physiotherapists, occupational therapists, nurses, speech language therapists, and others such as dietitian, pharmacists, counselors, and medical social workers may also be involved as the need arises. This aim to provide a patient-centered, goal-oriented, holistic, and personalized rehab program for an optimized medical, physical, cognitive, and functionality outcomes for our patients. Rehabilitation goal in COVID-19 are to reduce the impact of COVID-19 not only on their health parameters, but also on their functionality. So we aim to improve the multi-systems dysfunction, empower the patient and their families to understand the impairment, and to educate them with self-management skill to manage their symptoms in their daily life. This aim to maximize their cognitive, physical, and functional capacity, hence their quality of life. Our ultimate target is for full reintegration of long haulers into society. However, if they are inflicted with residual disability, to be able to compensate, adopt, and adapt to their disability. The spectrum of COVID-19 rehabilitation response in Sungai Buloh commenced during the acute rehabilitation phase by our single discipline physiotherapy predominantly. Other interdisciplinary team members are activated on a case-to-case basis. Once the patient has achieved the subacute phase and when they are off-tagged in the medical wards, COVID-19 rehabilitation, inpatient specialized services, or CRIS are being activated. Upon discharge, those with existing rehabilitation needs will be referred to our COVID-19 rehabilitation outpatient specialized services, or known as CROSS. Due to the predominant impact of COVID-19 on the pulmonary system, pulmonary rehabilitation principles and practice are being adopted to deliver rehabilitation program for post-COVID-19 survivors. This is our CRIS rehabilitation framework model that we had adopted in our center. All category 4 and 5 survivors are referred for our interdisciplinary intervention, and any other categories with identified rehabilitation needs. We provide interdisciplinary team evaluations as well as intervention, and we set common goals for an optimized outcome. We use standardized outcome measures and functional tests to ensure a safe prescriptions of our rehabilitation programs. We also facilitated early supported discharge which include the prescription of adaptive and assistive devices for enhanced patients' recovery in the community. Our hallmark respiratory intervention at CRIS includes airway secretion management using mechanical or manual chest percussions. We also provide adjuncts for airway clearance, for example, using oscillating positive expiratory pressure devices. Ventilation capacity are enhanced using diaphragmatic breathing techniques, deep breathing techniques, and using adjuncts such as incentive spirometers. For those who had issue with coughing, steam inhalations are being advocated, and we find menthol crystal steam inhalation as beneficial for our patients. Our hallmark strategies for autonomic dysfunction post-COVID-19 are ensure good hydration, nutritional, especially salt intake, using TED stockings, abdominal binders, and gradual profiling using recliner wheelchair, as well as using table. Our hallmark for pulmonary, cardiovascular, and musculoskeletal intervention increase are using ambulatory gait retraining using oxygen support, and patient will be subjected to 1 minute sit to stand, 2 minutes walking test, or 6-minute walking test according to their aerobic and exercise reserve capacities. We also facilitated equipment, prescriptions, and social support for a safe, supported discharge and transfer of care to the community. This is our long COVID clinical framework model that we had adopted since its inception in November 2020. And we dynamically improve it based on available publications. CROSS has got initial service via teleconsultations, as well as comprehensive in-person review by our multi-interdisciplinary team. We use standardized outcome measures, and our functionality outcomes being adopted are modified Vital Index and post-COVID-19 functional scale. This is our total number of referrals received from January to December 2021, with a total number received of 6,508 patients whom benefited from either teleconsultations or in-person reviews. Teleconsultation are done by our dedicated MO in rotations. We aim to monitor the patient's progress at home and screen for red flags so that medical advice could be given appropriately, and decision for in-person review are made upon teleconsultation. For preliminary teleconsultation database analysis involving a cohort of 2,712 COVID-19 survivors showed that 63.2% suffers from long COVID, ongoing symptomatic COVID-19 that is persistent of symptoms for more than 4 weeks to 12 weeks duration. The commonest being fatigue, exertional dyspnea, cough, insomnia, anxiety, brain fog, and others as depicted in the descending order. During in-person review, we provide knowledge and skill to support patients' rehabilitation self-management in the generic manner. We also teach patients on methods to enhance ventilation capacity that they can adopt in their own settings. Breathing control techniques, position for dyspnea relief are also being taught during this session. During the in-person review, patient will be subjected to comprehensive objective evaluation by the rehab nurses, our physiotherapists, occupational therapists, and finally, these objective evaluations are being concluded by the rehab physicians. Our in-person review database preliminary analysis involving 2,324 COVID-19 survivors showed that 61.1% of our patients still reported persisting symptoms more than 12 weeks from their initial acute symptoms. It is less varied in more than 3 months, commoners still being fatigue, exertional dyspnea, prolonged cough, pain, insomnia, muscle weakness, peripheral neuropathy, anxiety, brain fog, and the rest in descending orders. If we group these symptoms into the various systems, the general sequelae, that is fatigue, are the commonest, and this is followed by respiratory sequelae, commonest being exertional dyspnea and prolonged cough. The commonest are psychological system, whereby anxiety and mood disorders are the most frequently reported. Neurological complications are also common, with insomnia being the most common, loss of taste, brain fog, loss of smell, peripheral neuropathy, headache, hyperhidrosis, and blurring of vision are few of the symptoms being reported. Till now, there's no curative treatment that has been proven for long COVID, as its pathophysiological mechanism is still not defined. As rehab physician, we recognize long COVID symptoms, rule out any red flags or any alternative diagnosis. We may refer long haulers to the specific organ impairment specialties as indicated. We facilitate optimization of medical comorbidities in consultation and referral to our medical and ID colleagues. We provide symptomatic treatment and support the long haulers for rehabilitation self-management. Due to the potential benefits of exercise on the most frequent clinical manifestation of long COVID, exercise is the mainstay of rehabilitation prescriptions for our patients. However, caution has to be made, for some patients may be inflicted with post-exertional malaise, whereby exacerbation of their fatigue may happen following physical or exercise and activities. For this type of patients, energy conservation is the mainstay of rehab interventions. Intensity prescriptions in exercise need to be guided by their cardiorespiratory objective evaluation. And we guide our intensity prescriptions using the modified box scale according to the phase of recovery of our patients. It is also important to look into the element of autonomic dysfunction with exercise prescription. Measures that has been mentioned prior may be employed even at the outpatient setting for some patients. And at cross, common manifestation of dysautonomia are postural orthostatic tachycardia syndrome, less so with orthostatic hypotension. Common long COVID symptoms are often interrelated and confounding between each other. For example, increment in fatigue perception may lead to worsening brain fog, and this will cause an increase in the stress level, which may lead to bodily aches and pain, resulting in more anxiety and worsen their insomnia, and insomnia further worsen their fatigue. And this intercorrelation are vice versa, whereby improvement, for example, in insomnia will lead to improvement in fatigue, brain fog, and the domino effect with the rest of other symptoms. So in the rehab setting, when our patient present with a cluster of symptoms, we will identify the most predominant symptoms and target the most practical intervention with the hope for anticipation of domino effect with the rest of their cluster of symptoms. And we also integrate our pharmacological approach with that of non-pharmacological approach by our interdisciplinary team members. For example, in management of fatigue, be it physical fatigue or mental fatigue, upon occupational therapy strategies for rehabilitation intervention, we also may prescribe analgesics or nociceptive pain medications in the confounding or concurrent evidence of nociceptive or neuropathic pain conditions. And if there is any element of depressive symptoms with consultations of the psychiatrist, patients may be prescribed with antidepressive medications. For symptoms such as exertional dyspnea, apart from pulmonary rehabilitation strategies adopted by the interdisciplinary team members, patients may also be prescribed with supplemental oxygen therapy based on our objective evaluations. In the evidence of bronchial hyperresponsiveness, inhaler medications may be prescribed with consultation with our medical colleagues. And respiratory physicians may be referred in the evidence of pulmonary fibrosis consequences, and patient may be considered for antifibrotic agent in the evidence of progressive fibrosing lung diseases. For cough, non-pharmacological interventions for dry cough and productive cough are being employed, and pharmacologically for dry cough, suppressants may also be prescribed. As mentioned earlier, we find menthol crystal steam inhalation are beneficial for our patients, and for those whom we suspect sensory neural cough, prescription of neuropathic medication may be both diagnostic and therapeutic for our patients. For productive cough, mucolytics, for example, solvent or N-acetylcysteine may be indicated. We also prescribe expectorant depending on our evaluation. Improve further on return to work programs for long haulers. We collaborated with Pusat Rehabilitasi Perkeso Tun Abdul Razak and its satellite branches that is most visible to our patients. The aim for provision of more intensive and holistic program to enable return to work of these patients. These are educational material that has been established with collaboration with WHO and is now readily available for free download or utilization of our patients. And these are also educational videos established in Bahasa Malaysia via collaboration with WHO, and it is also readily available for download at the WHO website with the link given. And these are also the primary document that can be used up to provide support for rehabilitation self-management. And inshallah, this e-booklet is already in final stage for utilization for long COVID and long haulers in our population. And these are the reference for this presentation. With this last slide, thank you very much for your kind attention. Thank you.
First of all, I would like to thank and also congratulate the PGMES of Hospital Bahiyah for this 12th biennial scientific meeting and inviting me to participate in this regular update, medical update in Hospital Al-Usta and also for the northern part of Malaysia. So I'm given task to talk and discuss about primary prevention of coronary syndrome. Tak jalan. Tak jalan siapa? Ha?
Kita kena mulai.
Tak boleh dia tak jalan. Tak. Okey, boleh. Ni jalan. Tadi tak jalan. Ni jalan. Boleh. Boleh. Sekejap, kalau saya tekan ni tekan apa? Tak, kalau tekan ni. Oh, kalau ini klik saja kan? Ni yang pegang ini lah. Saya pegang ni. Tapi nampak tangan pula kan? Boleh kan tak? Tak nampak, okey. Posisi nampak. Kalau saya buat di sini, baik tekan di sini, no? Tekan kat laptop.
Jalan nak pakai laptop.
Jalan.
Tekan laptop.
Tekan laptop. Okay. Assalamualaikum. Good morning. Selamat pagi. First of all, I would like to congratulate the organizing committee for 12th PGMES Biennial Scientific Meeting at Bahiyah and also thanks for inviting me to participate in this important update for medical fraternity in the northern part of Malaysia. I was given task to discuss about how to prevent coronary syndromes. Because of a bit time limitation, I'm discuss mainly the primary prevention of coronary syndrome. So as we know, this coronary atherosclerosis started at the adolescent age, and then probably by age of 30 or 40s, there will be progressive atherosclerosis, and then usually around age of 50s or 60s, then patient will have symptomatic coronary artery disease. So we now have the option whether we want to let the coronary atherosclerosis progress, or do we want to prevent it primarily before it happens, or we have to wait until it occurs and going for secondary prevention. I think it definitely will be good if we can prevent it from happening at all. But the problem is us in Malaysia, we were caught unprepared. I think a lot of us, I think you can hear many of us, even before their retirement age, they end up with acute coronary syndrome. I think it lies because we did not prepare to prevent this disease from happening. So the question is, we have to ask and answer now. How common are the CV risk factors in Malaysia? And how cost effective is the CVD prevention? And what are the type of CVD1 that we should target for prevention, the risk factors, and then is there any new things that we know that beyond traditional risk factors which may accelerate the disease? And next, we have to assess what is the severe risk for each of us. Basically, for this discussion today, I'm discussing only mainly primary prevention. Hopefully, probably in the next symposium, we can discuss further about secondary prevention. And then what steps should be taken to prevent cardiovascular risk at individual level, community, population, as well as government level. So when you talk about prevention of cardiovascular disease, basically for primary prevention, we are talking about how to address this at the healthy general population. That means they are not having any disease yet. And two, more important, is for those individuals who have multiple or high level of single cardiovascular risk factors. And then last but not least, individuals who are at risk of cardiovascular events but haven't got the disease yet. Just to remind ourselves, coronary cardiovascular disease include coronary heart disease, cerebral vascular accident, as well as peripheral arterial disease. And then for the coronary heart disease, it can be patient with asymptomatic and who have silent ischemia, or maybe on imaging have significant plaque. But for this purpose of update, I will focus mainly on prevention of coronary heart disease. So the latest National Health and Morbidity Survey 2019 have further enlighten us about how bad is the CV risk factors in Malaysia. Basically, the common problem of diabetes, hypertension, and hypercholesterolemia, not only high prevalence, but they are increasing significantly. And at each time of NHMS survey, we can see dramatic increase in the numbers of each. For example, diabetes prevalent, which was 11% in 2011, and then on the survey in 2015 was 13%, and now this is almost 20%, like 1/5 of us are diabetic. Hypertension, alhamdulillah, they are plateau at 1/3 of the population, about 30%. From 2011, 32%, 2015, about the same, 30%, and now also about 30%. And there is also little bit improvement in terms of adult with hypercholesterolemia, with the previous prevalence of 35%, and then 2015 was 47%, and now little bit improved of 38%. So basically, the prevalence of common cardiovascular factors in Malaysia are very high. So these are the exact numbers for each factors just now, for the three main factors. So the three so-called triplet together, which are the so-called, we can see a rising incidence of diabetes, hypertension, and hyperlipidemia. And then on top of that, we have also rising prevalence of unhealthy lifestyle, namely physical inactivity, about 35% in 2011, a little bit improved now to 25%. And there's a bit plateau of current smokers trending in Malaysia from 20% to 21% now. But the thing that is not improving is the dietary habit in Malaysia is still not very good, because more than 90% of us are not taking enough fruits and vegetables, and also some quite high incidence of beach drinkers among population. And then we know that obesity, we are top in Southeast Asia. We are #1 in terms of prevalence of obesity, which is another worrying trend, as they are also another CV risk factors. So this is being seen. I'm a bit sorry because the numbers is a bit small, but suffice to say, the numbers of patients admitted for coronary artery disease is rising. Actually, the slide in the right hand side of the slide, actually the old data of 2008, and then in the left hand side is 2018. So the numbers of patients admitted to coronary disease rises from 32,000 in the whole KKM hospital to almost double of 70,000-80,000 in the years of 2018. So, and then this is another annual report of NCBT ACS registry, which was done by major public hospital and also cardiology department in MOH hospital and UMMC and also IJN. It shows the same figures of CV risk factors are very, very high in patients admitted for ACS. For example, for dyslipidemia, almost 30 to 40% of patients are abnormal. And then hypertension, more than 2/3 of the patients are hypertensive, between 60 to 65%. And for diabetes, almost 50%, and between 43 to 46% of patients admitted to ACS are having these multiple CV risk factors. And you can see the lower part of these figures, but 1/3 almost 36% of the patients are obese, and also more than 1/3 of the patients are smokers. So basically, most of our patients have multiple CV risk factors. And then the worrying thing is the age of admission here. This patient admitted at the age of young 50 years old. You can see that at 50, even at the late 30s, our patients are admitted for this life-threatening STEMI, non-STEMI, and unstable angina. As compared to the Western registries, usually the patient are at the age of 60 and above, they mean post-retirement age. Same thing for those patients who are admitted for angioplasty, and the same figures were seen with multiple risk factors, young age, and then a lot of them have more than 3 risk factors. And you can see there both male and female here, patient admitted for angioplasty, following either stable or unstable angina. Between 30 to 35% of them more than 3 risk factors. So based on that, our MOH, as well as in collaboration with Academy of Medicine and also National Heart Association, has come up with assessment of atherosclerotic cardiovascular disease risk factor, which were adapted from both the European Society of Cardiology as well as American Heart Association, in which we advocate to do screening at earlier age for this patient, maybe as early as late 20s. We have to screen them because our disease definitely start earlier. So we can't be like waiting until at the age of 50s, because by then most of the patients already symptomatic or admitted for acute coronary syndrome. So on top of that, based on few other registry meta-analysis of trials, guidelines now have come up with another things that we have to look into, which is the so-called atherosclerotic cardiovascular risk enhancers. You can see at the left side of the slide there, family history of premature CAD, hyperlipidemia, CKD, metabolic syndrome, history of pre-eclampsia, patient with inflammatory disease, rheumatoid arthritis, or psoriasis, and then in particular in our population, South Asian in ancestry. Even in our NCBD, ACS, as well as PCR registry, we noted Malay and Indian predominant in the data. So based on this, we categorize the patient between low risk, borderline risk, intermediate, and high risk, and which will be assessed by using the LDL level as well as other comorbidities such as diabetes, hypertension, smoking, etc. So if the risk is uncertain, then we can add on another few other factors, which we will discuss after this. So the recommendation, so the most important way is to prevent atherosclerotic vascular disease is to promote a healthy lifestyle throughout the life, even before patients succumb to coronary disease. And we must approach by a team-based care, which include physicians, diabetologists, dietitians, maybe physiotherapists, and then all pharmacologists, so that will be more effective to prevent this from happening. So we need to screen the patient, must be opportunistic rather than mass screening. And each time when we see the patient, we have to use Framingham risk score, try to estimate what are the patient general CVD risk score. And then at the age of 20 and onward until age of 40, we must assess this risk factor, at least for those who are still asymptomatic, and between 4 to 5 years. And then at the age of 40 onward must be checked annually at least And then for each time we see the patient, we must calculate the 10-year risk of atherosclerotic cardiovascular disease, which we can refer to this table. You can see this is table for the man, and then this is the risk for each factor when you accumulate at the point, which is the age factor, HDL level, total cholesterol, blood pressure, either smokers or non-smokers, or diabetes. And then you total up, then you can get what is the 10 years risk for each of us. For example, I just calculate myself. This is for the woman, that is for the man. Actually, somehow the one that I calculate for myself somehow was I got about 21%, which is here. 21%. This is thing we have the disadvantage of when you are already above 60, your point become very, very high. And even the age point itself is more than 10. So when you add up with your blood pressure, your status of either smoking, non-smoking, and cholesterol level, so mine, I got 21% of 10-year risk, which is quite worrying. So what do we do with that? So if we do that, we should first, as we discussed earlier, must practice healthy lifestyle, and namely the exercise, the diet. I think we know what diet to be avoided and what diet to be taken. So basically, that actually the new guideline is actually based on the few meta-analysis from recent studies. Maybe you all have heard about this Interheart study, which almost recruit the whole continent everywhere. I think it includes, quite a number of patients from Asian origin also included. And finally, these are the 9 potentially modifiable risk factors which you can so-called address to prevent coronary syndrome, mainly smoking, hypertension, the lipid level, abdominal obesity, diabetes, fruit and vegetable intake, alcohol intake, physical activity, and then psychosocial problem. And then recently, also by the same author, the same principal investigator, if you remember the first picture of my slide, I show the picture of Professor Salim Yusuf, who was the principal investigator for Interheart study, as well as POP3 study. POP3 study also involved Malaysian, in which a patient without non-cardiovascular disease but intermediate risk factors, maybe BP of borderline around 130 to 85, cholesterol is mildly elevated. So it has been shown from this POP3, even though it takes a bit longer time, I think by almost 9 years to see the difference, definitely it was shown that fixed dose treatment with low dose statin therapy will reduce long-term cardiovascular effect. Because the patient selected most of the time have as a pre-hypertensive stage, probably the effect of antihypertensive not well seen in the POP3, but reducing cholesterol definitely reduce the cardiovascular event.
Well, thank you, Dr. Omar Ismail, for the kind presentation for our first topic for our symposium. And let me introduce you our second speaker for today, who is newly appointed Dato. So we are glad to have you, and congratulations from the PGMES Society to you, Dr. Asri. Dr. Asri Rangga graduated from University Kebangsaan Malaysia in 1996 and obtained his Master in Internal Medicine from the same university in 2003. He has been involved in multiple research works and publications, as well as a distinguished speaker in interventional cardiology, be it in the national level and also international level. He currently works as a senior consultant cardiologist in Sedang Hospital, as well as visiting consultant cardiologist in Sunway Velocity Medical Center, various Columbia Asia hospitals, and Pantai Hospital Ampang. So delivering the talk today about smoking and coronary atherosclerosis. So the stage is yours, Dr. Asri.
Good morning, Salam.
Over to you.
Thank you, Shuko. I'll share my screen now. I hope you all can see my screen. Okay, smoking and atherosclerosis, and it's an honor to be given the task to speak at this important meeting. I'm Dr. Asiranga from Sedang Hospital, and the title today is Smoking and Atherosclerosis. It's always a tough bet to speak after Dr. Omar. And if you look at smoking, how was smoking viewed in the past? So if you look at this, it's so glamorous, and doctors were actually roped in. Believe it or not, in the 50s, 60s, physicians were actually promoting smoking, and it was seen as a macho thing, something very sexy, something of, something high up in the high society. So this is how smoking was viewed in the past, unfortunately. And only in the 1960s, there were signals saying that, smoking can cause problems. So one of it was cancer of the lung, but the other one was cardiac disease. And this is way back in 1968, talking about angina and so on. So not until recently, only in 1993, this was the landmark trial that actually proved correlation with smoking and ischemic heart disease, the Framingham study, which followed up patients over 34 years, looking at more than 5,000 individuals. The connection to lung cancer and so on was done much earlier, but really atherosclerosis took time. And if you look at our own data, like what Dr. Omar presented just now, this is the National Cardiovascular Disease Database Registry looking at ACS. And if you see, 1/3 of the patients are smokers, okay? So you're talking about something from 33 to 37% of the Malaysian population who have acute coronary syndrome have smokers, and a lot of them have actually 3 risk factors. So there's this thing called non-linear dose effect of smoking on cardiovascular function, and recent large epidemiological studies have shown a trend for more CVS events in heavier active smokers, but it doesn't mean that you need to smoke a lot of cigarettes. And this is an interesting paper from Norway, looking at almost 40,000 plus patient population, not only patients, men and women, over a period of almost more than 30 years. And what they found was interesting. You smoke 1 to 4 cigarettes per day, or you smoke more than 25 cigarettes per day, the risk of you dying from ischemic heart disease is the same. So basically, it does not tell you like a dose effect, unlike the others. So there's no dose effect, there's no safe dose when it comes to the number of cigarettes you smoke. And then we have this thing about secondhand smoking. So secondhand smoking also affects your heart and increases the risk of coronary heart disease by 30%. This is a report in 2005. And if you look at all these studies, the odds ratio, even with secondhand smoking, sometimes secondhand smoking can be worse than the initial smoking because you're taking unfiltered smoke. And it actually affects the platelet activation, endothelial dysfunction, inflammation and infection, oxidative stress. I will actually go a bit more detail after this. So let's go into details of how smoking causes atherosclerosis. So almost 1 billion people in this world smoke, 20% of the world population, and cigarette smoke contains over 7,000 known components. And I will talk about nicotine after this, but carbon monoxide is one such component which has actually atherothrombotic effects. And although nicotine plays a major role in smoking-related increase in cardiac output, heart rate, but it's to tie to actual atherosclerotic disease is still somewhat controversial. So this is basically pathophysiology in a nutshell. This is a cross-section of your artery. And in your artery, the most important cell is your endothelial cell layer here. And what smoking does, it actually increases activation of the platelets, increases activation of leukocytes, causing release of pro-inflammatory cytokines and tumor necrosis factor. A lot of chemicals are being released, and all these actually promote thrombus formation here. As per, it actually follows all these other pathways to promote thrombus formation. It also directly affects the endothelial cell, decreases the nitrous oxide production in these cells, reduces the progenitor cells, and it actually can cause direct endothelial cell death by affecting the integrity of the cell membrane, microtubules, and so on. And apart from that, it accelerates atherosclerosis. It actually releases matrix metalloproteinase activation, which actually thins out this atheroma cap and making it more prone to rupture. It increases hemorrhage, inflammation, and all this is bad news for the patient with heart disease. So you have side stream stroke, smoke, and mainstream smoke. 92% of the product from the cigarette is actually gaseous, 8% is tar related, and so on. So when you look at the physiology, there's vasomotor dysfunction, there's inflammation, there's modification of lipids at a very early stage, even before the atheroma forms. When you talk about vasomotor dysfunction, both in animal and humans, cigarette smoking, either active or passive exposure to cigarette smoke is associated with decrease in vasodilatory function. So they cannot vasodilate, especially in the presence of stenosis. And even cigarette smoke, extract CAC, and so on, has been shown to decrease nitrous oxide, another important factor for vasodilatation. So nitrous oxide not only is a vasoregulatory molecule, it also helps reduce platelet activation, formation of thrombus, and so on. And then you have inflammation. So cigarette smoke increases levels of interleukin-6, tumor necrosis factor alpha. It causes activation of the leukocytes, and this actually can promote atheroma formation. And then there's modification of lipids. You know, LDL-C is very important. So smoking increases the oxidative modification of LDL. So the circulating products of lipid peroxidation is increased. The LDL receptors per se actually are decreased. And the other thing is, it modifies the LDL-C as per this study in 1988, and it actually turns the macrophages to foam cells. Foam cells are the precursors for atherosclerosis. And all these causes platelet dysfunction, and platelets in smokers are actually abnormal. And after exposure to smokers, serum platelets actually are more prone to congregation and forming thrombosis. And cigarette smoking decreases also nitrous oxide on the platelets, not only in the endothelial cells. There's also alteration of antithrombotic and prothrombotic factors, like I've shown. Fibrinogen levels are higher, so this correlates with increased thrombus formation. And there's alteration in tissue factor pathway and so on. There's also alteration in fibrinolysis. So there have been in vitro studies in the human umbilical vein, which actually shows that there's decreased certain proteins, which actually promotes thrombosis and less autofibrinolysis by the cells and so on. There's this thing called genetic predispositions. Very interesting to note that there are certain individuals who are more prone to smoking, especially those with polymorphisms of chromosome 15. Chromosome 15 is actually important because it is where the nicotine gene is based. So some people with this polymorphism tends to smoke more. And there's also inter-subject variability in how the atherosclerotic process plays off. There's other factors like epigenetic factors. For your information, cigarette smoke exposure is one of the strongest forces which actually causes deformity of DNA. So this thing called DNA methylation, hypomethylation, can predispose the patients to increase thrombosis. And there's recent data that also indicates some good news. When you reduce smoking or stop smoking, not reduce, when you stop smoking, smoking cessation, actually you can reverse some of the effects. There's a study published in 2003 which showed that smoking ban in a city in US actually reduced acute MI by 60% over a period of 6 months. So the pro-thrombotic effects of exposure to cigarette smoke can actually be reversed to some effect. But if you look at this, it depends on the atherosclerotic sites. So across the board, when you have peripheral artery disease, coronary artery disease, stroke, smoking actually increases the risk of major adverse events. But if you were to stop smoking, If you look here, current smokers, slowly the risk actually comes down, but it takes a long time, almost 20 to 30 years before you come back to the normal population. And in certain instances like peripheral artery disease, it takes even longer to regress back. So it's not an immediate effect once you stop smoking. And I want to talk a bit about electronic cigarettes. I think a lot of people who think they're quitting smoking are taking electronic cigarettes. So like EC actually has been popularized in the last 10-15 years. It consists of 4 components. You have a large battery, a microchip, a canister inside, which actually contains the nicotine like gel-like material, and an atomizer which heats up. Okay, and along the way, this is third generation EC. The third generation are not so good because previously the nicotine component was actually much smaller. Now the cartridge are much bigger. So nicotine causes increase in catecholamine release, increases diastolic BP, blood pressure. But so far, we don't see, according to the current data, there's no effect on coronary flow reserve, echo parameters, so diastolic dysfunction as far as electronic cigarettes are concerned. Early studies showed no apparent effect on atherosclerosis, but those studies were done on the earlier cigarettes which actually deliver less nicotine. So more research is still needed in this aspect. I'd just like to tell the audience about what we call the smoker's paradox. This is a paper in China looking at 20,000 smokers who underwent, and ex-smokers who underwent PCI or coronary intervention. And what it shows here, repeat revascularization and even adjusted mortality seems much less on those who are actually smoking. If you can see, non-smokers is higher. So this is what is called smoker's paradox, and many studies have repeated this. This is another study which showed the same thing post-PCI. Smokers seems to be having a positive effect, but actually this is what they call a smoker's paradox, because they said the smokers tend to be the younger patients, so they look like in the short term the mortality is and the results are better, but the long term is actually deleterious. And also those who are smoking, most of the time the plug which ruptures in a usually the whole artery is not so diseased. So there's one plug which ruptures. So it's unlike patients who are having diabetes and so on. But in the long term, it is still deleterious to their health. And this is what they call smoker's paradox. And in conclusion, epidemiologic studies have established that cigarette smoke exposure is an important cause of cardiovascular morbidity and mortality. And secondhand smoking is equally bad, as I've shown you. Clinical and experimental studies indicate that either active or passive exposure promotes vasomotor dysfunction, arteriogenesis, and thrombosis in multiple vascular beds. Smoking cessation can partially reverse the risk of exposure, but over time. And data on electronic cigarettes or EC or atherosclerosis is still controversial. Thank you. That's my lecture. Thanks.
Thank you, Dr. Asri, for your very kind and very comprehensive lecture. And let's move on to the third speaker for this symposium. Let me introduce to you Dr. Sa'ari Muhammad Yatim, who is the head of the Medical Rehabilitation Department, Hospital Serdang. He is the head of Rehabilitation Medical Services of Selangor State and deputy head of the Rehabilitation Medical Services, Ministry of Health, Malaysia. He received his MD from University of Science Malaysia in 1998 and later graduated Masters in Rehabilitation Medicine from University of Malaya in 2006. He completed his subspecialty training in cardiopulmonary rehabilitation in Hong Kong in 2010 and special training in pulmonary rehab in, I hope I pronounce it right, Chonbuk National University, Korea in 2016. Apart from that, Dr. Sa'ari is also a certified medical impairment assessor under NIOSH. So presenting to you coronary syndromes, cardiac rehabilitation post-ACS. The floor is yours, Dr. Sa'ari.
Assalamualaikum and hello everyone. So now I'm going to discuss about cardiac rehabilitation in post-coronary syndromes. I'm Dr. Sa'ari Muhammad Yatim, rehabilitation from Hospital Serdang. So I hope the learning point for these presentations includes evidence-based cardiac rehab, current model structures, and process in cardiac rehabilitation, indication, time of first visit, risk stratification, safety, goal setting for the cardiac rehab. By definition, cardiac rehab is a sum of activities required to ensure patient the best possible physical, mental, and social conditions so that they may resume and maintain as normal a place as possible in the community. So, cardiac rehab is increasingly recognized as integral component of continuum of care for the patient with cardiovascular disease. Even in under MSQH is a part of the quality management that need to be include cardiac rehab in any cardiac disease patient that needed. So the first systematic review and meta-analysis of exercise-based cardiac rehab by Ulrich and colleague and O'Connor and colleague were published 30 years ago, showing a 20% to 25% reduction in all cause and cardiovascular mortality on the basis of the data from 22 RCTs in over 4,300 patients. And numerous of previous studies and meta-analysis have demonstrated the positive effect of cardiac rehab and exercise training reflected in reduction of mortality and increased functional capacity of the coronary artery disease patients. For the first time, this systemic review and meta-analysis from 2011 showed reduction in mobility and future recovery, a future coronary event in addition to a reduced mortality of the coronary artery disease patient. And the latest update Cochrane review of exercise-based cardiac rehabilitation for coronary heart disease reported an absolute risk reduction in cardiovascular mortality from 10.4% to 7.6% for patients after MI and revascularization who receive cardiac rehab compared with those who did not. So what are the benefits of cardiac rehab? These include improved cardiac endurance, increased ischemic threshold, improved left ventricular functions, open up collateral vessel in the heart, in the myocardiums, reduce mortality about 25%, coronary risk factors modifications, ameliorate serum lipid, decrease serums, catecholamine, and decrease platelet aggregation, as well as improve quality of life and psychological status of the patient. Before we start on the cardiac rehab programs, there are some essential knowledge that we need to understand. Cardiovascular physiology, exercise physiology, as well as drug therapy modulation in hemodynamics. This is need to be well understood. Some basic physiology, as we know, autonomic nervous system is the most powerful regulatory mechanism of cardiovascular system. High sympathetic activities and low vagal activity are both independent predictors of mortality. So vagal activity will reduce the heart rate and sympathetic activity will increase the heart rate. Therefore, vagal activity basically protects the heart and sympathetic activities increase the risk of arrhythmia in the heart. So cardiac rehabilitation programs consist of rehabilitation training as well as primary and secondary prevention, which include education and risk factor modifications. There are many guidelines that I can refer to on any statement, and as well as a statement that have been mentioned in the internet. Okay, you can have American Heart Association's statement, American College of Cardiology statements, AACPPR guideline of cardiac rehabilitation as well as pulmonary rehabilitation, American College of Sport Medicine, European Guideline, NICE, as well as BACR, British Association of Cardiac Rehabilitation, as well as a cardiac rehabilitation framework from University of York. So the indication for cardiac rehab basically for acute myocardial infarction patients, post coronary artery bypass grafting, open heart surgery, stable angina flectoris, heart valve repair or replacement, post interventions, especially post PCI, with or without stenting, heart or heart lung transplant, as well as in heart failure patients. So traditionally, cardiac rehab can be divided into three phases. Phase 1 or inpatient phase that been introduced in 1960s with the aim at the early graded mobilization. Or phase 2 is outpatient that consists of outpatient monitored exercise and risk factor reduction. It's a multidimensional approach gained popularity in 1970 and is well structured in 1980s. And for phase 3 is a maintenance phase. Actually, is a self-maintenance for the patient, consists of home or gym-based exercises containing the risk factor modification. For inpatient, phase 1, the objective is actually to prevent prolonged bed rest, to hasten adjustment to the hospital environment, to begin risk stratification, to begin identification and modification of risk factor, to facilitate return to activities, to provide medical surveillance, and to maintain neuromuscular rehabilitation. And the program consists of progressive accumulation, low-level exercise, low level of exercise, that means it's at a flat level, usually at the bedside as well as in the ward itself at the flat level. You don't give any resistance for this type of exercise while the patient in the ward. Patient and family education, initial vocational and psychosocial assessment, and pre-discharge treatment or an echogram if possible. And this is a phase 1 cardiac rehab. Look at the original Wenger program that have been introduced previously. It's about 14 days. Previously, that if we can see that patients, most of the patients basically, maybe some of you may experience that the word of CRIB, complete rest in bed, that most of the patients with heart disease usually admitted and usually discharged after 14 days, after 2 weeks. Okay, the Wenger program actually is an old program. You can see it's 14 days, but now it's a modern program that can just up to 3 days. By day 2, basically, patient is already walking up to 3 meters. This is a division 3 for cardiac rehab. I mean, when patient have been referred to cardiac rehabilitation program, we do the clinical assessment. Whether it's clinical assessment, the patient can be included in exercise training as well as the education for risk modification. And for the exercise training, we can see whether the patient, we have to look into, okay, certify the patient have any contraindication for exercise training or not. If patient have contraindication for exercise training, for example, uncontrolled heart failure, or still uncontrolled pulmonary hypertension, for example, so we need to reevaluate for the exercise training later date. And then for those who have no contraindication for exercise training, so whether we can do graded exercise tests, I mean the stress test, to guide us in terms of exercise prescription for this patient. If yes, it's good. If no, that means if we don't have any facility, and most of us have difficulty to do the graded exercise test, we can go for low intensity ECG monitoring first, and then later we can go up to the moderate intensity exercise in terms of the prescription. And then for those who have exercise tests, basically we can recertify the patient to low risk, moderate risk to high risk. And then for those who have moderate risk and high risk group, we can start with a low to moderate intensity exercise, ECG monitoring, and as well as for those who have low risk, basically you can prescribe exercise to moderate to high intensity with ECG monitoring at beginning. So for phase 2, the objective is really to instruct proper exercise procedure, to restore a desirable exercise capacity, to provide understanding for both patient and family, to continue risk factor modification, to meet psychosocial need, to provide surveillance, to assist graded return to work and vocational activities. So the program consists of educational sessions, supervised exercise conditioning, individual or group counseling, rehabilitation class and stress management, work assessment, and work hardening. So this is a component of secondary prevention. As we did mention about the cardiac rehab, it consists of the secondary prevention component that must be monitored. This is a part of the outcome in terms of a in terms of lifestyle, as well as in terms of the what are other risk factors of this patient. Then cigarette smoking, blood pressure, lipid management, physical activity, weight management, diabetes, antiplatelet, and in terms of drugs, whether the patient still, have been prescribed with this medication or not. So this is some data about approximate mortality reduction potential to lifestyle change. As compared to the medication, you can see the lifestyle modification itself actually is reduce the mortality risk. Reduce the mortality risk. For example, like combined actually change can reduce up to 45%, and smoking cessation about 35%, and in terms of physical activity about 25%. So regular exercise training also contribute to a significant reduction in late luminal loss in a stented coronary segment in acute myocardial infarction patients. And then when you want to start a cardiac rehab program, you have to know the patient risk during cardiac rehab. There are two main risks during the cardiac rehabilitation program, which include ischemic risk or arrhythmic risk. So these are listed of ischemic risk, and for those who have post-operative angina, left ventricular ejection fraction less than 55, NYHA 3 and 4, patient who have experience of VT and VF, with systolic blood pressure high with 10 points during the exercise, rising up of the systolic blood pressure, ventricular ectopy, as well as myocardial ischemia during exercise testing. And for those who have arrhythmic risk, those who have acute infarction during 6 weeks, acute ischemia during exercise, ejection fraction less than 30, and history of sustained VT, history of sustained supraventricular arrhythmia, initial therapy with ICD, and initial therapy with a cardiac pacemaker. This is a guideline to re-stratify the patient in terms of low risk, moderate risk, and high risk. This is a guide for the clinician, that include the coordinators and the therapists, the doctors, to classify the patient in the low risk, moderate risk, or high risk. So why we need this guideline basically is in terms of monitoring of the patient. If patient have moderate risk and high risk, we need to closely monitor the patient. But for those who are high risk, actually, we can train the patient to be independently doing their exercise in our center or at home. Talking about safety of CR, supervised exercise rehabilitation is associated with a small risk of adverse event. In 2007, American Heart Association's statement said that the risk of any major cardiovascular complication, I mean cardiac arrest, death, and MI, is 1 in 60,000 to 80,000 hours of supervised exercise. So it's very low actually in terms of any incidents happen during the cardiac rehab with a proper assessment and evaluation. Just a bit of clinical data with regard to the type of strengthening exercise. Here I put here actually is two types of strengthening exercise, whether it's isotonic exercise and dynamic exercise. I mean there is a joint movement of exercise, and then another one is an isometric exercise in which there is no joint movement. Okay, I mean the strengthening exercise we do without any joint movement. So you can see the difference in terms of the isotonic, in terms of the cardiac output, heart rate, slope volume, TPR, total peripheral resistance, as well as the blood pressure. You can see that the isometric exercise will increase in terms of total peripheral resistance, and also will increase in the blood pressure. So this is actually a contraindicated for those who have uncontrolled hypertension as well as those with heart failure, because this will increase the left ventricular work in the moment. You can see the pressure load will be increased. We need to understand also some drug modulation in exercise hemodynamic and tolerance. You can see that beta blockers will reduce the heart rate and decrease the blood pressure. And in terms of exercise capacity, they will increase in patients with angina. That means good. Most patients with angina should be prescribed with beta blocker. It will increase the exercise capacity. Same thing with nitrate, we increase exercise capacity, calcium channel blocker. But for diuretic and ACE, basically there is no change in terms of the exercise capacity. So most of cardiac patients have been prescribed with a beta blocker. So exercise prescription using percentage of heart rate maximum. Usually most of the time that we use 220 minus H to get the heart rate maximum without any stress test. So actually this method have limited accuracy for the patient, those who are taking beta blockers. Okay, and then the covenant formula that underestimate the heart rate at the anaerobic threshold in beta blockage patients. Therefore, we have to be very cautiously prescribed patient for those who have a poor heart rate response. For those who have on beta blockers with poor heart rate response, we have cautiously prescribed, and I will guide in terms of what type of exercise that's suitable for them. So exercise is medicine. We need to prescribe exercise. Proper exercise prescriptions, okay, can make the patient safe during the exercise. So exercise prescriptions include in terms of frequency, intensity, type, time. Okay, and then we add enjoyment. Need to be enjoyment to make a patient sustain in terms of the exercise that actually to change their lifestyle. So based on the circulations and the exercise prescription and primary preventions of cardiovascular disease, you can see this is this recommended exercise routine. Okay, in addition to activity of daily living for cardiovascular patient. So in terms of aerobic, okay, then suggested exercise is a walking exercise, stairs climbing, and using the electrical machines. But this walking actually is one of the best exercise for these patients with target of moderate intensity, 5 days per week, and it's total length about 30 minutes. And then other aerobic exercise, running, a single tennis, swimming, at least 3 times per week. This is a high intensity. I mean, this is a vigorous activity, but we have to prescribe cautiously for this patient. So most of the patient basically we prescribe low intensity to moderate intensity at beginning, and then later when the patient have confidence, they will increase and progress to the high intensity training for 20 minutes. And then another exercise is resistance trainings. This include the upper limbs as well as the lower limb exercise that should be done twice per week. So usually it's a moderate intensity exercise with 8 to 12 repetitions per set and twice a week. So this is correlation with exercise training level that sometimes we have difficulty, especially in beta blockers patient, that we have a problem in terms of prescribing exercise, because when we do 6-minute walk test for this patient, sometimes the heart rate is never increased. So sometimes it's the same. Okay, that's why this is a very good correlations that we can utilize, can use in our clinical practice. It's very simple and low cost. So we can do, for example, like low intensity exercise. We can prescribe increment over resting heart rate. For example, resting heart rate plus 10 to 25. That is a low intensity. For moderate intensity is a resting heart rate plus 20 to 35. This is 20 to 35 is exercise heart rate zone. For example, okay, resting heart rate patient of 80. Okay, so resting plus 20, that means is a 100. I mean the exercise heart rate zone of the patient is 100 to 115. So that is a exercise heart rate zone. So the patient should achieve within that limit.
Well, thank you, Dr. Sari, for the excellent talk. And due to the time factor, I think we have to adjourn the session, end the session for now. And we will actually answer your Q&A questions to emails and chat groups. So please do send yours. So I shall pass the stage to the next chairman, Dr. Joyce Tan, for the next agenda. Thank Thank you very much.
Thank you very much, Dr. Shuko. It's me again. I'm Joesh, physician, and I'll be chairing the next session, which is the Tea Symposium, which is very kindly sponsored and provided by Abbott Laboratories. On the topic of optimization of glycemic control to slow diabetic retinopathy, ? Good enough. Today, we are very pleased and we are very honored to have with us a consultant endocrinologist in Hospital Sultanah Bahiyah, Dr. Noor Rafati Adyani Abdullah. Dr. Rafati is no stranger to the world of endocrinology, herself a graduate from the University of Newcastle upon time. She was admitted as a member in the Royal College of Physicians. She went on to subspecialize and complete her fellowship training in the field of endocrinology from famed centers like Putrajaya Hospital, University Kebangsaan, and the fabled Christine NHS Foundation in Manchester, UK. She's a member of the Malaysian Endocrine and Metabolic Society, a member of the British Endocrine Society, and also an active member in the Endocrine Society of the United States. For her good works and her deeds, she was awarded the Anugerah Perkhidmatan Cemerlang from HKL in 2013. Apart from being an expert clinician, she's also a wonderful and a master teacher, as such making her suitable for the role of being a trainer in the endocrinology fellowship program under the Ministry of Health. Her area of interest includes that of diabetes, pituitary and adrenal diseases, and also neuroendocrine tumors and reproductive endocrinology. So on the topic of diabetic retinopathy, we have nobody more suitable and more expert than Dr. Rafati to share with us her expert and her experiences. So ladies and gentlemen, your warmest virtual applause for Dr. Rafati.
Thank you, Joesh, for the very kind introduction. Assalamualaikum and a very pleasant morning to all the members of the floor, ladies and gentlemen. First and foremost, I would like to say thank you to Abbott for sponsoring this tea symposium. So, okay, so the topic that I'm going to talk about today is optimization of glycemic control to slow diabetic retinopathy progression. Is it good enough? So the answer is obviously no, otherwise I won't be here talking to you. Okay, so as everyone is well aware of, there are a myriad of complications related to diabetes, which can be macrovascular as well as microvascular. So diabetic individuals are 2 to 4 times more likely to develop stroke compared to non-diabetics. They are also 2 to 3 times more likely to develop coronary artery disease compared to their counterparts with no diabetes. And they are also extremely at high risk of developing peripheral arterial disease. And in diabetic individuals, about a third of them are affected by diabetic retinopathy of multiple spectrum. And diabetes is also the leading cause of end-stage renal failure in the world, especially in this region, Southeast Asia. And this is looking at the IDF data, which actually stated about a third of individuals with diabetes will develop diabetic retinopathy. And about a third of those individuals with diabetic retinopathy, a significant proportion of them actually develop diabetic retinopathy that actually threatens their vision and requires immediate treatment. And this is really the data looking about the Malaysian prevalence, what is happening in our Malaysian landscape. And the prevalence of diabetic retinopathy was quoted to be as much as 36.8%, which is very similar to the global prevalence. And this data was actually published in the medical journal in Malaysia in 2008, which actually revealed that about 36.8% of our diabetic individuals develop any form of diabetic retinopathy, and about 14.7% of them had vision-threatening retinopathy. And the scary thing is about 2/3 of our patients actually never had any prior eye examination. So this is really scary, given the fact that diabetes is really a significant burden in our population. And this data was actually quoted from Diet Care Malaysia in 2013, looking in greater depth what is happening at the microvascular level in terms of different categories of severity in diabetic retinopathy. And we are comparing the proportion of patients between 2008 and 2013, basically actually showed that the proportion of diabetic retinopathy has significantly doubled. And basically, this is just going back to our physiology, looking at what actually we can see behind the eyes in non-proliferative diabetic retinopathy compared to proliferative diabetic retinopathy. There are significant proportion that actually develop hemorrhage, heart exudate, as well as aneurysm. And for individuals with proliferative diabetic retinopathy, they actually develop extra growth of abnormal vessels. And these vessels are tiny, but they're very fragile and they're very prone to rupture. So if you all can imagine, this is what the diabetic individuals will see from their vision comparing to normal individuals with normal vision. So we can never really imagine what they feel given the impact of the problem. So not only blindness, but any degree of visual loss will affect the quality of life of these individuals with diabetes in a multitude of ways, including their psychological and physical well-being, their work, and also social integration and independence. Basically, we all have to accept the fact that blindness robs people of their independence and dignity and increases the need for greater social support. So blindness is no joke. I'm very happy to give this talk because we know that over the years, a lot of conferences are giving a lot of emphasis on cardiac problems, nephro problems, but we have less talk looking at the retinal visual problems. So this is what is the current flow of management for patients with diabetic retinopathy. There are 3 main stages as the disease progresses. And the most crucial part, the most pivotal part is the screening, which can be done at multiple levels. It can be done at the GP level, FMS, clinic kesihatan, as well as the hospital. And importantly, we need to prevent the development of diabetic retinopathy. And once it has developed, we have to try to retard the progression of the diabetic retinopathy. Unfortunately, by the time the disease has reached the advanced stage, we have to employ whatever modalities that we have to treat the advanced stage of the disease. So this fundal camera can be utilized to do diabetic screening. And we all know that at this point in time, a lot of clinic kesihatan already have the facilities to do fundal camera. It is really important to determine the condition of the retina because a lot of these patients, especially in the early stages of the disease, are fairly asymptomatic. And it's important to do timely referral so that we can actually stabilize the vision and to prevent the further deterioration which will lead to visual loss. So the examination schedule recommended by the Ministry of Health is at least once a year, including those individuals with no diabetic retinopathy. And by the time the diabetic retinopathy has developed, obviously the frequency will be more intensified. And what are the kind of patients that need referral to the ophthalmologist? That will include those individuals with mild or moderate non-proliferative diabetic retinopathy with maculopathy. I'm sure later on during the day, Dr. Hasnia will talk more about this. And individuals with severe NPDR without maculopathy and any form of maculopathy that can be detected. And individuals that require urgent referral to ophthalmologists include those with proliferative diabetic retinopathy and advanced diabetic eye disease. So basically, the mainstay of pathogenesis of the development of diabetic retinopathy lies in the consequences of hyperglycemia. Hyperglycemia will lead to alteration in the retinal blood flow that will cause vascular occlusion due to platelet aggregation, leukocyte activation, and adherence. And another important pathology would be the thickening of the basement membrane and also alteration in the growth factors that will eventually lead to vascular cell death. So all these multifactorials will lead to retinal hypoxia, which will further aggregate the development and the production of the growth factors that will lead to retinal neovascularization. So the important question number one, can glucose control in diabetes with, in patients with diabetes prevent the onset of retinopathy? So the answer is quite obvious, yes. So if we intensify the glucose control, we can actually prevent the development of this problem. So it's really essential for us to optimize the whole spectrum of the metabolic control on these kind of individuals to delay the progression. So when we see any diabetic individual, it's important for us to assess the A, B, and C. So A, obviously the HbA1c, we try to aim for less than 6.5 for majority of them, provided that they are not at risk of developing hypoglycemia. And we have to individualize the target if these individuals are at risk of developing hypoglycemia. Good blood pressure control, we try to aim less than 135/75 in majority of them. And also it's important to look at their cholesterol profile. And we want to make sure all the parameters of cholesterol, LDL, HDL, TG, and I did not mention non-HDL here, but it's also important for us to make sure all these three parameters are to target whenever we deal with any diabetic individual. So, despite optimal metabolic control, diabetic retinopathy still progresses. And this was clearly demonstrated. This was a study called STENO2 trial, basically looking at what is happening at the retinal part if the patients have received intensive glycemic treatment. So when we say intensive, basically we are looking at all these A, B, C parameters. And despite intensive glucose control, trying to achieve HbA1c less than 6.5, about 48% of these individuals still demonstrated progression of diabetic retinopathy after 8 years. And prevalence of diabetic retinopathy is very, very closely linked to the duration of diabetes. So the longer you have diabetes, the more at risk of you developing problems. So how do we fill in the treatment gap? So we basically need a unique mode of action, which is not mediated by the lipid lowering effect. And we need some therapy, especially in the early stages of diabetic retinopathy, which actually possess anti-apoptotic activity, which will increase the expression of VEGF to stabilize and strengthen the retinal endothelial cells that will actually regulate the survival of the retinal endothelial cells. And we also need an agent that can give you some form of neuroprotective effect that will reduce LPPLA2, which has been implicated to induce the cell death. And it has been demonstrated that fenofibrate, which is the highlight of this talk, possess the antioxidant, anti-inflammatory, and anti-apoptotic properties, which may contribute to this effect. So once the diabetic retinopathy has progressed to later stages, we need something very potent to downregulate the angiogenic effect. We need something that will reduce the expression of VEGF to inhibit angiogenesis as well as neovascularization. And also we need some agent that will protect against the blood retinal barrier breakdown that will result in lesser vascular leakage. So I'm not going to talk in details about this because I think Dr. Asina will talk more about what we can do for advanced diabetic retinopathy. But basically, it's important for us to know in this day and age, there are multiple options that we can deliver to treat patients with advanced diabetic retinopathy. So again, going back to fenofibrate or Lipantil, the brand name, there are two major trials which have demonstrated the importance of fenofibrate to retard the progression of retinopathy. And one of them is actually the Accordion eye follow-up study, which was published in 2016. And basically, the study demonstrated the benefits of fenofibrate across the spectrum of the lipid level. So regardless of your lipid level, there are benefits of fenofibrate. However, the beneficial effect of fenofibrate on the diabetic retinopathy requires continuous treatment because it does not have any legacy effect. Once you stop the treatment, basically the effect stops. So again, reiterating about the difference between Accord-I and Field. Accord-I was published in 2010. About 1,500 patients were recruited, and it was a 4-year follow-up, basically 2 arms comparing patients received fenofibrate and simvastatin versus simvastatin plus placebo. And the main objective was looking at the progression of the diabetic retinopathy. And the Field study was published in 2007. Almost 10,000 patients were recruited, and it was a 5-year follow-up, basically comparing fenofibrate and placebo. And the main objective was to look at the need for laser therapy for diabetic retinopathy, as well as the progression of diabetic retinopathy. Yeah, so in Accord-I study, those that were excluded with history of proliferative diabetic retinopathy that requires laser and or vitrectomy. And how did they assess the progression of the diabetic retinopathy? Was basically using a scale called Early Treatment Diabetic Retinopathy Study Severity Scale, and the progression was denoted as progression by more than 3 steps. And the development of proliferative retinopathy was actually indicated by photocoagulation therapy or the need for vitrectomy. And these was the baseline characteristics of patients at the beginning. It was a long chronic duration of diabetes, about 10 years. HbA1c baseline was 8.2%, and their baseline LDL was around 2.5, TG 2.1, HDL 1. So it's fairly almost the same as the kind of patients that we see maybe at the clinic kesihatan level, I would say, because patients coming to our MOPD are obviously more complicated than this. And nearly half of the subjects had pre-existing diabetic retinopathy at the baseline, with the majority of those individuals actually belong to the group of non-proliferative diabetic retinopathy. So basically, the study demonstrated a significant reduction in the risk of progression. In the overall population, there was about 40% relative risk reduction in the individuals that received Lipantil or fenofibrate. So that is denoted by the line in blue. and the number need to treat was 27. And how about if we look at the subgroup analysis of individuals with diabetic retinopathy at the baseline, there was a 57% relative risk reduction if they receive Lipantil or fenofibrate. However, in this study, it was demonstrated there was no benefit seen in patients without diabetic retinopathy at the baseline. So ACCORD-I study basically demonstrated if you actually subcategorize these individuals regarding based on their baseline TG level, whether it's high or low, baseline HDL level, high or low, glycemic therapy, whether the A1C at the baseline is less than 6% or more than that, and also the duration of the diabetes. Basically, fenofibrate showed the same benefit across the spectrum, and it was independent of the baseline lipid level, as well as the intensity of the glycemic control. And how about the field study? Field study was a 5-year follow-up, 2 arms comparison, and the trials basically showed that fenofibrate reduces the progression and the need for laser therapy. So if you look at the mild NPDR, there was 57% risk reduction of progression, and moderate NPDR, it was as much as 79% risk of progression in those individuals with pre-existing diabetic retinopathy. And how about if the patient has progressed to the more severe end of the spectrum? There was a 31% reduction in the need for the first laser treatment for macular edema or proliferative diabetic retinopathy. And for those patients who have received lasers in the past, there was a 37% risk reduction of need for more laser therapy. So because of the solid evidence garnered by all these landmark trials, there are various recommendations provided by professional bodies throughout the world. It has been recommended in the UK guideline to advocate adding fenofibrate to a statin for individuals with non-proliferative diabetic retinopathy, and the European Society of Cardiology also advocated the use, and the American Diabetes Association also advocated the use of fenofibrate, especially in those with mild NPDR. So this was the Singapore guideline. Our neighbor also advised the usage of addition of fenofibrate to retard the progression of diabetic retinopathy. And Australia, which also advised and advocated the usage of fenofibrate. IDF. And this is from our Malaysian CPG guideline for the diabetic retinopathy in 2017, also advocated the usage of fenofibrate. So what is exactly fenofibrate? It is a fibric acid derivative which actually reduce the triglyceride by activation of PPAR alpha and also lipoprotein lipase, which will reduce the production of apoprotein C3 and increase the synthesis of apoprotein A1 and A2, which eventually will reduce the production and synthesis of VLDL, LDL, and increase the HDL. So this is according to the latest Malaysian CPG guideline published in 2020, which also clearly stated the place for fenofibrate in individuals. And obviously there was a main emphasis given to intensive glucose control, but also fenofibrate usage should be considered to retard the progression of retinopathy, especially in those with NPDR. And this holds true irrespective of their baseline lipid status. So, ladies and gentlemen, we all have to be aware that we have to put a lot of emphasis for strong metabolic risk control throughout the spectrum of diabetic retinopathy. And importantly, we all should consider initiation of fenofibrate early in the disease, especially mild NPDR and moderate NPDR. And by the time the patient develops severe NPDR and PDR, they should be under the ophthalmologist follow-up, and they should receive laser therapy or anti-VEGF or even surgery. So ladies and gentlemen, just to summarize everything in a nutshell, early detection is very important to arrest the progression of diabetic retinopathy. I can't emphasize enough on the importance of screening for this problem, and it is the progressive disease which is clearly linked to the duration of diabetes, and it can continue to progress despite the optimal metabolic control. And fenofibrate has been shown to be very effective in slowing the progression of DR, and it is independent of the lipid lowering effects. And it is effective in patients with existing diabetic retinopathy, regardless of their lipid status, A1C, as well as comorbidities. With that, I thank you.
Thank you so much, Dr. Rafati, for that very brilliant session. And I think Dr. Rafati very nicely sent the message home that blindness is no joke. Hence the need for very good care for patients, especially with mild diabetic retinopathy. So while waiting for the chat screen to come up, maybe a question for Dr. Rafati. I think both studies had a very strong emphasis on type 2 diabetic cohorts. Do we see fenofibrate benefiting patients with type 1 in a similar fashion? And do type 1 patients actually derive more benefit from fenofibrate in other mechanisms?
Okay, thank you for the question, Joash. So basically, fenofibrate has been demonstrated to be beneficial in both cohorts, type 1 and type 2. So I would not hesitate to start fenofibrate for type 1 and type 2. Yeah. At the moment, just to illustrate what's happening in Hospital Sultanah Bahiyah, is actually a quota item. But I'm hoping that in the future, we can actually make it a free flow medication, because I can see potentially a lot of our patients can benefit from fenofibrate, especially at the KK level as well. And there are some hospitals, for example, Hospital Kuala Lumpur and Hospital Putrajaya, which are already making it as a free flow item.
Okay, we have 1 more minute. Are there any other questions from our live audiences? YouTube? None. Okay, I'm sure everybody has benefited from today's session. Once again, we would like to thank Dr. Rafati for this expert session, and for the T Symposium. We also like to thank Abbott for kindly providing and sponsoring this symposium. So I pass the time over to Dr. Tan Ying Jie, who will be chairing the next symposium on diabetic complications. Thank you very much.
Okay, good morning, everyone, ladies and gentlemen. I wish everyone enjoyed the T Symposium just now. So now welcome to our next symposium entitled The Diabetic Complications of the 12th PGMES Biennial Scientific Meeting. So regarding on the diabetic complications. So I'm Dr. Tan Ying Jie, your chairperson today. So we are honored to have a panel of distinguished faculty members who will be delivering lectures on these topics. So it's my great pleasure to introduce our first speaker, Dr. Haslina, who will be presenting on the diabetic eye disease. Dr. Haslina is a renowned ophthalmologist in Malaysia. She graduated from UKM in 1989 and obtained her master in surgery ophthalmology from the same university in 1999. She completed her fellowship training in vitreoretinal surgery in Royal Liverpool University Hospital, United Kingdom in 2005. Currently, she is working as a senior consultant ophthalmologist in a hospital Sultanah Bahiyah and a visiting ophthalmologist in Pusat Pakar Mata dan Lasik Utara Cinta Sayang Resort Home, Sungai Petani, Kedah. Without further ado, I pass the floor to Dr. Haslina.
diabetic eye disease. And this is the outline of my talk. Diabetic eye disease is a group of eye problems that can affect people with diabetes. Over time, it may lead to poor vision, that is either low vision or blindness. Diabetic retinopathy is the main cause of blindness in working age group in our country. And most patients are asymptomatic in the early stages. But diabetic eye disease is more than just diabetic retinopathy. There's a spectrum of other problems as well, and this includes glaucoma, cataract, vascular and neurological disorders, and also infection. This is to recapitulate, just to remind you that the eye is an extension of the brain. This is the anatomy of the eye. This is the cornea, which is the transparent part of the eye, and it forms the wall of the eye anteriorly. Posteriorly, it is continuous with the white part of the eye called the sclera. And why this is white is because of the arrangements, or opaque is because of the arrangements of the fibers. So this is the iris, and the chamber in between the cornea and the iris is called anterior chamber, and blood and pus can accumulate in this chamber. This is the lens, and it is suspended in its position by suspensory ligaments, and the chamber in between the iris and the lens is called posterior chamber. The wall of the eye, the inner part of the wall of the eye, is the vascular layer. From anterior, it comprises of the iris, the ciliary body, which produces aqueous, and the posterior part is called the choroid. And this is the vitreous cavity. The innermost layer of the wall here is the retina, which is part of the brain. This is the optic nerve head. This is the optic nerve, and the optic nerve head is what we call the optic disc. So we go to the first problem, which is the neurological problem. This patient has problems with ocular motility, and if you focus on this photo, he has A6 nerve palsy. Patients with diabetes can also have third nerve palsy, but usually the third nerve palsy is incomplete, and usually it is painless, and usually it does not affect the pupil. It does not cause pupillary dilatation. This is a patient with left orbital cellulitis. If left unchecked, it may lead to cavernous sinus thrombosis. This is a patient with herpes zoster ophthalmicus. And if you see here, if the lesion affects the tip of the nose, which is called the Hutchinson's sign, then there will be 100% chance of ocular involvement. So you need to refer this patient to an ophthalmologist. But a patient with a Hutchinson's sign may still have ocular involvement, and you need to listen to symptoms and look for signs of ocular involvement. This is the same patient who came to us late with corneal ulcer, and it subsequently led to corneal perforation, and he lost this eye. This is a patient with meibomian gland, infection of the meibomian gland. This patient will need antibiotics, and some may also need drainage. And this is a patient with infection of the lid margins called blepharitis, but this patient has chronic blepharitis, so you can see that it's very thickened. This is a patient with corneal ulcer. Another patient with corneal ulcer, but the ulcer is larger, and he also has pus in the anterior chamber called hypopyon. So this patient will need extensive antibiotics, drops, topical, and also maybe subconjunctival injection. And we will need to see whether the patient, whether the infection has extended to the posterior part of the eye. In order to do so, we will need to do a scan called a B-scan. And why this needs to be established is because, one, the prognosis is poorer when the posterior part of the eye is affected. Number two, the patient will need intravitreal injection of antibiotics. And number three, when the view permits, the patient will need surgery. Okay, this is to show that this patient has conjunctivitis. I would like to emphasize if you could look at the hyperemia of the eye, the conjunctiva, tarsal conjunctiva is affected, the bulbar conjunctiva is affected, but the conjunctiva surrounding the cornea or circumcorneal conjunctiva is not as red as over here. So the patient has conjunctivitis, usually viral in origin. They are painless. They usually have discharge, and they are infective. As opposed to this patient who has endophthalmitis, the redness is more around the cornea or circumcornea. You can see that the lashes are matted over here. There's fibrinous exudate and also pus formation or hypopyon. A patient with other kinds of infection like urinary tract infection, septicemia, infection elsewhere with red eye or red eyes, please suspect endogenous endophthalmitis, and urgent referral is mandatory. This is a patient with cataract, and this patient happens to have mature cataract. I'm going to the posterior part of the eye, and this is the head of the optic nerve, what we usually call optic disc. These are all the retinal vessels, veins, and also arteries. And this is macula. I'm pointing straight to the macula because this is the most sensitive area of the eye where vision is concerned when during daylight or when there is when there's light. Yeah. This is the fundus photograph of the right eye and also the left eye. So this is the optic disc. If you can look at this, these are vessels coming out from the center. It has a small cup over here. This is the macula, very healthy. This is one of the conditions in diabetic eye disease. This patient has advanced glaucoma. If you can see here, the cup is very enlarged and the vessels are pushed nasally. Okay, again, this is the photo of the macula. You call the macula over here. For ophthalmologists, this is called the macula, and this is called the fovea. Yeah. And because the macula is such an important and sensitive area, so we have what an optical coherence tomograph, or a scan called optical coherence tomograph, and it shows the 10 layers of the retina, and this is the choroid. And this is to make sure that the macula is all right. Okay, we'll go to pathogenesis in diabetic retinopathy. Firstly is microvascular occlusion, and secondly is microvascular leakage. In microvascular occlusion, when it's occluded, then there's hypoxia and there is formation of new vessels. Initially, posteriorly, and subsequently, the anterior segment of the eye can be affected, rubeosis iridis or formation of vessels at the iris. Okay, this is the result of microvascular occlusion, neovascularization at the disc, or NVD we call it. You know, if a patient has occlusion at the brain, that can cause stroke. At the heart, that can cause heart attack, AMI. But in the eye, God has made it such that new vessels are formed. But these new vessels, to compensate for this hypoxia, but the new vessels are very fragile and they bleed, they break very easily, causing bleed. This is at the disc, and this is neovascularization elsewhere, away from the disc. And this is the macula. As you can see, the macula is still all right. So vision is still good. The patient does not know that he or she has a time bomb, waiting to bleed. If there is no screening, the patient will have blood in the eye. So back to our diagram, the posterior segment. So when there is microvascular occlusion, there's hypoxia, vasoformative substance being released, and there's formation of new vessels at the disc and also elsewhere. And at this time, the patient's vision is still good. But as time goes on, with a small trigger, a cough, a strain, then there can be bleed in the eye. And this is when the vision is affected. The macula is over here. And with time, when there is no proper treatment, the hypoxia will cause the vessels to grow anteriorly, and what you see are vessels on the iris. And these vessels they will grow at the angle of the eye, and that will cause obstruction to the outflow of the fluid, and intraocular pressure will go up, and that is what we call glaucoma. Initially, it can be treated, but if left untreated, it will be intractable. So again, this is a patient with microvascular occlusion, new vessel formation, bleeding, and this is very bad. You can't see the whole of the macula over here. The vision is very poor. We need to do surgery for this patient, or else there could be formation of glial tissue beneath on the macular area, at the macular area. So you see bleeding over here, and there's gliosis, glial tissue formation. These patients need treatment. Apart from diabetic retinopathy, patients may also develop central retinal vein occlusion. Okay, this is the macula over here. This is the nasal part, and also branch retinal vein occlusion. This is our patient, one of our patients. So this is supratemporal retinal vein occlusion. Okay. Both central retinal vein occlusion and also branch retinal vein occlusion can also cause new vessel formation and lead to hemorrhage in the future. So the next pathogenesis is microvascular leakage, causing edema, and when it occurs at the macula, that's when vision is affected. If it occurs elsewhere, then vision is not affected. But of course, most of the time, it will occur at the macula. This is again a normal, to recap, normal scan of the macula. And this is a patient with diabetes with fluid intraretinal in the layers, in the retinal layers, and this is heart exudate that is caused by leakage. And this is right and left. This is a patient with even severe edema. These are fluid. This is fluid in intraretinal, and this is fluid subretinal or underneath the retina. Severe macular edema caused by diabetes. Okay, I would like to take this opportunity to just to just emphasize regarding challenges during pregnancy in a patient with diabetes. So unlike a person who's not pregnant, pregnancy could lead to blindness in a matter of few months, and diabetics, patients with diabetes in childbearing age need to be properly counseled regarding the risk of blindness from diabetic retinopathy during pregnancy. An effort should be taken to achieve a good metabolic control, and patients can still get pregnant if they have had optimum eye treatment. They should have planned the pregnancy, but if the pregnancy is unplanned, then they should be referred as soon as possible. If or the eye should be looked into the moment they are pregnant, the moment the doctor knows that the patient is pregnant. So this is a 23-year-old lady, pregnant, right eye developed bleeding from proliferative diabetic retinopathy. This is the left eye, also bleeding. So right side 4/6 division, left eye, hand movement vision. I did her surgery after her delivery in the right eye first. So this is another patient, 34 years old, Gravida 1 at 29 weeks. She has developed neovascularization. And she was only at 29 weeks, so it's very difficult to manage these patients. And the same patient had also had macular edema. This is another patient, 27 years old, Gravida 2, Para 1. And the right side, she had proliferative diabetic retinopathy with retinitis proliferans and traction defect in the macula. In the left eye, she had all this neovascularization and also gliocysts, and also a bit of macular edema. So again, surgery was done after delivery. This was a 37-year-old lady at 12 weeks with poor vision in the right eye due to pre-macular hemorrhage and also vitreous hemorrhage. And this was after her pregnancy, and we could see that in the left eye, there's very bad traction, as also traction in the right eye as well. So, and another patient, 37 years old at that time, G7P5, BKA done, PDR in the right side, and left side she came with uveitic glaucoma. This was her scan, very bad macular edema. She underwent a termination of pregnancy because of multiple medical problems. So this is another patient at 32 years of age at that time. She had good laser scars and also gliosis over here, and she had this macular edema in the left eye, macular scar in the left eye even before her pregnancy. So she went on to deliver, and during the pregnancy, she did not have any problems, did not have any progression of her diabetic retinopathy. And this was her scan. This was a scar in the left eye. So we'll go to treatment. There's laser treatment, anti-vascular endothelial growth factor injection into the vitreous, and also surgery. So this is laser treatment. This is the usual pen photocoagulation, and also focal laser for diabetic macular edema. And laser PRP or pen photocoagulation has been shown to decrease blindness in patients with proliferative diabetic retinopathy. This is one of our patients with laser PRP done. And intravitreal injection of anti-VEGF. There are so many retinal barriers in the eye, and in order for treatment to be optimum, that intravitreal injection should be intravitreal. Antibiotics for an infection, for endophthalmitis, and in this case, anti-VEGF. So again, to recapitulate, this is the normal optical coherence tomograph or scan of the left macula. this is a patient with macular edema. If you can see over here, there are intraretinal fluid and also subretinal fluid. This is a sequence of macular edema with monthly injection. With injection, the subretinal fluid subsided and intraretinal fluid decreased further. Although sometimes you can see increase and then it decreased again. So the injection, multiple between 4 to 6 in the first 6 months, and some will need further injections, or most, you'll see that most will need further injections. Okay, this is a patient, so anti-VEGF injection for macular edema is established. The usage of anti-VEGF for proliferative diabetic retinopathy has been approved in Malaysia, but in KKM, we will need individual approval. So this is a patient with proliferative diabetic retinopathy in the left eye. There are preretinal hemorrhages, and this is before injection. This is after the first injection. You can see that the blood has contracted. Okay, the vision has always been good because the macula is not covered by the blood. So this is after the third injection. You can see it, that the blood has contracted further. And this is after the fourth injection. And we are continuing with the fifth injection. Okay, then the next treatment is surgery, and it's what we call vitrectomy, transpus planar vitrectomy. Currently, I use 25 gauge. It's sutureless. 27 gauge is available, but with smaller gauges, the cartridge and everything, the cutters are more expensive. This is a 24-year-old girl whom I did last week. Proliferative diabetic retinopathy. This is the right eye, and I've managed to clear up the scar tissues, and fortunately, the macula has not been, there's no traction onto the macula, is at the edges over here, and that has been released, and this is the left eye. So, sorry, this is the left eye, and she is seeing quite well with the left eye. So one thing about this young girl is that she was very adamant that she did not want surgery, and we had to really, explain to her. We had to take a lot of time to tell her that this will lead to blindness. This was because her mother, who passed away 10 years ago, had very bad eye disease, but she came to us with rubeatic glaucoma in both eyes. So in order to get rubeatic glaucoma, they must have problems with the back part of the eye. So vitreous hemorrhage, advanced diabetic eye disease, or proliferative diabetic retinopathy, and then subsequently it goes to the front, as I've mentioned before. So, but we are now having patients who come and present straight with rubeatic glaucoma. So that was what the mother presented with. So we did surgery for her, but doing surgery, glaucoma surgery, and then retinal surgery, and then we lost her to follow up. So some patients, they don't understand that surgery is not, the end of treatment, but we need to follow them up. But of course, I'm also aware that most patients, they do not just have complications in the eye, but they have multiple systemic complications as well, and that causes them to be lost in follow-up. So maybe if they're admitted, the nurses or the nurses and doctors, you can find out whether if they are admitted but have appointments to other clinics, then these appointments should be rescheduled. So And coming to summary, diabetic eye disease is a group of eye problems that can affect people with diabetes. Diabetic retinopathy is the commonest cause of blindness in working age group in Malaysia. Pregnancy could lead to blindness in a matter of few months. A patient in medical ward, for example, with infection and red eye, doctors, you need to rule out endogenous endophthalmitis because this is a blinding condition. And lastly, can we avoid poor vision in diabetics? We definitely can, but it boils down to good metabolic control, screening, even when the vision is good, and also apt referral to the ophthalmologist. So with this, I thank you.
Okay, thank you, Dato, for enlightening us regarding the diabetic eye disease and in terms of the complication as well as the treatment modalities for that. So besides the common diabetic retinopathy complications, you need to aware they can cause multiple various types of eye infections as well. So again, Dato stressed regarding the screening, the good metabolic controls as well as the urgent referral. So to prevent the complications. So we will have the questions and answer sessions at the end of these 3 lectures. So, but feel free to type any questions in the chat box. So next, our second speaker is Dr. Ching Cheng Hua. Dr. Ching graduated from University of New South Wales in 1994 and obtained her MRCP in 2000. She later obtained her fellowship in nephrology in 2004. She has been involved in multiple research work and publications. Dr. Ching is currently a senior consultant nephrologist and head of hemodialysis unit in Hospital Sultanah Bahiyah. Today, she will deliver lectures on the prevention of the diabetic nephropathy. So Dr. Ching, the floor is yours now. Thank you.
Thank you, Madam Chairperson, for the kind introduction. First of all, I would like to thank the Postgraduate Medical Education Society for inviting me to share the knowledge on prevention of diabetic kidney disease. As you all know, diabetes has become a global emergency. The prevalence of diabetes continues to rise, and the cost to treat and to manage its complications has imposed a great burden to our healthcare system. About 35 to 40% of the diabetics will end up having chronic kidney disease. The world celebrates World Kidney Days on every second Thursday of March every year. 2 weeks ago, our health minister mentioned that Malaysia has one of the highest rates of kidney failure cases in the world based on the number of patients per million population. Every year, we have about 8,000 new end-stage kidney disease entering our dialysis program, and this doesn't include those patients with end-stage kidney disease but did not make it to dialysis program. And we spend about 1.5 to 3.2 billion ringgit every year to treat this group of patients. Therefore, our health minister urged the public to undergo regular tests and seek treatment from nephrologists to check if they are at risk of developing kidney disease. According to our Malaysia National Renal Registry, in 2017, there were about 67% of our end-stage kidney disease patients on regular dialysis. The cause of the end-stage kidney disease were diabetes mellitus. Diabetic nephropathy or diabetic kidney disease is a clinical syndrome, consists of a package of persistent albuminuria, increased blood pressure, sustained reduction in glomerular filtration rate, increased cardiovascular events, and associated mortality. Hyperfiltration as a result of hyperglycemia activates the renal angiotensin-aldosterone system, which leads to relative vasoconstriction at the efferent arterioles, and the end result is raised intraglomerular pressure. The persistent raised intraglomerular pressure causes damage to endothelium and causes focal glomerulosclerosis, which eventually leads to loss of kidney function. The raised intraglomerular pressure also causes loss of podocyte integrity, leading to leakage of protein manifested as microbinuria or overproteinuria. Our kidney went through few stages of pathological changes throughout the journey of diabetes. Initially, the hyperfiltration, as reflected by the increased glomerular filtration rate, leads to the compensatory renal hypertrophy. After that, it goes into incipient diabetes nephropathy, where the kidney starts to decompensate and it manifests as microalbuminuria stage. Prolonged uncontrolled diabetes leads to overt proteinuria, where the kidney functions start to deteriorate, and eventually it went into end-stage kidney disease. These classic changes are typically seen in type 1 diabetes. However, type 2 diabetes may not follow these classic step-by-step changes. Persistent uncontrolled diabetes started the whole cascade of diabetic kidney disease, and the activation of renal angiotensin-aldosterone system causes glomerulosclerosis and also inflammation, which leads to progressive loss of kidney function and eventually end-stage kidney disease requiring kidney replacement therapy. Therefore, optimal glycemic control is the most important key intervention to prevent the onset of diabetic kidney disease and its subsequent progression. There were several landmark trials clearly demonstrated that optimal glycemic control can reduce the incidence of microvascular disease, and it can actually reduce the incidence of diabetic kidney disease by 30 to 60%, depending on the initial HbA1c. The higher the HbA1c to start off with, we see the greater benefit when it gets the HbA1c down to 7%. What is the target we're aiming for in terms of seeing the renal protection of the diabetic kidney disease? In terms of the glycemic control, the answer is individualization. According to the KDIGO guideline published in 2020, the target glycemic control range between 6.5 to 8%, depends on the patient's characteristic and their risk of developing hypoglycemia. We allow higher HbA1c in patients with advanced kidney disease, such as CKD stage 4 and 5, patients with many comorbidities, patients with short life expectancy, or patients with severe macrovascular complications, or those patients who have a propensity of treatment to cause hypoglycemia. In treatment algorithm of patients with type 2 diabetes and CKD, lifestyle therapy, which consists of physical activity, nutrition, good nutrition, and also weight loss, is the cornerstones of the management plan, which we need to emphasize early on in the CKD management, because it needs a lot of time, effort, and perseverance to see the results of the benefit, and it is actually the safest and most effective therapy. We should keep reminding and emphasizing to our patient the importance of this lifestyle therapy during every single consultation session. In terms of pharmacological agents, metformin is still the agent of choice because it has long history of safety and efficacy records. However, the dose needs to be adjusted when the eGFR falls below 45 mL per minute, and it should be discontinued when the eGFR falls below 30. SGLT2 inhibitor is also listed as one of the first-line therapy based on the recent available data. Again, SGLT2 inhibitor is not recommended in CKD4 and above. After this, you can add any of the anti-glycemic agent in order to achieve the glycemic targets. Depends on the patient's kidney function, comorbidities, availability, cost, and preferences. Just to remind again, we need to monitor the patient's kidney function from time to time and to adjust the anti-glycemic agent dose accordingly. Patients with diabetic kidney disease have manifold higher CV risk compared to those without diabetes. Therefore, it is best to choose anti-glycemic agent that not only able to control the diabetes, but also has beneficial effect on the heart and kidney. And this table shows some of the newer anti-glycemic agent with additional cardiovascular and also renal protective effect. We always need to remember to take special consideration on the kidney function, as it will affect the choice and the dose of the drugs prescribed. After we tackle the hyperglycemia, the second most important therapeutic intervention is to block the renin-angiotensin-aldosterone system. As mentioned earlier, activation of the RAS leads to raised intraglomerular pressure by causing relative efferent vasoconstriction. ACE inhibitor and ARB causes efferent vasodilatation, and this leads to the drop in the intraglomerular pressure, reduction in the proteinuria, and in the long run, it leads to the renal protection. Is there any evidence on this? The answer is definitely a yes. We have two landmark trials, which names Biennial and IDNT, which have clearly shown the benefit of this ARB in the renal protection, and we take ACE inhibitor as a class effect. Therefore, we equivocate the ACE inhibitor also have the similar benefit as the ARB. In the Biennial trial, it is a two-arm trial, which showed the significant less patient in the losartan arm, which reached the primary outcome compared to the placebo. And we see similar results in IDNT trial, which is irbesartan compared to amlodipine and also placebo. This two landmark trial has shown that ARB is renal protective with a relative risk ratio of 0.81 to 0.84. However, it still leaves a residual risk of about 32 to 40% of risk to progression to end-stage kidney disease. In other words, a significant number of patients still progress to end-stage kidney disease despite on maximum dose of ACE or ARB. And this obviously is not good enough. But unfortunately, this is the only bullet we have for the past 20 years. SGLT2 inhibitor, which was first introduced as a glucose-lowering agent 10 years ago, has filled a long-standing gap in nephrology's approach to the care of diabetic kidney disease. More and more evidence have shown that it can provide further opportunities to address cardiorenal complications and the comorbidities of type 2 diabetes. Our kidneys play a critical role in the management of glucose reabsorption and maintaining the overall metabolic balance in humans. This SGLT2 inhibitor, it exhibits its glucose-lowering function by blocking about 90% of glucose reabsorption at the proximal tubules giving rise to the glucosuric effect. In this schematic diagram, we see that in the uncontrolled diabetes, there's a hyperfiltration in the early stage of diabetic nephropathy, and this hyperfiltration will then leads to relative efferent arterial vasoconstriction, and that leads to the raised intraglomerular pressure, and then eventually leads to glomerulosclerosis and loss of kidney function. In SGLT2 blocks both glucose and sodium reabsorption at the proximal tubules, so there are more sodium delivery to the distal tubules, and it's sensed by the macula densa, and the end result is it causes a relative efferent arterial vasoconstriction, and that leads to the normalization of the intraglomerular pressure. SGLT2 inhibitor can protect against the onset of diabetic kidney disease and slow the disease progression independently, in addition to the blockade of a renal angiotensin aldosterone system by ACE and ARB. As you can see here, SGLT2 works mainly on the efferent arterial, and ACE and ARB acts on the efferent arterioles, and both cause to the reduction in the intraglomerular pressure. The clinical benefit of SGLT2 includes metabolic effects, and it can reduce the HbA1c by about 0.5 to 1%. It also has diuretics effect, and in terms of renal effect, it can restore the tubular glomerular feedback, reduce the intraglomerular pressure, and also reduce the albuminuria. There are actually many SGLT2 inhibitors in the market at the moment. However, there are only 3 SGLT2 inhibitors that actually conduct trials, especially looking at the kidney outcomes at their primary outcomes. And they are Credence trial, which is these are 3 RCT trials, especially looking at the kidney outcomes as their primary outcome. And they are Credence, which is using canagliflozin versus placebo, DAPA-CKD using dapagliflozin versus placebo, and also EMPA-Kidney using empagliflozin versus placebo. And all these 3 landmark trials are using different eGFR and also different level of a urinary albumin creatinine ratio as their one of the inclusion criteria. The 2 landmark trials that already published are Credence and the DAPA-CKD, and both show that there will be a relative risk reduction of about 30 to 40% in the kidney outcome. EMPA-Kidney trial, we expect it to release its result by end of this year. Remember, I mentioned earlier in the talk that patients on ARB still has a residual risk of developing CKD by about 30 to 40%. And by adding the SGLT2 inhibitor on top of the maximum dose of ACE or ARB, hopefully it can further prevent more patients from going into the end-stage kidney disease. This table shows that there were no dose adjustment in terms of SGLT2 inhibitor dose until the eGFR of 45 mL per minute. FDA actually didn't recommend the initiation of a SGLT2 inhibitor when the eGFR is less than 30. However, we are waiting for the outcome of the EMPA-Kidney trial, which hopefully will publish by end of this year. And EMPA-Kidney trial actually recruit patients with eGFR of as low as 20. Another emerging agent that which can be a renal protection, which is actually mineralocorticoid receptor antagonist. One of the trial that been published early in end of the 2020, which called Fidelio Dapa CKD kidney, and it demonstrated that in people with type 2 diabetes and albuminuric CKD treated with a finerenone over 2.5 years period, there were a slow progression of CKD with a hazard ratio of 0.82. Another treatment area that we need to focus on is the blood pressure control. Optimal blood pressure control can retard the kidney function progression, and the relationship is of linear relationship. In our second edition, Malaysian CKD CPG, which is published in 2018, we actually recommend the target BP with a systolic of less than 130 and 130 in a patient with diabetic kidney disease. Few trials, and including the recent KDIGO guideline published in 2020, they actually recommend the target systolic blood pressure to be less than 120 millimeter mercury, considering that it has an additional cardioprotective effect. However, it doesn't have any more additional renal protection. How about the antihypertensive agent? Many studies have shown that the benefit of ACE and ARB as a first choice in diabetic kidney disease, because it can actually retard the progression of the diabetic kidney disease. Our KDIGO guideline published in 2020, it recommended that the treatment with an ACE or ARB to be initiated in patients with diabetes, hypertension, and albuminuria, and that this medication should be titrated to the highest approved dose that is tolerated. ACE and ARB used in patients with hypertension and eGFR of less than 60, but without albuminuria, appears to be of little or no benefit over the blood pressure control with other agents. Both the KDIGO and ADA guidelines discourage the use of ACE or ARB inhibitor in normoalbuminuric, normotensive patients with diabetes. How about dietary protein? According to the KDIGO and KDOKI guidelines, they recommended that the low protein diet, which is about 0.6 to 0.8, should be recommended to a patient with an eGFR of 30 or below. That's provided that they have a stable nutritional status and optimized glycemic control. So in summaries, I have touched the 5 pillars of the methods for the prevention of the diabetic kidney disease, and which includes optimal blood sugar control, and recommend is about 6.5 to 8% according to the patient's characteristic. Optimal blood pressure control, and for the renal protective effect, you will be less than, we target for blood pressure of less than 130/80, and we ought to use RAS blockers in whenever we can, and also we can consider SGLT2 inhibitor for patient who is suitable and eGFR of more than 45. And last one is there are emerging data to show that non-steroidal MRA is also can confer a renal protective effect. Last and not least, we must not forget the foundation of the diabetic kidney disease treatment is our diabetic diet, which include low salt and low protein diet. With that, I thank you for your attention and happy to answer any questions. Thank you.
A very good day to everyone. Thank you very much for inviting me for this talk. Now, it's actually on diabetic foot management, but I would like to actually talk about how do I heal DFU, tips and tricks. This is the place where we actually have the wound care unit under the Department of Internal Medicine. It's in the 8th floor of the specialist complex ACC building. And this is where we have about close to 20,000 patients coming in to see us for the past, in a year, basically. So we started off with about 2,700 patients, and now we have about 20,000 patients. This is the Asia Pacific Issue and Diabetic Limb Problems. I took over the presidency of the APADLP last year, and you can see here, basically, we have got provinces from Singapore, we've got from Taiwan, Hong Kong, Thailand, Indonesia, and then Philippines and myself. This was actually taken in Yogyakarta in Indonesia. This is the DFO International. We are the implementation arm of the International Working Group on Diabetic Foot. I'm also a member of the board and the vice president for DFoot, which is an international organization. And we sit in the regional chairs under the Western Pacific region also. So DFoot International is a big organization where we're having actually webinar series now, basically every other month. Okay, we're having in January and now in March we're having. So this actually in Petarin Hospital in Bangkok, where we had the train the trainer session. Now this is an international consensus document, which is also a part of this document, identifying and treating foot ulcers in patients with diabetes, saving feet, legs, and lives. Now this is important for us to actually differentiate between diabetic foot ulcers and pressure injuries and all that, so we can manage the patients better. Now this was actually launched by the Journal of Wound Care in Krakow, Poland during the European Wound downloadable documents in the Journal of also international best practice, looking at best practice guidelines, wound management in diabetic foot ulcers.
Bantu sikit lah. Boleh. Setiap bilik dia letak ke atau bilik dia? Saya letak aje, bila tak ada letak air pun ada pecik je. Letak balik sebab bilik dia letak lampu merah semua tu. Kalau bilik untuk on malam-malam. So dia buat macam neraka and then dia baca. Tak pernah I tengok orang letak lampu merah.
That's important. So people who do pedicure, it doesn't mean that you actually look after the feet itself. And diabetics end up with autonomic neuropathy and all that, with dry skin, with fissures and all that. So all these have to be managed. Now look at this particular patients. Two of them actually came to see us all that. So one of the important dictums here basically is lower extremities amputation prevention. We want to prevent basically lower extremities amputation itself. And you find that one of the main themes of the DFO International is to prevent avoidable amputation. Okay, that's very important now. And patients come in with neuropathy because of nerve damage, whether it's somatic, whether it's motor, or whether it's autonomic. And then you've got ischemia also. Patients can have pain, they can have calluses, they can have numbness, they have deformities, ulcers, gangrene, and all that. So all this is a range of things that can happen to a patient's foot. And if you look at the risk factors of foot ulcers, diabetes for more than 10 years, previous amputation, it follows the rule of 50, past foot ulcer history, a peripheral neuropathy, diabetic peripheral neuropathy, or peripheral vascular disease, poor glycemic control, HbA1c more than 9%, visual impairment, retinopathies and all that, diabetic nephropathy, dialysis, all right, foot deformity, and also the usage of nicotine and cigarette smoking. This also causes a lot of problems, especially hypoxic feet and toes, and that's when you end up with a problem. If you look at diabetic foot inspection, diabetics are vulnerable to infection of the feet, which can be more severe than they appear. So you should examine your feet daily for any injury or signs of developing infection. So look at the redness, look at warmth, look at swelling, look at pain. Okay, so some of the things they talk about is rubor, tumor, color, dolor, punctulasa. That means talking about basically inflammation. It was mentioned by Celsus before. So it's very important. And it's what they call diabetic foot syndrome. So diabetic foot syndrome will have signs of inflammation. So you don't walk 10,000 steps, you cut it down to only 5,000 steps. If you look at this, basically, this is a normal foot, all right? And this actually is what we call this diabetic foot itself, all right? You can see the blood supply is not so good, okay? So some of the symptoms are basically, they have the same thing. You're talking about when you look at diabetic foot, it's redness, warm or swollen feet. You can have a break in the skin or discharge. They can have itchiness, dryness because of autonomic neuropathy, pain and stiffness, especially your gastrocnemius and also your tendon Achilles can be stiff. They feel unwell, they can have ulcers, blisters, they can have sore feet, you can have paresthesia and all these things. Like this is a blister basically in the feet. Here basically you got a callosity and a neuropathic ulcer after you start debriding the callus. Here you need to feel the pulses because patients are actually having what we call as gangrene. So it's grade 4 Wagner's classification, or you can even say grade 4 what we call as Texas classification, or grade 3 with 3C basically because of ischemia. Now, if you look at this Texas classification grading system, they've got 0, 1, 2, 3 basically, and then after that you have got stages. The stages is A, no infection or ischemia, B, you have infection, C, ischemia, and D, infection and ischemia. And the stages are important to show what they call that, how badly the foot is actually infected and how is the prognosis. If you follow this, we actually what we call is comparing the Wagner classification or the Megid-Wagner classification against the Armstrong. Now, the Armstrong classification or the University of Texas classification for San Antonio, Texas, is now the approved classification under our CPG guideline that was launched in 2019. Now, if you look at this, basically, you can see the Wagner classification just gives you the depth only. Meanwhile, what we call is the Armstrong classification is the depth plus also the staging, whether there's any infection, whether there's any ischemia. So that's important for prognosis. And then there's the other classification looking Wi-Fi. Wi-Fi is wound. That means whether it's an ulcer or the gangrene, a small ulcer, deep ulcer, extensive ulcer, 0, 1, 2, 3. And then you have ischemia where you look at toe pressure. Anything below 30 millimeter mercury is grade 3. And then you got foot infection, whether it's non-infected, mild, moderate, or severe. So this is Wi-Fi. Okay, W-I-F-I. This is a study that we did on 340 patients in HKL, where we looked at what we call is diabetic foot ulcers. A lot of it basically a plantar aspect ulcer, 51.8%, and forefoot ulcers were quite common compared to what we call this midfoot and hindfoot. And if you look at this, the prevalence of infection was about 41.5%. All right, and these patients basically, when they have got fasting blood glucose, high fasting blood glucose, or even high blood pressures, or even the ethnicity, whether they're Malay, Indians, or even when they have got larger ulcer size, it takes longer to heal. So you must manage the comorbid conditions. You must see whether how big the ulcer is, and also see whether infection is there. And there's many, if you look at the pathogenesis, basically, number one, neuropathy. Somatic neuropathy, where you have decreased sensation, you get insensate feelings, insensate feet, and you get decreased proprioception. Now, this can actually increase the foot pressures. If you look at motor neuropathy, the limited joint mobility, muscle wasting, foot deformities, that you end up with increased foot pressures. If you have autonomic autosympathectomy or autonomic neuropathy, you have absent in sweating, dry skin or callus, and fissure formations. You can have altered blood flow regulation, distended foot veins, or even warm, hot feet. And they end up with foot ulceration. In vasculopathy, it was 10% when I was a medical student. Now, basically, it's about 40% where they end up with ischemic foot. And you got immunopathy. Diabetes itself is an immunocompromised condition itself. So this is important for you to check. And look at cholesterol levels, and also if the patient is smoking. You need to actually cut all this down. So if you look at that, polyneuropathy is one aspect. And then you have got trauma coming in, basically causing it to have ulceration on the very proper footwear or not footwear. And then even when you have all these absence of pulses and you've got arteriosclerosis and atherosclerosis, the patients end up what they call is with gangrene, and they can be further, and it can further deteriorate with infection on board. This is macro and micro angiopathy. So in macro angiopathy, you look at atherosclerosis, or that patients have ischemia, and then you've got many factors, abnormal immunity, you've got triggering factors like trauma, deformities, and all that, which can cause injury. And then you've got micro angiopathy, whereby they can have what they call this AV shunting, they can have edema, and infection can aggravate all of this. So one of the assessments you do is triangular wound assessment, looking at the wound bed, age, and the peri-wound skin. This was in 2015. And we have the Hare Krishna peri-wound skin classification. This actually came out in 2015 and was actually published in 2018 and 2020 in a validation trial also. So 0 for normal skin, 1 for at-risk skin, 2A is basically desiccation, B is maceration, C allergy, and 3 basically with inflammation, and 4 infection, and 5 atypical wounds, where they can have cancer. Because chronic wounds can actually become pre-cancerous or even cancerous itself, basal cell carcinoma and even squamous cell carcinoma. And you can also have senescent cells, you can also have subcutaneous emphysema. Now, this is a validation trial that was done in 2020, and this is a 50-patient trial we did 2018, where this what do you call things have been published. And now there's 4 papers basically on this what do you call that peri-wound skin classification itself. Now, since you're doing everything virtually, I show you Maldives virtually. I've been visiting Maldives every year for 4 years to actually train the surgeons on that, so they're in regards wound care. Now, if you look at tips and tricks, number 1, when you triage patients, you're looking at diabetes itself. So there's an increased risk of mortality from COVID-19. And then you find out whether it's actually limb threatening or not. So look at the Infectious Disease Society of America's grade 3, grade 4. All right. And these patients now we're actually decentralizing them. We actually do some of these cases basically at home. We have got home nursing free under the Malaysian Society of Wound Care Professionals. So we did about 1,800 cases last year and 3,350 dressings this year. All right. This actually is on the Diabetic Foot Society of India. And if you look at complaints, they can come with foot pain, erythema, swelling, or even foot ulcers. All right, something like this. And what you do is, if patients coming in breathlessness, fever, tachycardia, rule out sepsis. It also could be due to COVID-19, but it also could be due to sepsis itself. So refer to a hospital with a ICU facility. And if patients come with pain, all right, without active wounds or all that, it could be ischemic or it could be neuropathic. Ischemic, acute limb ischemia and all that, please refer to the vascular surgery as far as possible. If chronic limb ischemia, you have to assess and also get the vascular limb. Neuropathic, basically, the evaluation is important, and rule out ischemia, reassurance, and foot care advice is important. Now, if there's erythema, it could be infection, it could be inflammation. If mild to moderate, oral antibiotics. If severe, you need a diabetic foot specialist prevention. Swellings also can be because of actic sharp coats, whereby a diabetic foot specialist consultation is important. Or it could also be due to what we call is cellulitis. So cellulitis, if mild and non-purulent outpatient management with all antibiotics, if moderate or severe and non-purulent, admission, systemic antibiotics, and limb elevation is important. So the proper way of doing this basically is looking at the types of what we call that infection and how it's actually affecting the feet. Now, if you look at this under the management of patients with wounds, IDSA class 1 says uninfected. So foot care advice. Mild infection, all antibiotics, foot care advice. If class 3 and 4, then basically, yes, you need a diabetic foot specialist consultation, you need a referral to a hospital with the ICU facilities. So clinical appearances, you look at the site, you look at the size, you look at the edges and walls, 4 types, whether it's inflamed, indurated, covered with slough, or healthy in color, and look at the types of exudate and the state of the surrounding tissue. Look at what we call this necrosis, look at the depth, look at whether there's any infection or anything, or whether any slough, all right? And then you look at what we call this smell, you look at granulation tissue and also epithelial tissue, all right? So all this is important when you assess the patient. Look at the stages, whether it's spreading or extending active, or whether it's stagnant, or whether it is healing. So wound cleansing is primary objective is remove the foreign material, reduction of bioburden, and reducing exudate and odor. So that's important. And you can use distilled water for clean wounds. You don't use normal saline because you can go Pseudomonas and MRSA. You can use Betadine, which is diluted PVPI, all right, 2.5% dry powder spray, 10% is a solution of that, so it's much better. Octane dihydrochloride or octanisan octanisep. You can use PHMB with betaine, which is Pontosan. You can use superoxidized solutions such as hydroxyl dermacin, nanocopper, and also hypochlorous solution. If you look at debridement, the next step after assessment is cleansing. After cleansing is debridement, whether surgical debridement, mechanical debridement, autolytic, enzymatic, biological, you've got ultrasonic debridement, you've got hydrostatic debridement. Okay, so all these are available basically in HKL. And debridement is what they call as a gold standard surgical debridement basically. And these are all the papers for that. And if you look at bedside, we can even use hydrostatic debridement using water to debride versus jet device. All right. Only thing the handpiece is a bit expensive. One handpiece is about 2,000 over ringgit. If you look at the surgical side, orthopedic, vascular, general, and plastic surgeons, all them will be actually operating a lot of cases in terms of debridement. And if you look at this King's College is saying diabetes with active foot disease. If it's non-limb or no limb threatening, we can actually see whether it's uncomplicated or whether it's repeated, and we can treat accordingly. Some even basically through telemedicine communication. But if limb or life threatening, you must see whether it's severe infection, or is it severe ischemia, or is it sepsis, or is it acute limb ischemia. So each of it has to be managed urgently in a proper hospital setting. So treatment and management strategy involves tight glycemic control, investigations, your IBC, exercise sedimentation rate, C-reactive proteins, X-rays, culture sensitivity, better not to do swabs, better to do tissue biopsies and also bone biopsies. Cleansing and dressings are important. You've got many types of dressings. It maintains hydration, moisture-sensitive dressings, manage exudate and bacterial burden. Mechanical therapy like padding and offloading is important. That's a standard of care. Surgical treatments such as IND, debridement, and amputation, where you require it, and advice. So all of this requires teamwork, basically a multi-thread team approach. If you look at biofilms, basically, so chronic wounds are a battle worth fighting, because why biofilms are present in at least 78% of chronic wounds. Previously, it was 60% in chronic wounds and 6% in acute wounds. Now it's up to about 78%. And if you look at what you call it, biofilms, they actually are in the defense mode, attack mode, and recovery mode. So you need to manage them well. So biofilms, chronic wounds, you can see here basically in a biofilm challenge of a wound count with a scab, you can see here it shows a formation of aggressive Pseudomonas aeruginosa biofilms. And you have to use dressings which can be left in situ for several days. So we have 5 books on wound care dressings and other modalities. And there are many types of dressing, whether it's semi-permeable polymeric membranes, whether it's hydrocolloids, hydrogels, alginates, polyurethane foams, hydrofiber, charcoal, silver dressings, polymer, and collagen dressings. So in this particular case, you can see gangrene, you can see what we call this pressure over the area and then causing what we call this blockage. This is a central plantar space abscess. So and then another patient, basically, you can see Charcot's foot. Charcot's foot, basically, the Lisfranc joint is fused, all right, in the cuneiform and the, what we call it, metatarsal. So this is the earliest radiological signs. Like here, you can see it's like a bag of bones. So you got acute Charcot's, whether it's, and you have chronic Charcot's, whether it's forefoot, midfoot, or hindfoot Charcot's, like this. So you need a proper rocker bottom shoe for these kind of patients. So at risk foot, you can got ischemia, you got numbness, you got structural deformities, you got callosity or corns, you got absence of pedal pulses, a problem with the capillary refill, let's say it's in excess of 3 seconds, limb pain or paresthesia, intermittent claudication, history of foot ulcers, loss of sensation of light touch, sharp and blunt touch. So all these have to be assessed. So one of the important things is do foot care health education, basically examine the feet and all that, and also make sure don't dip your leg into the hot, what you call this, water and all this, because it's not very hot, it's only about 40 degrees Celsius, and there might be bacteria inside there. Bacteria is not disinfected. And then food assessments are important at least once a year for those who have got normal diabetics and all that. These are the radiological food assessment tools. Basically, your tuning fork, 1 to 8 hertz, your monofilament 10G, neurotape, and cotton. You need to do your vascular assessment with Dopplers and all that. This is where you wear PPE during, especially when you have got what you call it, COVID patients and all that. That's important. This is the Twin Towers, showing HKL here. Now, mega debridement therapy, all right, that's very important to actually devitalize tissue and all that. So we use Lucilia cuprina from the Institute of Medical Research. Like this case, basically, you can see very, very cheesy material. When you put the megas, become 7 or 10 times normal size, 1 centimeter square, 10 megas, and the wound is better. This is another patient, same thing. We incised the patient was supposed to have a raised septation, but I incised it and there was through and through what we call this hole. And finally, what we call this, we debrided and all that, and we actually saved the foot. Okay. This patient, we use what we call this hypochlorous spray, and you can see the wound closed up. This is another patient where we use a bioelectric dressing. Now, bioelectric dressings are dressings with zinc oxide batteries, flat ones basically. You can't feel them very well, and they've got silver also basically. You see the wounds healing very well. They come out with electrical current. Now, this wound cream is something, it's like a topical organic ointment where you can apply, where you can actually deslabs and all that. It's got honey, it's got beeswax, it's got a few other things inside, lanolin and glycerin and all that. So it helps to moisturize. It's coming from the Amish group in the US. Right? You can see now beefy red now basically the wound. And then you also have got modified collagen and glycerin basically when used for this patient. Within less than a week, the wound closed up. And then we have got topical oxygen therapy, basically, which is available now. And these are the consensus that I was involved with, basically in the UK. It's like this patient every foot ulcer, within 41 days, the wound closed. All right. So it's just slightly more than a month by using topical oxygen therapy. And then we have Domaxan spray, mangosteen spray, which is being approved by the MOSTI, and all that. You can see the wound clears up. It's a very good antimicrobial dressing in terms of a spray form. So this is actually using collagen and glycerin, and also what do you call this, a polymer basically. And you can see the wound healing well very fast. We also have lasers now, photobiomodulation, low level laser, K lasers also to have this adjunctive therapy, and we published about 2 papers on that. And also we have got what we call that dressings, which can help in terms of prevention or reduction, because what we call this, we have got collagen sheets and all that, which you can actually apply on the wounds, and the wound starts to close up. So these are some of the dressings that are available basically in our place. We also got what we call this honey in 2 dressings also for this cancer patient, if you publish in BPI. You can see the difference. Proper wound bed preparation with beefy rate thing. Hydrotherapy leeches to actually reduce the swelling and pain and all that. So that's really important. There's a study now basically. We're using Hydronaria meninensis. So the foot care guide is important. The 9-step daily foot care guide for people with diabetes. You must actually teach people how to look after their feet. Trimming the diabetic toenails are important. Foot care and footwear benefits are important. So with that, try to take your leg for a holiday. This is actually from the Indian Diabetic Foot Association, where we actually met them in 2004. And it's important to actually look after your feet. It's a very nice slide where you actually look after your feet. So with that, thank you very much. Take care, stay safe. God bless.
Okay, thank you. Yeah, thank you, Prof. Dr. Haris Krina, delivering such informative lectures from the assessment of the diabetic foot and types of the diabetic foot complication, as well as different methods of the management. So, but unfortunately, due to the time constraint, we cannot accommodate any live questions and answer. Please revert your questions and answer to our PGMES email. We will direct to the respective panel. So thanks again to our 3 distinguished panels, Dr. Haslina, then Dr. Ching Cheng Hua, as well as Prof. Dr. Hari Krishna. Now I would like to invite Dr. Rafati as a chairperson for the next symposium. Thank you.
Thank you, Dr. Tan Inje. Good morning, ladies and gentlemen. It's me again. I will be the chairperson on the next symposium for the topic obesity. It is with great honor for me to introduce our first distinguished speaker for this symposium, Dr. Masni Muhammad. Dr. Masni and I go way back since my days in Putrajaya, and she has always been an inspiring person and a very respectable figure in endocrine fraternity. Dr. Masni Muhammad is a consultant endocrinologist at the Endocrine Unit Hospital Putrajaya, where she has served since 2004. She obtained her MD in University Science Malaysia and proceeded to do her master's in internal medicine in University Kebangsaan Malaysia. She completed her subspecialty training in endocrinology from University Kebangsaan Malaysia too. She is actively involved in research and teaching. She is an honorary lecturer for UiTM Undergraduate Medical School and UKM Master's Program. She is also a trainer for endocrine subspecialty program under the Ministry of Health. Her area of interest include obesity, diabetes, thyroid, and parathyroid. She is currently in charge of the multidisciplinary team obesity clinic in Hospital Putrajaya. She is also the vice president of the Malaysian Endocrine and Metabolic Society, and she is an active member of the Endocrine Society with a professional role of clinical practitioner since 2010. She is indeed the best person to talk about this topic. Please welcome Dr. Masni. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Thank you, Chairperson, for the kind introduction. I'm Dr. Masni Muhammad, consultant endocrinologist from Hospital Putrajaya. Thank you. Before I proceed, I would just like to thank the organizing committee of this biennial 12th Biennial Scientific Meeting of Postgraduate Continuous Medical Education for inviting me again. Yeah. So it's an honor to be here, even though it's virtually. So in this obesity symposium, I'll be talking on prevention of obesity. Preventing obesity is mandatory because obesity has become an epidemic worldwide. I will be covering on these few topics: objectives, the trend, the prevalence worldwide and Western Pacific and regional. So what are the issues presently? What are the obesity complications? Asian are definitely higher risk at lower BMI. What are the prevention, primary, secondary, and tertiary prevention? What are the benefits of early intervention for this prevention? So what the steps taken from, we can learn from China prevention and other countries. So what are the worldwide prevalence of obesity? In 2016, global prevalence of worldwide world obesity showed 1.9 billion world adult more than 18 years old and older are overweight and obese. So out of this 1.9 billion, 650 million are obese, defined as BMI more than 30. So they estimated by 2025, what the numbers will be. In 2025, the prevalence of overweight and obesity is estimated to be 2.7 billion. And of this, 1 billion will be obese. 1 billion is obese. And out of this 1 billion, 177 million are severe obese, defined as BMI more than 35. So why don't we go to region, according to the region, Western Pacific region, where Malaysia are included in the Western Pacific region, China, Australia, or Australasia, yeah, all those Pacific islands. So of course, Tonga, Cook Islands. So I think about more than 70, about 80% of the population are obese and overweight. Yeah, obese are so huge. But China, looking at China, Malaysia, comparing to Malaysia versus China, New Zealand, and Australia, the numbers are increasing. Malaysia are in between Singapore versus Australia, yeah, but still it counted to 50%. The gray color is overweight, the black color is for the obesity. So looking at the Southeast Asia country, so these are the Southeast Asia country, so Maldives, Bhutan, Thailand, Sri Lanka, Bangladesh, Nepal, and Timor-Leste. So the numbers are slightly lower, but still it's the trend are increasing, yeah. The trending, the highest is still Bhutan. Zoom in to our beloved country, Malaysia. So the numbers within this 1 decade is increasing. Obesity, the obese is increasing. Overweight is about there, but total number of overweight and obesity is 50.1%. So if you walk around in the mall, 1 in 2 of you are overweight or obese. What are you in? Please measure yourselves. And abdominal obesity are definitely increasing. So what is so important about this abdominal obesity? It reflects your visceral adiposity. So Asian female should be lower than 80 centimeter. Male should be less than 90 centimeter. So if you are more, so you have abdominal obesity. So it reflects your visceral adiposity and it increases the metabolic complications for you because of the insulin resistance. Right. So looking at the gender, female are higher compared to male. Similarly found in children and adolescent obesity, about 1/3 of our children and adolescents are overweight and obese. So it is a serious health concern, reason being because 80% of these children and adolescents are obese, 80% of them will become an obese adult. Yeah? So we have to prevent them much earlier. So the current issues or the current problems about obesity, so lack of awareness among the public and healthcare professionals of obesity as a disease, whether it can seriously impact health. So lack of this awareness, our Asian food culture and addressing obesity can be politically sensitive, lack of medical education of obesity, be it at medical student level, be it at nursing school or at medical assistant syllabus. So there's nothing being stressed about obesity education. Number 4, no advocacy within government to make obesity a priority area for public health funding or resources. Lack of consensus obesity definition, lack of healthcare professional trained in managing obesity in community level, and meaning they keep on referring to the specialists, so overburden of work to the specialists mainly. Limited therapy. Pharmacotherapy is for obesity is limited, but even is available, it is costly and out of pocket cost, which impacts compliance. Limited structured research on effective interventions, and the stigma is not addressed. Further increase health inequality in person with obesity. So why do we need to prevent obesity? Mainly because of the morbidity and mortality in obesity, secondary to the medical complications of obesity. So if you want to see the complications easily put, obesity affected from head to toe, or every organ is affected by obesity. In this slide, I divided into mechanical complications, metabolic complications, and others. Mechanical complications such as gastroesophageal reflux, lung function defects leading to OSAS or obstructive sleep apnea, hypoventilation syndrome, osteoarthritis, be it prolapse intervertebral disc, hip osteoarthritis, knee osteoarthritis, LUTS, lower urinary tract symptoms. Cardiometabolic complications, mainly diabetes is the highest risk related to obesity. On top, besides that, heart failure, cardiovascular disease, coronary artery disease, non-alcoholic fatty liver disease, becoming more and more, and the causes of it causes hepatocellular cancer, polycystic ovarian syndrome, dyslipidemia, and hypertension. Others are related, such as cancer, infertility, female infertility, male infertility, gallbladder disease, psychological disorder, and stigmatism. So in this meta-analysis done about 10 years ago, though this is 10 years ago, it's still very relevant up till now. This meta-analysis showed the BMI related to disease. So the highest disease that related to BMI is type 2 diabetes. It's so proportionally high. The confidence interval is so high in male. The chance of the confidence interval 6.74 relative risk, and for female 12.41 relative risk of getting diabetes with a BMI more of 30, just BMI more than 30, followed closely by pulmonary embolism, congestive heart failure, and hypertension, coronary artery disease, and also stroke. Cancer, that is so high. The cancer in female, the highest is endometrial cancer, colorectal in both gender. Breast cancer postmenopausal is also significant. Other cancer is kidney cancer, and also pancreatic cancer is high in for both gender, right? So cancer is, by the higher your BMI, the higher risk of you getting all this cancer. Asthma, gallbladder disease, osteoarthritis, and heart failure is also relatively high. So what drives obesity in Asian region? Genetics, but mainly it starts with urbanization and globalization by transition of food, fast food, so high calorie dense food from this globalization. So sedentary lifestyle from urbanization. Our social cultural factors celebrate with food, so it all boils down to, it drives the obesity. On top of that, the genetics and the phenotypes make it worse. So in Asia, significantly higher proportion of people getting diabetes at younger age. This age, they get the age of 20 to 40, less than 40 years old, 20 to 40. So they see what's the percentage of diabetes in type 2 diabetes, not type 1. So it's slowly increasing from 2003 to 2013 and significantly higher in Southeast Asia region and also Western Pacific region. Why is that so? Significantly higher in type 2, young type 2. This is because of they are higher risk at lower BMI. Asian are higher risk at lower BMI. They get diabetes at lower BMI, because of the higher visceral adiposity in Asian population. So this is shown as in recent papers by Chalaya Chiti. So in South Asian, that is from the Southeast Asian region population ethnicity. So they get diabetes at BMI of 23.9, 23.9. For the Chinese at 26.9 compared to the Caucasian, which is at BMI of 30. So that's the reason why we are higher risk. Asian are significantly higher risk at lower BMI. So how to prevent this? Start from primary prevention, secondary prevention, and tertiary prevention. So primary prevention defined as minimize the weight gain or prevent obesity from developing in the first place. So it has to be at population level intervention. So primary prevention is the most cost-effective option for addressing obesity. So start with, of course, it has to be public health measures. So public health measures from government, so to the law, to the acts, So act, what I mean, when it comes to eating, dietary, so promote from public health measures, promote healthy eating, tax to the unhealthy food and beverages, calories, start with calories on menus, do nutrition labeling, and put a star on healthy food, and all this labeling. Healthy food programs and subsidize the healthy food, limit the unhealthy food and beverages production, and limit the sale and advertisement of this unhealthy food, especially to kids. So what about physical activity? On primary prevention, increase and improve the walkability of the built environment, such as the footpath, increase the bicycle lanes, public sports venue. So other primary prevention, we know that in every pregnancy, women gain weight. So we can start preventing them at this point, at that point of level. So reduce the gestational weight gain if they are overweight or obese, and postpartum weight retention, try for them to prevent them from gaining weight. We know smoking cessation causes weight gain, prevent the weight gain during when they want to stop smoking. Young adults, when we know young adults, they tend to gain weight during that period because of puberty and sedentary schooling. So we have to intervene because at that level, because we know this adolescent and children obesity, they will become adult obese. So how can we prevent at that point of level? Prevent at school level, school meal program, increase school program activity. We know menopause cause weight gain, so prevent at that level also. Certain medications cause weight gain, so I'm sure there are many alternatives for weight loss, antipsychotic, for diabetic medications also, and also for antidepressant. What about secondary prevention for obesity? Secondary prevention aims to reduce the impact of obesity that already has developed, so we want to reduce the impact. So the intention is, what are the plan? We have to detect early detection, and treat the obesity as soon as possible. The aim of secondary prevention is to return the obese patient to their original health and functional status to prevent long-term complications. So such as try to stop, so meaning they are already overweight and obese, try to prevent further weight gain. So we have to catch this kind of group. How to catch them? By doing obesity screening at clinic level, or clinic primary care level, or community level, or school level, university level. Get them to do obesity screening, measure their BMI, their waist circumference, diagnose where they are, prevent them from gaining weight, and treat at population or community level. Yeah. So, by doing, we want to implement this. We have to train personnel, school personnel, medical school or medical personnel or community personnel on how to do this, on how to detect this. We have to incorporate this training during the school level, at the nursing level. Yeah, all right. Okay, so we have to do some training to start with secondary prevention. So what are the secondary prevention that we can do to in order to detect early and to prevent them from progressing? Yeah, avoid any stigmatization, evaluate once they have that overweight or obesity, evaluate their eating disorder, their stress level, their depression. So we have to intervene at that level, treat with behavior modification, nutrition, monitoring, monitor themselves, eating behavior, physical activity or inactivity. We treat that level. We have to increase the physical activity by patient education. Increase your patient motivation by using motivational interviewing. So hence the importance of self-weighing because self-monitoring. Tertiary prevention of obesity. The tertiary prevention aims to soften the impact of obesity from ongoing, the illness or the injury, from having lasting effect. So synonymous with weight loss and long-term obesity management. So often this is a complex health, they have complex health problems already. So usually long-term management for person with obesity, once they have the obesity or the overweight, they have metabolic disturbance. So we have to detect the metabolic disturbance, screen the metabolic disturbance and comorbidities, and treat them with lifestyle modification, pharmacotherapy, right? Or may need bariatric therapy, bariatric surgery. So usually when it comes to tertiary prevention, the treatment should be done by multidisciplinary team. So early intervention is very important because the benefit is much more compared to late intervention. Once patient is obese, of course the intervention may have definitely there are benefits, but at late intervention, if they are already adult, the benefit is limited. If we intervene at motherhood or infant or during childhood, we prevent them from becoming adult obese, the early intervention will have more significant potential benefit, especially when they are children. So if they are already adults, they have obesity, any intervention, any weight loss, be it 5%, have benefit, have medical benefit. So let's say for 10% weight loss, in a metabolic syndrome person, that can prevent type 2 diabetes. For 5 to 15% weight loss in a obese type 2 diabetic, that will reduce significant A1C, about 1 to 2% of A1C, and can induce a diabetes remission, even though for a short duration, 2 years. For 5 to 15% weight loss in a patient who has dyslipidemia, that will reduce triglyceride and also LDL and increase high density lipid. For 5 to 50% weight loss also in a hypertensive person, that will significantly reduce systolic and diastolic blood pressure by 3 to 5 millimeter mercury. But for non-alcoholic fatty liver disease person, obese with non-alcoholic fatty liver disease, by 10 to 40% weight loss, significant reduction in intrahepatocellular lipids and inflammation that will reduce the chance, the progression to hepatosteatosis and also liver cirrhosis. In a person obese polycystic ovarian syndrome, 5 to 15% weight loss, increased ovulation, reduced androgen levels, reduced hirsutism, and increased insulin sensitivity. In an obese sleep and OSA person, by 7 to 11% weight reduction, reduced AHI index. In obese asthma person, 7 to 8% weight loss, improve their forced expiratory volume 1, and also improve GERD. Yeah. All right. So that is so significant. Metabolic and medically improve with weight loss. But in the long run, for the government, with this obesity-related comorbidities, with that weight reduction, so they have estimated in Mexico 5% decrease in BMI, so they will save USD nearly about 117 million. So in Europe, they estimated with that about 10% with reduction of that BMI, estimated to be reduced about 10% reduction in cardiovascular. Saving in US about 611.7 billion. It will be saved because of this reduce in medical costs. In Australia also, with that BMI reduction, with BMI of 1.4 only, so they estimated about 30% lower direct medical costs. So not only health improve, cost saving to the government also. So, but there are barriers to clinical, there are barriers. So easy said than done, because the barriers are mainly from us, healthcare professionals, because of lack of understanding, poor healthcare professional communications, because the limited availability of treatment, pharmacotherapy, insufficient reimbursement, right? So in the end, person with obesity that suffered. From a study showed, there's one study showed about 55% person with obesity receive a diagnosis, only 55% receive a diagnosis. So because of that, there will be only this half of them get access to pharmacological and surgical intervention. 46% PCP said they only follow up this person with obesity occasional only, and 11% of PCP never follow up patient with obesity unless they raise the issue. So any steps taken, what can we learn from China, from Asian? So steps taken from Asian in 2015. So they come up with, they identify that nutritional transition resulting in unhealthy dietary patterns have increased the risk for development of non-communicable disease and obesity. They admit that. So they declare on the reformulation and production of healthier food and beverage options that was published in 2021. So they have come up with 7 priorities, so that the detail can be read from the that agenda. China is a big country, so they come up with their own prevention because their obesity trend is increasing. Okay, so they come up with the macro, the meso, and the micro plan. The macro, it involves the government, the intervention program, prevention policies, national provisional food policies, healthcare policies, the social culture and norms. They come up with that legal regulation system also to approach to prevent the obesity. So the meso, smaller family program, school program, community program, healthcare program. So but when it comes to micro, it's individual. So how to treat individually the patients, the energy balance, so what are researchers, any genes, all right, okay, so they have come up with this systemic approach, a framework to prevent obesity in China. So it should be a focus, preventing obesity, it should be a focus. Do we have any results from other countries? Yeah, so this paper published in 2017, showing the trend of childhood and adolescent obesity. We can see that some countries showing a plateauing of BMI, plateau, not reducing, not reduce, a plateauing. Yeah, so mainly in countries that developed countries, the northwestern Europe, the southwestern Europe, and also high income Asia Pacific. They see if you can see, it's plateau, it's not increasing like other countries. Yeah, so this in females, and similarly seen in male children, adolescent. So the plateauing of children and adolescent BMI in these high income countries, yeah, which will relate later on in adult, so they will not become obese adult, okay, because of the specific initiative they started by the government, community, schools. Yeah, they have started because why they have started, because they have increased public awareness about the overweight obesity, so leading to changes in nutrition and activity to curb this obesity increase. So what about Malaysia? So I borrowed these slides from Dr. Faizul Mustafa. She is our NCD person in our ministry. So these are the current approaches to NCD from birth to tomb to prevent non-communicable disease. Obesity is included, right? So it started first from birth to tomb. Why from birth to tomb? Because the first 100 days of the child. Okay, so mainly to reduce the obesity and NCD. So start with pre-conception, that they have a Jom Mama initiatives, intervention package, health promotion during pregnancy, before and during pregnancy. So when it comes to infant, toddler, preschool, so they start the first 100 days to prevent obesity. So the garis panduan pemasaran makanan dan minuman kepada kanak-kanak, there are garis panduan penguatkuasaan larangan penjualan makanan minuman di luar pagar sekolah and once they become the school age, at the school age years. Yeah, garis panduan pengurusan kantin sehat, yes, they do have that. It is being implemented currently. So what they have that BFF, body fit and fabulous program at school setting, but it's not ongoing, as stopped. COSPEN also has stopped. Yeah, okay. Going to the adulthood, higher education, adult and elderly. So at clinic kesihatan, they has certain activity physical for program. At the same time, program warga active, warga productive, right? Healthy workplace for healthy workforce, amalan pemakanan sehat, hidangan sehat semasa mesyuarat. Yes, I'm not getting any snacks during mesyuarat, which is good. Cafeteria sehat, you will notice a restaurant, they have ABC labeling, yeah. Garis panduan pelaksanaan vending machine makanan minuman sehat dalam perkhidmatan awam. So this the one that I managed to get, yeah, they are being implemented at present and some are not, yeah. So in conclusion, ladies and gentlemen, obesity is increasing, has tripled since 1975 and has become an epidemic. So it is scary. So we have to start from ourselves, and within our family, then to our workplace and community. So the current state of affair, lack of awareness is still rampant, lack of awareness. So whatever knowledge, you have to start, increase our knowledge and pass the knowledge to our community and our friends. Obesity complications is a real thing. So do screen yourself, screen our patients, start screening our patients. Primary, secondary, tertiary prevention, as I mentioned just now, we have to start preventing from our clinic level. So early prevention is important. With that, I thank you.
Thank you very much, Dr. Masni, for a very comprehensive lecture, as always. Now we're going to move on to the next topic, which will be presented by Mr. Yeo Zixiang. Mr. Yeo Ziziang graduated from University Malaya in 2008 and obtained his master's in otorhinolaryngology from the same university in 2019. He has been involved in multiple research work and publications. His ongoing projects area include outcome of multidisciplinary approach to endoscopic decryocystorhinostomy procedures and allergenic status for rhinitis patients. He is currently an ENT specialist in Hospital Sultanah Bahiyah. Please welcome Mr. Yeo.
Hello, good afternoon, everyone. Ladies and gentlemen, fellow attendees of 12th PGMES Biennial Scientific Meeting. My name is Yeo Zhixiang. I'm an ORL surgeon in Hospital Sultanah Bahiyah. First of all, I would like to thank the organizing secretariat for inviting me to share today the topic on obesity and obstructive sleep apnea. It is actually an honor to be in the same panel with some of my teachers here today. First of all, for disclosure, I have no relevant financial or non-financial relationships with any companies that I'm going to tell you later. And the presentation is for academic discussion. This is the outline of my lecture. And first of all, we would like to discuss why do we need to bother about obstructive sleep apnea. So obstructive sleep apnea is actually a continuum from very quiet sleep to intermittent snoring to upper airway resistance syndrome, and then on the other extreme will be the obesity hypoventilation syndrome. So what happens in OSA is there is repetitive upper airway narrowing and closure during sleep, and this causes intermittent hypoxemia and hypercapnia and frequent cortical arousals. Therefore, it also stimulates the acute and eventually chronic inappropriate sympathoexcitation, and it accentuates free radical formation and incites chronic inflammatory response on the body. So, Eckert et al. Further suggested phenotypic traits for OSA, whereby the subject would have collapsible airway, no doubt, but it is also affected by low arousal threshold in relation to the cessation of airflow, poor muscle responsiveness to the hypoxemia or hypercapnia, as well as high loop gain in terms of the ventilatory response. So he showed that, of course, 100% of OSA patients has impaired anatomy, but they have variable magnitude and it is influenced by all these non-anatomical factors as mentioned here. So why bother OSA? So of course, first of all, they may have some domestic issues with their bed partners, but more importantly, in daytime, the OSA patients will be very sleepy and they are prone to crashes such as motor vehicle accidents. And secondly, the danger comes from the sequelae of obesity as well as other metabolic diseases that comes together with OSA. So back to the topic, obesity and OSA, they have bidirectional relationships. Talking about the numbers, the adult population is estimated to have 9 to 38% prevalence of OSA. Higher in men, elderly, and of course, even higher in obese subjects. So in industrial countries, it is estimated about 60% of the adult population is overweight and 30% of them is obese. Let's see what us, Malaysia, is doing. So we are here and we rank 123 according to World Obesity, which is actually a body by WHO to raise awareness and action on obesity being an new emerging threat. So 13% of our population is deemed obese. Closer to today, in 2019, there is this National Health and Morbidity Survey showed, surprisingly and perhaps not so surprisingly, 1 in 2 adults in Malaysia were overweight or obese. As you can see from the diagram, 30% of our population is overweight and 20% are obese. So, and this is also seen in children and adolescents, and another 15% of adolescents are overweight and 15% of them are obese. Worse still, 1 in 2 of adults in Malaysia had abdominal obesity pattern, which we know from medical textbooks that this is associated with a lot of major morbidities. So this busy slide showed the interaction, which is complex by nature, as in any other disease, a nature versus nurture kind of situation, the interplay between genes. And so we see obesity causing sleep apnea by having this adipose tissue deficit surrounding the airway in parapharyngeal area. Abdominal fat deposition reduces the mediastinal traction on upper airway, causing less stable airway during sleep, as well as the proposed leptin resistance, causing neurophysiological ventilatory instability in patients with obesity. So a 10% weight gain actually leads to 6 times higher OSA progression risk. Whereas on the other direction, sleep apnea itself is also said to cause obesity. Okay, so by number 1, these patients invariably big size, so they might have these OSA patients have this excessive daytime somnolence, and then they might have arthritis, so making them a bit difficult to move about to do physical exercise. Also, sleep apnea mimic sleep deprivation in the sense that it causes those patients to have poor dietary habits. I'm sure some of us can testify when we have less sleep during on calls, for example, then we get cranky and we crave for fine carbohydrates. Okay, so in OSA patients, ghrelin, which is our craving hormone, is increased with leptin resistance has been described in literature. In OSA, there is also less delta sleep, and hence there is also associated insulin resistance, reduced renal function, and the body in chronic systemic inflammation effect. Not to mention, there are some side effects from the medication given in sleep apnea patients, such as antidepressants with side effects of obesity. So treating sleep apnea can mitigate some effects of obesity, either directly or indirectly by having a better sleep, less sleep deprivation, endocrinopathy. So how do we diagnose OSA? So as in any other disease, we'll start from history. So basically there are 2 groups of history, the nocturnal symptoms as well as the daytime symptoms. So the nocturnal symptoms hallmark will be snoring and witness apnea. Together, they form about 94% specificity for OSA diagnosis. Other possible nocturnal symptoms that can be witnessed can be gasping, choking, restless sleep, frequent toss and turn. And it is very important to obtain this kind of history from the patient's bed partner where possible, because the patient simply can't tell you much when they are lacking in sleep. Daytime symptoms are very obvious. Because of non-restorative sleep, they might have morning headache, sore throat, and feel very sleepy in the daytime. And worst case scenario, they might have cognitive deficits, mood changes, as well as manifestations psychosomatically. Examination-wise, we invariably see an obese patient from BMI measurement with large neck circumference, thick short neck, increased myelopathy of Friedman's score, enlarged tonsils, and more frequently crowded oropharynx. But not to forget also some craniofacial abnormalities such as retro or micronectia can also contribute to OSA in non-obese patients especially. We can also see the effects of the sequelae of OSA in a patient, such as from hypertension, heart failure, pulmonary hypertension, stroke, metabolic syndrome, and type 2 diabetes. This is just to illustrate that there are some congenital malformations, such as Goldenhar syndrome and Treacher-Collins syndrome, that can also cause someone to have obstructive sleep apnea. There are various screening questionnaires. I'm sure you all are familiar. The Berlin questionnaire is primarily used in primary care setting, but they have high false negatives. Stop bank questionnaire is also very famous. You just need to get 3 out of 8 to be positive. However, it's very sensitive, no doubt, but they are a bit low in specificity. Epworth Sleepiness Scale is developed from Melbourne Clinic, whereby 8 questions were asked with likelihood of them to happen, and the score maximum of 24. If someone scored 11 or more, then it indicates excessive daytime sleepiness. It's just that it does not distinguish the cause for the sleepiness. So after clinical assessment, so typically in our setting, we will proceed to an office flexible nasopharyngeal laryngoscope with Mueller's maneuver, which is actually a forced inspiration against a closed mouth and nose. This is convenient, but we might miss the changes due to tone loss during sleep. Hence, drug-induced sleep endoscopy, DISE, which is essentially a sedation in OR setting using agents such as propofol, midazolam, dexmedetomidine, can mimic sleep with collaboration with our NS colleagues. So this is just to show what happened during the scope. So for the benefit of those who are not familiar, the yellow color line indicates the scope. So we'll enter through the nostrils into the nasal cavity, posteriorly down to the postnasal space, witnessing any collapse of airway, and then further down into the oropharynx, tongue base, and last but not least, the supraglottic larynx. So these are also other pictures to indicate, for example, in here, you can see a concentric collapse of the retropalatal airway. And this is, needless to say, on very obstructive airway during sleep. If for whatever reason we need objective measurements, the lateral cephalometry can be performed using plain radiographs, or if available, we can do some high-tech Cine magnetic resonance imaging MRI to evaluate the narrowed airway dynamically. Sleep study or polysomnography, PSG, is considered the gold standard test to diagnose OSA and other sleep disorders. So conventionally, we do it in a lab, in a supervised lab, and there are various sensors that simultaneously being recorded for their physiologic parameters. So this is a diagram to show the wires being plastered or with sticky tape to the patients, and then the patient goes to sleep in this way. This is the actual picture where after we have hooked up the patients in our own lab. So the sensors, of course, will feed the data into computer, and then we can see real-time tracings like this. And from there, we will pick up various respiratory events, such as apnea, hypopnea, or RERA, respiratory effort-related arousals. as evidence here, where there is drop in the flow of the nasal cannula with absent thoracic abdomen movement, which is the central apnea, followed by attempt to breathe in some thoracic and abdomen movement, which is the obstructive apnea. So at the end of the apnea, it's usually a arousal, cortical arousal, and that's where the airway opens up and the patient starts to breathe again. Okay. So we calculate the number of apnea, hypopnea, total up per hour of sleep, and then anything less than 5 is normal. But if the magic number is between 5 to 15, the patient had mild OSA, 15 to 30, moderate, more than 30, severe. You might come across a term called RDI, it's Respiratory Disturbance Index, which is also essentially AHI plus the RERA event per hour of sleep. So if we cannot cater for all patients for lab level 1 PSG, home sleep test is sometimes a useful alternative, but it is not recommended by AASM, American Academy of Sleep Medicine, for diagnosis of OSA in certain high-risk groups. This is the examples of home sleep tests. Nowadays, it's very miniature using the advantage of our own smart devices. So once we have diagnosed OSA, the options to treat OSA depends in part on the severity. It can be non-surgical managements, such as behavioral changes, nocturnal CPAP, oral appliances, and last but not least, surgery. So weight loss constitutes the major component for behavioral measure for OSA, as studies have shown 10% weight reduction leads to 26% reduction in RDI, which means every 1 unit BMI that we reduce from various measures, including bariatric surgery, can translate to 2.3 units AHI reduction. Maintaining good sleep hygiene is also important. We advise those alcoholic drinkers to avoid alcohol 4 to 6 hours prior to sleep, because alcohol itself is a sedative and will cause more muscle tone loss during the sleep and worsening the OSA. Positional therapy can be useful in certain patients, whereby we advise them to sleep in a lateral position rather than supine position, because in supine position, the tongue will fall back and obstruct the airway. So this is just an example of a tennis ball being placed on the back of their t-shirt, and they wear it at sleep to prevent them from sleeping supine. Modern devices such as such vibration device are also available. Oral appliances act by pulling the tongue forward or move the mandible and soft palate forward, hence indirectly pull the tongue forward to create a larger posterior airspace. So as you can see from the diagram, the device is worn to pull the mandible forward, and hence the posterior airway here can be larger and less obstructed. PEP therapy, positive airway pressure therapy, is the standard of care for OSA, and it is indicated for moderate to severe OSA. So a typical setting will be a blower like this, just about the size of an alarm clock, and then with a conduit and a mask interface. So essentially, the mask delivers a positive airway pressure to form a pneumatic stent, pneumatic splint, to keep the upper airway non-collapsed. Okay, these are the various available nasal mask interface. So even a patient which is claustrophobic to full face mask can also enjoy the CPAP. Application of adequate PEP therapy is always useful. It almost always resolves the OSA and increase the quality of life, but the compliance may be an issue. So failing which, of course, last but not least, we will consider offer surgery, but not as a primary therapy, okay? So the surgical procedures chosen should be tailored against the patient's individual anatomy from the previous evaluation, such as the DICE. And this is the summary of various soft tissue and bony work that we can do for the patient to enlarge the airway. So usually we start off with nasal surgery first, then various combination of all these palatal and oropharyngeal procedures. Failing which, we'll proceed to bony work, such as hyoid suspension and maxillomandibular advancement and MA. And last resort would be a tracheostomy, whereby it is the only procedure to show 100% effectiveness in treating OSA, but at a high cost to the patient. Not to forget, there is also an option of bariatric surgery, which of course I'm sure my teacher, Mr. Najmi, will tell us very well after this. So these are just pictures showing honest cold instrument tonsillectomy to fancy robotic surgery. This is MMA, showing advancement about 2 centimeters of the bony works can increase the posterior airway. And this is hypoglossal nerve stimulation, whereby a sensor sensing the inspiration of the chest wall will stimulate the hypoglossal nerve to protrude the tongue and increase the airway during sleep. So this is just to show the sleep surgery algorithm in Stanford, known as the Mecca of sleep management in our ORL fraternity in US, showing various options of surgery. I will not discuss further on pharmaceutical targets, nonetheless, because it is not mainstream, but there are potential targets in the future. So take-home message, obesity has bidirectional effect with OSA. Weight loss can reduce the effect of obesity and OSA. It is important to recognize and treat OSA early, and the tagline, exercise is medicine, sleep well to be well. And if everything else, keep calm and refer us. This is the sleep team in Hospital Sultanah Bahiyah. We have a very nicely decorated sleep lab in our 6A bed 28. Thank you for your attention.
Thank you, Mr. Yeo, for the very informative lecture. We're going to move on to the next session, which will be presented by Mr. Wan Najmi Wan Daud. Mr. Wan Najmi graduated from University Science Malaysia in 1997 and obtained his Master's in General Surgery in 2005. He then completed his fellowship training in upper gastrointestinal surgery. He is currently the committee member of the Malaysian Upper Gastrointestinal Surgical Society, MUGIS. Mr. Najmi currently works as the consultant of the upper GI surgery at KPJ Penang Specialist and also a visiting surgeon at Kulim Hospital. Mr. Najmi is going to share with us his extensive experience in bariatric surgery. Please welcome Mr. Najmi.
Bismillahirrahmanirrahim. Assalamualaikum and good afternoon to everyone. Thank you for the organizing committee and warm welcome from the chairperson today. I would like to present the topic for today, which is given to me to talk about the bariatric surgery as the surgical approach to obesity. Okay, so briefly, I declare there's no conflict of interest in this presentation. Basically, we will cover prevalence of obesity as our theme is concerned. So infirmity in this lecture is obesity itself, how we mitigate the problem, and of course, the most important part is the results after the surgery. So as we know, obesity is getting serious in Malaysia. We are the champion among, the Southeast Asia countries from so many years until now. So what is the possible causes of the obesity? We can talk about, the theory behind, and I would like to highlight about this statement, globalization of food market, whereby in Malaysia, it's very easy to find food anywhere and any point of time. So what are the true burdens of obesity? Yes, as the word itself is a very, very heavy problems, disturbing the population and our function to do our work, etc. Because it's associated with so many problems. There are few speakers talking about the morbidities, obesity, including sleep disturbances and metabolic syndrome, which are the most important part. So ideally, the weight loss program should be very effective. It's sustainable for long term. Of course, it should be safe for everyone. And if possible, something that we can do to reduce the weight must be very very effective in terms of cost and associated with low risk. So if we're talking about the ideal losing weight program, surgery is the only one component or one example of the weight loss program, whereby it's not applicable to everyone. It must be carefully selected and discussed with the patients themselves, whereby some patients they prefer to do their own weight loss program using specific drugs or supplements and control their diet, doing exercises, everything. But main objective of the program, they must have the effective, sustainable techniques with good quality of life. So if we are talking about bariatric surgery, this is not only something that very simple. You operate today and then they lose weight within 1 week or 2 weeks time. It takes a lot of efforts, whereby surgery is the only one component to reduce the volume of the food delivered to our intestine, but also comprising effective exercise, very positive mindset with strict control of your diet intake, and very importantly, they must have a very good motivation. So preparation from the beginning must be emphasized from the first visit to see bariatric surgeons. It consists of very long and repeated counseling about the benefits and the risks of bariatric surgery. And then some of us practice giving the patients who have BMI more than 40, 45 with low calorie diet around a couple of weeks before the surgery, and patient must comply to these rules and regulations, and a few other assessments such as a blood test and endoscopy to evaluate the stomach, and certain imagings like ultrasound to assess the liver and gallbladder. So there are few guidelines published about the role of bariatric surgery in managing type 2 diabetes mellitus, and Malaysia have our own expert of panels talking about the role of obesity management by surgical approach, especially bariatric surgery. And of course, the guidelines were quite some time. Management of obesity was published in 2004, and CPG of diabetes mellitus was revised in 2020. So panel of experts did mention about role of surgery in diabetic remission, and it's proven those who were operated sustain better weight reduction after few years following the surgery. And that's why the panel of experts recommend to consider metabolic surgery to control diabetes. What about the comparison with other countries? I quote these articles. They mention about grades of obesity, whereby the role of bariatric surgery was considered whenever you have diabetes with obesity. Only the class 1 we can try with the lifestyle medical treatment, but once it's poorly controlled, most of them, they will suggest to consider bariatric surgery straight away. So there are few criteria that we comply to offer bariatric surgery for patients. There are various approach considered in treating these patients, but the most important part is the counseling to the specific patients must be done before the surgery. So the recent consensus published in our local journals somewhere last year by a few surgeons who are managing patients with these problems, then we managed to reach the what we call a Malaysian consensus by Dr. Gafur and friends. So we put a few criteria according to the international guidelines. And if you notice that we brought down the BMI according to our Asian population from 40 to 37.5 for those who are having obesity without any comorbidities, and 32.5 for those who have other morbidities such as a metabolic syndrome. Before we go details about types and the rest about bariatric surgery, I would like to emphasize that we must understand that there are two groups of intestinal hormones that are dealing with our appetite and their function, and it can be basically categorized into two groups. One group of hormones keep telling our brain to eat more, like you're going, for buffet or any function, for instance. On the other hand, there are another group whereby they're telling our gut and brain, you have to stop eating because you're eating too much. So the idea of doing bariatric surgery is to make sure that the group of hormones who are telling our gut and our brain, you must stop eating. So, and then we will reduce another group of hormones which stimulate our brain to eat more. So there are various bariatric surgical approach. I think now almost 20. A lot of them is actually modified by the certain groups of surgeons, bariatric surgeon, after they notice or their results telling one having more advantages or complications compared to another. But for the sake of bariatric surgery is concerned, for this very short presentation, I would like to emphasize about the two most common procedures done, which are sleeve gastrectomy, and another one is Roux-en-Y gastric bypass. So sleeve gastrectomy is very popular nowadays, not only in Malaysia, but in other countries as well. It consists of laparoscopic surgery, whereby we remove around 70% of the stomach. The most important part to be removed is fundus, whereby it consists of the areas where ghrelin is produced, which is responsible to tell our brain to eat more again and again. Compared to Roux-en-Y gastric bypass, this is more of the combined procedure in which the volume of food enter the stomach is reduced by creating a small pouch, and after that the food straight away bypass and enters the jejunum. And this procedure is very popular, in which we sometimes prefer bypass in a certain groups of patients if they have a metabolic syndrome, for instance. So this survey or audit done by Professor Nick from UK MMC, one of the highest volume of bariatric procedures done in Malaysia. As we can see, this survey was done, I think in 2016. There are more than 20 bariatric surgeons in Malaysia. As you can see, the sleeve gastrectomy is getting more popular because it's a lot of advantages that we can see. So I would like to show this very short video about sleeve gastrectomy. performed in KPG Penang. I think probably a couple of years ago. So the first step is to remove all the ornamental attachment to the stomach, because we're going to staple the stomach and remove at least 70% of the fundus and the greater curvature. So the calibration tube with the size of 32 French is inserted by anesthetist into the stomach. And this is a laparoscopic stapler commonly used by us to divide and at the same time staple the edges of the stomach. And this can be achieved in the same manner, whereby the bleeding is minimum. So as you can see, the stomach is getting smaller, and this is the portion that left behind. And what about the rest? We will remove after the procedure is completed. So this is how the end of the procedure looks like. The remaining we will remove through one of the incision, and then the wounds are closed in the usual manner. All right, so we want to know after the surgery what happens, all the benefits. This result actually published in our guidelines of CPG management of obesity. If we manage to reduce around 10 kilogram of the 100 kilogram person, that means only 10%, we will notice a lot of benefits, even from the 10% of weight reduction, in terms of blood pressure, their lipid profile, diabetic control, improvement in the arthritis, and most important part, reduction in the mortality risk. I would like to show this. I think some of us are very familiar with this graph. It's one of the longest follow-up done by Swedish group, where they compare the control obese population with those who were operated with the various procedures. One of the longest follow-up, probably now with 20 years plus. You can see those who were operated, they can sustain the weight loss for very long term. What about the safety, the potential serious problems happen during the surgery? Yes, it's a very risky procedure. That's why we are very selective and must be tailored down individually to particular patients. But I would like to highlight that the risk of mortality very low, almost similar to laparoscopic cholecystectomy only if it's done properly, and the complications also not that high. There are various papers published. One of these paper from Sweden, they also proven that over the years, when they compared various bariatric procedures with the control group, there was significant reduction of all causes of mortality, especially cardiovascular mortality, and at the same time, the incidence of dyslipidemia and ischemic heart disease also were reduced significantly. And similar papers proven to have a reduction in risk for getting diabetes mellitus as well, hypertension, and other comorbidities. So if we're talking about diabetes itself, yes, it's a really challenging management, especially to physicians who are managing diabetic patients, and those who are obese. That's why nowadays people start to realize that bariatric surgery actually have a very good impact in the diabetic control. So even those who are not operated, is proven that we can reduce the risk of getting diabetes significantly, as the Swedish paper showed that the incidence is reduced around 4 times compared to those who are not operated. And similarly, in other papers, even they compare a risk to get a diabetic remission is significantly much higher compared to those who are not operated in this follow-up group. So there are various formula that people use how to assess your diabetic remission, which I'm not going to go further details. What about the other morbidities like sleep disturbances? Yes, I think a previous speaker already mentioned role of bariatric surgery when they compare the parameters, how to assess the severity of sleep apnea. What we found is a significant reduction of the AHI in those who undergone the bariatric surgery, and then as you can see, if you reduce their weight, and you can see their improvement in sleep disturbances as well. Similarly, if a gonadal dysfunction is concerned by our gynecologists, it's also proven that after bariatric surgery, your gonadal function is improved, and hopefully this will give good news for those who are having an infertility problem. So similarly, for the gastroenterologists, we also notice significant improvement in liver function, and some of the authors even published their liver biopsy also showed a significant improvement after bariatric surgery. So what about the overall cost? If you compare, somebody who is obese, operated by bariatric surgery, and if you compare with another guy who is obese, and then eventually they develop multiple comorbidities, and as you're aware, some of the common cancers, at least 13 cancers, can have an association with obesity. And if you see overall cost of treatment when you're treating cancers by surgical means, the cost actually is much higher to if you compare with bariatric surgery itself. Having said that, they also have potential side effects of bariatric surgery. It's not something that we should deny. So that's why the counseling and patient selection, of course, the procedure selection also plays very important role in treating these patients. So if we ask around, how about the effectiveness or about the bariatric surgery in treating obesity? Yes, it's considered very effective, sustainable, and can be done in the same manner with a fairly effective cost. But of course, this is not a simple surgery, and it carries significant risk. That's why we usually choose the proper patients with the proper procedures before we embark into this surgery. So as a conclusion, ladies and gentlemen, mom and dad, boys and girls, prevalent obesity is worrying in Malaysia, and in fact can be considered as the greatest infirmity to our population. So everyone must play their role, talk to your patients and pick up the problems early before they develop significant comorbidities, because obesity itself is a disease. And like Dr. Mazni said, the best is prevention, and then mitigating obesity is our responsibility. And we are confident that bariatric surgery is the way forward that can be offered to these patients. Why? Because it's already proven excellent results by losing weight very effectively and sustainable for very long term. Also, it reduces associated comorbidities significantly, and as well as reducing the risk of getting diabetes and hypertension, with probably will reduce the overall long-term medical costs as well. So with that, I would like to end my presentation. Thank you.
Thank you, Mr. Wan Ajmi. I apologize that we are running a little bit behind time. We're going to move on to our last speaker for this symposium, Dr. Farid Rizal Abdul Hamid. Dr. Farid Rizal graduated from University Science Malaysia in year 2000, and he obtained his master's in healthcare management from University Technology Malaysia in 2016. He was the deputy medical director in our hospital from 2012 until 2020, and currently he is the deputy state medical director of Kedah. Dr. Farid is going to share with us his inspiring journey to battle weight problem. He actually expressed in his CV that he has a very high interest in new era of operational healthcare leadership management, and he has been embarked in training and giving talks on leadership and career rebranding in healthcare. Please welcome Dr. Farid.
Okay, Assalamualaikum, and a very good afternoon. Now I'm recording during afternoon session, but anyway, welcome to my talk. It's very unique, the talk upon the Biennial Scientific Meeting. Thank you very much, PGMES Hospital Sultanah Bahiyah, for inviting me for specific topic for the purpose of these meetings. True enough, this topic is very near to me as I experienced myself during my year's time. Okay, my age now is 48. Okay, what I had gone through my experience at the age of 31 plus. Okay, so whatever we're going to go through this topic, we're going to talk about my personal experience. It is, I think, it's a living evidence of, the achievement that a person can have. Then I will, together with my talk, there's some slides we can go through with all of you. The slides, I would say, is about Go Fit. Okay. Before I take off this topic, it is very important. We have to be very clear. Okay. We have to be very clear. There are two components. I'm not trying to share, I'm not trying to get a concept where if you are fat, you are not healthy, or if you are thin, you are healthy. So those are not, okay? And furthermore, we are not going to go towards, body shaming, you judge people based on size. No, that is not the objective of this talk. What we're going to go through this topic, we're going to talk about this topic is all about to be fit, to be healthy. And if you are fat or you are obese or you are overweight, we'll make sure that you don't have at least a non-communicable diseases, or you're going to have other complications due to the diseases. Those are the components that we as a medical practitioner and also a public must really understand the concept of Go Fit, the concept of being fit, or whatever reasons you want to stay thin, stay slim, and finally you always stay healthy. Okay. These are the slides, and you just take off. Those pictures are, we can take off this concept as branding of yourself, okay? And as for me, as my career as an administrator, when you are an administrator, a leader for an organization, wherever you go, you carry the branding of the organization, how you talk, how you communicate, and obviously how you present yourself. Obviously as you in a healthcare organization, and you go to an organization non-healthcare, it creates an aura of examples to portray who you are as a healthcare personnel. So those are the first point you should, we should really embrace on. Together with me, my helper actually, Emil Haril, is helping me to adjust the slides. Okay, next slide. Okay, I would share, starting off, we share a video to prove, to tell everyone that how big your size is, how huge you are, you can move, you can really do some fitness program in whatever ways, this is a video that proves something, thanks, yeah. We share the video. Okay. You see, don't judge a book by its cover. Corporate sector, size does not matter. What matters is really you want to be fit or not. As a worker, even you are a government servant or in a corporate sector, we want to work and to serve people. So to serve, we have to be always get fit. When you are fit, that is where you can perform. To be fit is a must for anybody, to portray their performance. Even as a surgeon, you must be fit to stand long hours for a surgery. You must be fit, as a physician, to be with the patients. When you are fit, you're going to have a peaceful mind. You're going to eat easily. You're going, we easy to control the emotion because you are fit and healthy. And fortunately, you can create a positive aura. So the slides, I promote that fit to serve. We don't say slim to serve, but you have to be fit to serve. Whatever size, make sure you continue a fitness activity to sustain your body fitness and also to prevent any diseases. Okay, next. One thing that, sad or not sadly, doctors, we are the role model for fitness. We should be the role model for fitness. And a broader concept, every healthcare professions is the role model for fitness. But why we struggle to maintain that forte in our branding, to motivate any patients walk into our clinic, to motivate anybody to come into our hospitals, to really feel, oh my God, I have to always get fit. By talking, but if we do not portray an aura of convincing, is going to be a lack of confidence to our customer, especially to our patients with all kinds of sickness. Those are the pillars and the struggles that everyone should have. Okay, I've gone through the episodes of forgetting myself to maintain, to be good branding in terms of my fitness, in terms of how I should portray myself as a doctor. You imagine you've been called for a talk you've been called for a preventive talk in terms of diseases. But by reality, you do not show an example how a person with fitness should be. So this is important. The first rule of thumb, we as the worker, as the agents of health in a healthcare profession should portray ourselves. And patients are inspired by desire to set a positive example and lead. When patients come in, you know, the aura, you like it or not, the aura from us as a doctor, from the paramedics, want to become, you know, a role model. Who you are, what he will remember. And also a doctor takes a hand and opens the mind and touches the heart. This is reality, like it or not. Whatever comes out from us, it should be a goal's idea. For any patients, it does not become a goal, it will only convert to scent if we as a healthcare profession or an advisor does not portray a role model to be like one. So this is a challenge, you know, and it was my turning point, you know, to really look back to myself, what I want to become, how I'm going to make my patient listen to you. You know, you convince them how without silence, people want to be like you. How is going to happen? So next. Okay, so you listen to all stories. There's a lot of stories that people successful when other can do it. Obviously, me as a person, furthermore as a doctor, can do it. You know, these are, I'm not talking about become huge or small. You maintain as fit. You know, I will share the next. Okay, it was me. It was me those days, you know, my size. You know, I starting off, you know, I'm forgetting myself. Originally, my size was about 72 kilogram with a height of 178 centimeter. And I reaches up to 150 kilogram with my waist about 42 inch. You know, the reasons I'm becoming that because I forget about myself. You eat and continue eating without exercising. And you overeat. Kita overeat. And I myself, not you lah, basically it's me who I love eating. I enjoy food, you know. When I was in Penang, nasi kandar breakfast, nasi kandar for lunch, and nasi kandar for dinner. And you know, after eating, go back and sleep, you know, after eating, you know, even during operating theater, in between OT also, you eat, even with an empty biscuits, you know, with a teh-o, you know, tea without sugar, tea without milk, it becomes, you know, delicious. You feel so delicious and it really makes you grow and grow. Why I want to be slim? You know, the reason when I decided, you know, you have money, but you can't really groom yourself. You have career, but you can't really brand yourself. You have family, but you can't really portray yourself to be a role model to your own family with the size that I used to have before. So those are what I want, why I want to be slim. But how about anyone? So as a doctor, when we advise people to be slim, we must make sure that why the persons want to be slim. Some people love a just moderate body size, but they are not fit. Then we have to guide them how to be fit. Then it comes to the second point, is definition of slim or fit. Ideally, we want to be slim or we reach the ideal BMI versus fit. Some people, educated, we are talking about BMI. Wow, they know what is BMI all about. When like me, be in Kedah, some of the people from Sek, some of the people from Padang Terap, very end there, Sungai Tiang. When talking about, you have to get an ideal BMI, this makcik-makcik just stare at you, so what is that? So ideally, you can use the word slim to portray what is actually you meant. So slim and fit are two different things. Ideally, it has to come hand in hand. When you are slim, at the same time you be fit. There's a lot of people who consume things to be slim, but they are not fit. Their heart rate is not an ideal heart rate to say that you are fit. So these are the definitions that we have to be very clear. And macam mana boleh obese, how you can get fat, obviously, no exercise, no activities, and yet you eat. I think basically we overeat. I did overeat. I eat a lot, trust me. And my favorite food is dessert. Cheesecake, blueberry cakes, those are my jargons of food. Every time you have to consume every day, not talking eating at night, and also including in between meals of, you eat junk foods. Then those are the things that really matters to me those times. That lupa diri lah. When you lupa diri, everything gone. Everything gone. Even you lose your figure also. Okay, next.
Thank you, Dr. Farid. I sincerely apologize to Dr. Farid that we have to terminate the video prematurely because of the time constraint. I have watched the entire video and I have to say it's really inspiring. Rest assured, all the videos for the symposium will be uploaded on our website and it will be there for the next 6 months. I believe some of the questions have been answered in the chat box earlier. However, please feel free to email us if you have further questions and we will forward to our panelists. Now I'm going to pass on the stage to Dr. Masni, who will chair our lunch symposium. Dr. Masni.
Assalamualaikum warahmatullahi wabarakatuh. Okay, thank you, Rafati. Welcome everyone to our lunch symposium. This lunch symposium is sponsored by Novo Nordisk. Thank you, Novo Nordisk, for sponsoring this obesity symposium, lunch symposium. March is World Obesity Day, that fall on 4th of March recently. So this is just nice to have this obesity talk or symposium also talked by Prof. Rohana. Right, so I'll be sharing today's symposium. The topic for today's lunch symposium will be role of pharmacotherapy in obesity management. The speaker today is none other than my good friend, Prof. Rohana Ghani. So before she starts, let me just introduce her. I have to do my part, right? Prof. Rohana Abdul Ghani is a consultant endocrinologist, lecturer at the Faculty of Medicine in Mara UiTM. Sungai Buloh. She is currently the Deputy Dean of Postgraduate Studies and Professional Training in the same institution. She received her undergraduate education in University College of Dublin, Ireland. She pursued her postgraduate studies in Masters in Internal Medicine, UKM, and subsequently completed her endocrine fellowship training also in UKM. Her clinical service include running of the endocrine, diabetes, and weight management clinic. Her research interests are in the areas of diabetes, obesity, and led her to multiple publications, national and international peer-reviewed journals. She's a national leader for international multi-center clinical trial, which I'm also involved. She is currently a member of various, not currently, she used previously was in CPG for gestational diabetes in 2017, and presently we are in the same team for CPG obesity. So, Prof. Rohana, the stage is yours. You can start.
Assalamualaikum warahmatullahi, and a very good afternoon. Thank you very much, Dr. Masni, for the kind introduction, and thank you to the organizers for the invitation for me to be here. It is a pleasure for me always to be sharing with you some of the current or updates on the treatment of either obesity or diabetes. Dr. Masni, I think I got a bit nervous because she started off with the undergraduate because I would reflect my age. But anyway, but also to mention that I do work very closely with Dr. Masni, her being the senior. And we are currently also part of the initiative of Malaysia Open, which is to boost the understanding of obesity in the country. So let me just share my slides. This is what I'll be talking about. So this is the role of pharmacotherapy in obesity management. I do look forward to the Q&A at the end of the session. So these are my disclosures, and it would include the research grants and multi-center clinical trials that Dr. Masni has mentioned, as well as on an honorarium for this talk. So I will try to keep it within the hour. So this is the content that I'll be talking about in terms of obesity treatment strategies. When to start the pharmacological interventions, and what are the pharmacotherapy options available currently and for presumably in the future, and the role of pharmacotherapy as an adjunct to bariatric surgery, because as similarly to Dr. Masni, myself and her, we are both proponents for bariatric surgery in the country. Sure. So just to start off with, and just to get everyone thinking and to remind everybody how obesity used to be so simple, that it was supposed to be a lifestyle disorder. It was supposed to be a completely patient choice to be fat or not fat, because it is really about energy intake and energy expenditure. So the more the patient consumes energy in terms of food and mainly carbohydrate, and very little energy expenditure equals fat. However, or equals obesity and overweight. However, in recent times, we have been made to understand that it is really a lot more complex than that. Firstly, we are also doing the initiative to increase the awareness that obesity is, as a matter of fact, a disease, because it is affected by a lot of factors, and not just this misbalance or mismatch between energy intake and energy expenditure. We have the modifiable factors, which includes, as you can see here, genetic mostly, and that translates to if parents are fat, therefore I am too fat. But also in recent times, we have been highlighted to the fact that there are hormonal abnormalities, including from the adipose tissues, the pancreas, and also the gut hormones, mainly the incretins. But as well as that, we have the modifiable factors that we blame it on the environment. However, we also understand that it is not just the availability of food. What is it that makes or differentiates between a patient who is unable to control his or her food intake? And that is the hedonic input and the satiety center. And also then we have the one element here on the rightmost, as you can see, the medication, which again, in a way, becomes an unmodifiable factor for the patients, a modifiable factor for healthcare providers, because we decide what medications we want to give. And for example, we know for sure that our sulfonylurea will increase weight gain, or will cause weight gain rather. And some of the antipsychotic medications would have the side effect of increasing weight. So are we really to be blamed? So what are the available obesity treatment strategies at the moment? We talk about self-directed lifestyle change. As a matter of fact, I'm involved in the obesity CPG or obesity consensus in the region. And some of our neighboring countries insist that patients should really do this on their own. However, we also understand that it is very, very difficult, as I mentioned earlier. And then so you have the trainers who will have who help the patients in terms of their physical exercises. So these are professionally directed lifestyle change. And this is where we come in. So when do we decide to give them pharmacotherapy? When do we decide to refer to surgeons for bariatric surgery? And following that, when do we decide that pharmacotherapy and bariatric surgery go together? And we have been working with the surgeons quite closely to do this. Because we understand that the weight loss is a long-term journey. It is if a patient puts his or her mind to it, he or she can actually lose that 10% of body weight. However, the challenge really is to maintain it because, it's difficult. So this has been shown over and over again from as far back as, is from the early part of the century even. Then you can see that no matter what treatment you initiate, it will result in some degree of weight loss. So either it's just a mere 1% or a significant 20%. But as you can see here, it increases, or the weight regain, the weight gain after following that treatment happens very quickly. And that is partly because of this fascinating physiological effect of the body that Allah has created, that when the body detects weight loss, there are adaptations, physiological adaptations, which resist this weight loss. And that would involve the reduction in satiety hormones, for example, and the increase in hunger hormones. And patients tend to have a little bit more craving. But as well as that, the other thing that we have understood over time is that the metabolism of the patient drops as well. So that makes it even more difficult to lose weight or to maintain that weight gain over time. And subsequently, it will result in weight regain. Right, so when do we therefore help or guide patients to start pharmacological intervention? This is one of the more recent guidelines, and this puts it very, very nicely. And I think the American guidelines will also be very, very similar. But I'm just going to quote this Canadian Obesity Guideline 2020. Let's start from the bottom here. So we agree that lifestyle intervention should be initiated at any part of the BMI. As you can see here, the reference that we use is still BMI. That has not changed over time. So, sorry, I'm just stuck here. So in terms of all individuals, regardless of body size or composition, should have a lifestyle intervention very, very early on. Then behavioral modification too, it comes together, as you can see, even from BMI of 25 to 27, and that would depict overweight in Canada. However, in Malaysia, as you know, we use a BMI of more than 23 to 27 as overweight. So behavioral modification very early on. So where does pharmacotherapy come in? Pharmacotherapy is indicated in BMI between 30 or above 30, essentially it's above 30. However, in some patients with adiposity-related complications, and this is obesity-related complications, including cardiovascular diseases, any of the mechanical complications, for example, any of the obesity-related complications, then the pharmacotherapy should be initiated earlier of BMI above 27. And when the surgery comes in, surgery is clearly indicated when the BMI is over 40, and we call it morbid obesity. But as well as that, it can be advised and recommended even when the BMI is above 30 and when optimal medication and behavioral management has been insufficient over a period of time. So we talk about 3 months, so 3 to 6 months. If you have initiated medical therapy has not resulted in any significant results, then you might want to discuss about bariatric surgery. Right, what about local guidelines? This is our management of type 2 diabetes, 6th edition 2021. And what we recommend is that pharmacotherapy can be considered for patients with type 2 diabetes with BMI of more than 27 kilogram per meter squared, and after failing 6 months of lifestyle modification. And the 3 anti-obesity agents which is available in Malaysia are phentermine, orlistat, and liraglutide, 3 milligrams Saxenda. Right. So I just very, very quickly, I've mentioned it. So I'm going to talk a little bit in detail about the medications available. The first one is orlistat. I'm sure most of you will be very, very familiar with this. It is a gastrointestinal lipase inhibitor. It works to prevent the hydrolysis of hydrogen in the synthesis or in the breaking down of triglyceride or the fatty acid molecules, and therefore prevents the absorption of fatty acids being absorbed into the bloodstream. And this has been shown, and this is an old paper in 1998, but it has clearly and nicely demonstrated here how orlistat actually works. But what is significant about this, and what was very common, I suppose, that you can see in your clinical practice too, that the weight loss quickly plateaus approximately after 6 months of use. And as you can see, the moment the medication is ceased or stopped, the weight regain happens very quickly in the gray line here, as you can see. So the next one that I use, and of course, the side effect, just to very quickly mention about Orlistat, the one side effect that is probably unacceptable for most patients is the steatorrhea. So a lot of patients will say that they can't control it, they will have fecal incontinence, and during a meeting especially, so that makes it quite unacceptable. So the other one is phentermine. So I know some of you would have some reservations about this, but because of the limitations in the anti-obesity treatment that we have, we use it a lot in our center. So it's a sympathetic amine that releases norepinephrine in the central nervous system. So essentially what it does is it's an appetite suppressant, and it works by the release of noradrenaline and dopamine. And because it involves the use of noradrenaline or dopamine in the pathophysiology or in the physiological tract, it results in very commonly two side effects, which is increase in blood pressure and headache. So that makes it one, what you have to be selective in the patients that you give phentermine, and also you have to monitor in terms of the side effects that they develop. However, in terms of effect, as you can see, the continuous line with X is continuous use of phentermine over a period of 36 weeks. Approximately 8 months, and the other line with the circles represent alternate phentermine and placebo. So the use of phentermine 3 months, and then you stop it for a month and you use it again. So that produce similar results, as you can see here, compared to placebo. So again, I think this early data, this is very, very early and very, very old data, but it also gives us an idea that phentermine can be used. It has significant weight loss. However, the long-term side effects are currently unknown, and so we usually limit our use for approximately 8 months or so. So finally, the GLP-1, a glucagon-like peptide. One is a native peptide that has a central effect on appetite and influences the energy intake and results in body weight. So what is it really? It is a hormone and neuropeptide. It increases the feelings of satiety and reduces the feeling of hunger, and therefore leading to decreased energy intake. But as well as that, we have also discovered that the physiological effect of GLP-1 receptor agonists or the GLP-1 hormones also work at the heart with a cardioprotection effect. It works at the kidneys to cause natriuresis and diuresis. It works at the blood vessels to reduce blood pressure. It works at the platelet, reduces coagulation, and also works at the liver and the intestine to reduce inflammation and postprandial lipids, respectively. So generally it has a significant benefit in terms of cardiovascular benefit as well as renal. Besides its main action at the pancreas, which is essentially reducing gluconeogenesis with a increasing insulin release by the beta cells, and also reducing glucagon secretion by the alpha cells. So what do you need to know about GLP-1 receptor agonists? Are they all the same? I'm sure you've heard of the many compounds that's available in the market right now. We have mainly two, which is the human GLP-1 based therapies and the exendin-based therapies, which is the neuropeptides extracted from the Gila monster. So on the left, the human GLP-1 receptor agonist, you have the once daily, which is the liraglutide, and you have the longer acting ones, which are administered weekly, including Dula and semaglutide. The exendin-based therapies are the old exenatide once daily, and the extended release of exenatide, and as well as that you have the lixisenatide, which is essentially probably the newer compound in the market. So just focusing on liraglutide. So we have been using liraglutide, we as in my institution has been using liraglutide since it landed on the shores of Malaysia many, many years ago, and we are very familiar with its use. So these are some of the clinical programs that utilizes liraglutide, the evidence of the use. There's some of it that is particularly interesting to me, which is a scale obesity and pre-diabetes. The scale diabetes, and these are numbers, not depicting the years, scale maintenance and scale sleep apnea, which are the phase 3A studies. And on the right side are the phase 3B studies, which looked at scale insulin, looking at the clinical benefit of lira in patients taking basal insulin, and also scale intensive behavioral therapy, which is weight management with liraglutide 3 milligram used as an adjunct to intensive behavioral therapy. So just focusing on the obesity and pre-diabetes, these are looking at patients who are obese with diabetes and looking at how long it takes for them to convert to diabetes, for example, that is. And scale diabetes is looking at the weight management. So this slide just very nicely summarizes it. What are the efficacy summary across the phase 3A trials, the key efficacy outcomes with liraglutide 3 milligrams. So just focusing on the scale obesity and pre-diabetes, it has resulted in a reduction of 8% change in body weight after 1 year, and a significant 80% reduction in the risk of type 2 diabetes over 3 years. So just take a moment to actually think about that. So this is 4 out of 5 patients who are pre-diabetes who were able to delay the diabetes onset over a period of 3 years. In the scale diabetes study there is a 6% change in body weight after, again, just above 1 year, 56 weeks, and with a change of HbA1c of 1.3% change from baseline. And this is taking into account a baseline of about 8%. The scale maintenance showed a 6.2% reduction reduction in body weight after 56 weeks, which is similar to scale diabetes. And on top of that, 81% were able to maintain more than 5% weight loss after a year. And finally, is a scale sleep apnea, whereby 5.7% of patients demonstrated a change in body weight after 32 weeks, and that is just over 6 months, with a reduction of 12.2 events per hour versus 6.1 events with the placebo. So that is halving of the events of sleep apnea. So in terms of the safety profile, the key safety outcomes were as listed here. The main one, as patients will tell you, is the GI adverse events. More events versus placebo, we understand that. However, of note, mostly are mild to moderate and none are really severe that requires hospital admission. Major adverse cardiovascular events, you will know this as well from the lira 1.8 milligram as well as the semaglutide studies, that they have fewer MACE events versus placebo. In terms of gallbladder disease, acute pancreatitis, and neoplasm and neuropsychiatric adverse events, these seems to be similar to placebo. So the clinical particulars, therefore, in terms of therapeutic indication, liraglutide 3 milligrams or Saxenda is indicated as an adjunct to a reduced calorie diet and increased physical activity for weight management in adult patients with an initial BMI of 30 kilograms per meter squared who are defined as obese, and also in those with BMI of more than 27 kilograms per meter squared in the presence of at least one obesity-related comorbidities, which includes some of the ones listed here, but not exhaustive, including dysglycemia, hypertension, dyslipidemia, and obstructive sleep apnea. So it has a strong weight loss efficacy of almost 10%, of 9.2% here, in terms of from the baseline body weight. It has a dose-dependent beneficial effect, so you need to maintain to get up to that 3 milligrams. It has an 80% risk reduction in the development of type 2 diabetes within 3 years, as I mentioned. 6.2% additional weight loss after low-calorie diet-induced weight loss, and this is from the maintenance scale study. Liraglutide 3 milligrams is required for maximum weight reduction, and 69% people with pre-diabetes returning to normal glycemia, therefore. And also, as I mentioned earlier, because of the effects on the blood vessels and the heart, etc., there's improved blood lipids, hypertension, and reduction in cardiovascular risk factors as a whole. So in terms of the algorithm, the choice of obesity pharmacotherapy, this is again from the Canadian guideline. As you can see here, if the BMI is more than 30 or BMI more than 27 with one comorbidity at least, to the left, if they have diabetes, pre-diabetes, hypertension, OSA, polycystic ovarian syndrome, then liraglutide is indicated as the first choice, followed by naltrexone, bupropion, combination and orlistat. So we don't have naltrexone and bupropion at the moment. It has been withdrawn, by the way, and not sufficiently successful weight management, and you need to discontinue the first choice and then go on to the second and the third. In terms of the craving, depression, and smoking, the first choice is naltrexone and bupropion, followed by liraglutide and orlistat. And you can continue the medication if after 3 months of assessment, if there is continuous weight management. So weight reduction, sorry. What about bariatric surgery? As I had mentioned earlier, we as in myself and Dr. Masni, have been working very, very closely with the bariatric surgeons. We understand that they can actually help patients, particularly patients with very high BMI of more than 65. As a matter of fact, bariatric surgery is indicated in those with above 40 kilograms per meter squared. However, with those BMI of more than 65, it is completely, has been demonstrated and completely understood that it carries a significantly higher risk, both surgical risk and cardiovascular risk following the anesthesia. So therefore, the pre-surgical weight loss is absolutely mandatory and very, very important to reduce intra-abdominal volume and achieve operability in laparoscopic techniques. And it has been shown to reduce morbidity as well as mortality. However, for some individuals, this is absolutely difficult to achieve with diet and exercise alone, no matter how much they try. So therefore, the use of weight loss medication has been shown to be significantly useful in the pre-treatment management. So these are some of the studies. As you can see here, there are small numbers, some are case studies, a few were retrospective, and only very few were prospective with the use of liraglutide 3 milligrams, various other anti-obesity management, lorcaserin here, exenatide, and orlistat as well. I'm not going to go through them, but just to mention or to share with you that there is a role in initiating the treatment before the surgery. However, more significantly is the weight regain. So as you know, some of our patients who had undergone bariatric surgery were able to maintain their weight loss, but a majority or almost all of them would have weight regain, and this would depend on the duration of whether they were able to maintain that weight loss would really depend on many factors. So significant weight regain of more than 15% occurs in approximately a quarter to 35% of patients within 2 to 5 years after surgery. However, there is no generally acceptable definition of weight regain, and most of them are based on the kilogram weight putting on and the BMI units, or the percentage of estimated percentage of excess weight loss. So years from the Roux-en-Y gastric bypass, as you can see here, the longer the duration after the surgery, they would have a weight regain. They would have regained their weight a lot more. So these were some of the studies using liraglutide and various other anti-obesity medications. Some of them were retrospective, some of them prospective here, and over a period of 12 months and 28 weeks, as you can see here. So there are various studies already looking into this. So in terms of post-surgical weight loss, this is looking at patients who have lost approximately 10% or 6.1%, and total weight loss here 6.8%. So summarizing that there is a role in the use of the various anti-obesity management medications post-bariatric surgery. But I just want to focus on one study, which is the use of liraglutide 3 milligrams for weight regain. So this were, because I would just like to underscore the fact that Roux-en-Y gastric bypass with lifestyle modification still remains the gold standard for treating severe obesity. However, weight regain following the surgery is, as I said, very common, like more than a quarter to a third of patients actually have experienced weight regain. And conservative approaches, therefore, can be unsuccessful in reversing weight regain. So this is a study, a 56-week double-blind placebo-controlled study, looking at patients who had Roux-en-Y between 18 to 121 months previously, and who achieved 25% total body weight loss after the surgery. However, experienced a weight regain of 10% total body weight loss after reaching post-operative nadir rate. So it was included more than 130 patients, and they were subsequently randomized to 2-to-1 ratio to receive liraglutide 3 milligrams and placebo. So what it had shown, or what it showed, was a baseline age of 47.2 years. So as you can see, generally quite young, a weight of almost 100 kilos, with a BMI of 35.6 kilograms per meter squared. 1 in 5 of liraglutide treated participants met or exceeded their post-operative nadir weight, compared to none on placebo at all, and this was statistically significant. And as you can see, just focusing on the graph now, change in body weight. So median weight loss from baseline with liraglutide is approximately 10 kilograms, and those who had achieved, compared to placebo, with only 2 kilograms median weight loss, and those who were able to achieve the weight loss target with liraglutide, more than 5% weight loss, almost 70% of them actually achieved that, and 10%, almost 50% of them achieving that, and body weight of more than 15% weight loss target, a quarter, 24% managed to do that with liraglutide 3 milligrams. In terms of side effects, 41.6% of the patients had GI-related side effects. However, serious adverse events were fewer in the liraglutide arm compared to the placebo arm, which was statistically significant, and no deaths occurred. So generally, it's quite safe. So anti-obesity medication is an effective method of preoperative weight loss. Given preoperatively, it may improve post-operative outcomes and reduce the number of surgeries required. The medications are an effective method of weight loss after bariatric surgery and in helping prevent weight regain. And in addition, liraglutide 3 milligrams can help patients with preoperative weight loss and also post-bariatric surgery weight loss. So just finally, I'd just like to summarize it all if you had missed the early part of it. So these are the 3 medications approved in Malaysia for weight management. So you have the orlistat. It results in approximately 6 to 10% weight loss compared to 4%, just above 4% above placebo. Advantages: it has no systematic and no long-term data available. However, the disadvantage is that it has low potency, it has no appetite suppression, and has no effect on high carbohydrate diet. It essentially only affects those with high fat diet. And in recent times, I'm sure you completely agree that we have been made to understand that the weight gain mainly comes from the carbohydrate as well. So the phentermine the phentermine is an appetite suppressant. It results in a 7% weight loss. The advantage is it has a good efficacy, I would say, a significant weight loss. However, the disadvantage being no long-term follow-up. So we have approximately 8 months. That's the longest that we have used. It is a short-term drug, and because the moment you stop it, there is a weight regain, and you have the CNS side effects, including the headache and the increase in blood pressure as well. So liraglutide 3 milligram weight loss is between 8 to 10%. And the advantages being significant weight loss with long-term data. The disadvantage is, of course, the GI side effects, which in a way becomes the advantage because then patients will lose appetite with the GI side effects as well. So in summary, lifestyle modification is critical but often challenging to conduct and continue. I think you all can relate to that because there is that defense mechanism, the physiological defense mechanism that the body metabolism has. Pharmacotherapy holds promise to bridge the treatment gap in obesity care between lifestyle intervention and surgery. And pharmacotherapy also holds promise as an adjunct to bariatric surgery pre and post procedure. So I think that's all, Dr. Masni. Thank you very much.
Right, thank you very much, Dr. Prof. Rohana, for the informative talk. I think we do have time for a few questions. Okay. What about semaglutide, Prof. Rohana? Semaglutide, since FDA already approved for as anti-obesity.
Yes.
Okay, so what about in Malaysia? Have you any experience?
Yes. So the semaglutide that we have right now is the use in diabetic patients with Ozempic. So that it has significant weight loss. It's a very similar GI side effects compared to liraglutide. The oral semaglutide is coming, ladies and gentlemen. We are excitedly waiting for its arrival, and we're hoping it should come by the third or the fourth quarter. I think more looking into the fourth quarter of the year.
But unfortunately for the oral, it will be daily, not
Yes,
weekly.
yes, that's right, that's right.
Yeah.
And it has limitations in terms of its administration. But
Mm,
for those patients who are absolutely terrified of injections, I suppose that's an option.
An option, true.
Yeah.
True. And there's another GLP-1 receptor agonist that's been combined with GIP, tirzepatide. That's really looking forward to it. Maybe you would like to comment, Prof. Rohana?
Yeah. I think that would also be another option, but of course, the cost is a major cost is a major limitation. But never mind, putting that aside, it should promise a lot of more compliance. But the side effects again is something that most healthcare providers should be very comfortable with. Because just from practical point of view, the side effects, as I mentioned, number one is mild to moderate, so it's not severe. If you can just reassure patients, it will go away. And as well as that, it usually lasts for about 2 weeks. At the Masni, I believe you would have the same experience. That after 2 weeks, it kind of abates and then it finally goes away and patient gets used to it.
But that depends on patients. Some patients last until 4 weeks. So we have to slowly titrate up the dose. For the other participants' information.
And as well as that, the titration of the dose, you may not be able to reach the highest dose. Because, for example, in the SOUL study, we were not able to reach the 14 milligrams as patients asked to. So we optimized at 7. That's okay too.
True.
Yeah.
I was looking for whether we do have any questions from the floor, but there's none.
Right. Good.
There's none. So you presented well. Okay. For phentermine, there's the phentermine XR apparently that may help to reduce the palpitation and the headache. Phentermine XR. Korea have it, but we don't have it in Malaysia. So that would be good. Another medication.
If you can get
play
that.
around.
If you can get that in, that would be good too. However, one of the side effects that I find quite worrying with that is the blood pressure. So so you have to be very, very selective because patients do have increased blood pressure after starting it and the headache.
Okay. All right. If there's no more questions, I suppose we can end this lunch symposium. Right, thank you very much, Prof. Rohana, for the informative talk. We'll see when we see again, inshallah. All right, thank you all for listening.
Yes. I'll be calling you, Dr. Masni.
Yeah, no problem.
All right.
Bye.
Bye-bye.
See you all. Right.
Assalamualaikum and good evening again. So we are now in our second half and final session for the 12th PGMES Biennial Scientific Meeting this evening. So I'm honored to introduce our speaker for plenary 6 entitled Suicide Risk Assessment and Prevention. So Dr. Ahmad Rostam bin Mat Zain is currently the consultant licensed psychiatrist in Hospital Sultanah Bahiyah. He graduated from the University Kebangsaan Malaysia, and as an officer, he had worked in various hospitals all over Malaysia before pursuing and obtaining his master's in psychiatry in University Science Malaysia. He then received his fellowship in General and Licensed Psychiatry, National University of Singapore. His special interest is in HIV psychiatry and psychotherapy, which is spiritual integrated psychotherapy, ACT, and DBT. We are thrilled to have Dr. Ahmad Rostam as part of our 12th Biennial Scientific Meeting this year. Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very good day to everyone. First and foremost, I would like to thank all of you for attending this current symposium. Thank you so much to PGMES Hospital Sultanah Bahiyah Al-Usta for arranging this excellent program for all of us. Thank you to Mr. Moderator for introducing me right now. And for today, I have a very important topic to discuss with all of you. I would say that this topic cannot be discussed within 30 minutes, but I will make sure that I will try to tell you the salient points behind this very important topic, which is actually I will be talking about the suicide prevention and management generally in Malaysia. So, ladies and gentlemen, when we are talking about suicide, right, we cannot pinpoint any specific reason for any of the incidents that we know. Of course, we have the idea that most of the suicide is due to the underlying psychiatric problems that they have, but the fact is not all of it is actually due to the psychiatric disorder that the patient have. And most of the time, the incidences that we have heard before in our society, in the community, even in a hospital setting, is not due to a psychiatric disorder, underlying psychiatric disorder. But of course, when we are talking about these particular incidents, there are elements of mental health issues. And of course, there will be a possibility of an underlying psychiatric disorder that was undiagnosed prior to the incidents, which is actually very important for us to really look into whenever we have the opportunity to talk to our patient, especially in an inpatient setting. Because there are a few groups of patients that we consider them as a vulnerable group, which I will discuss a bit more during my presentation for the next 30 minutes. And before I go any further, the first part of my presentation, I will be talking about the prevention part of it. And of course, in this situation, I'm discussing about the preventive measures that we can do while we're dealing with the patient when they are in our ward. Actually, it started from the point when they come to our emergency and trauma department downstairs, up to the ward, to the point of the first contact with the primary team. Maybe to the point in which they come to see us or we come to see them, the psychiatric team come to see them, and to the point of in which the incidents happens. Whether the incident is actually a complete suicide, means that patient died because of suicide or not, that's number two altogether. Because what we want to do now, right now, here, today, is actually what are the things that we can do to help our patient prior to the incidents or to prevent the incident from coming or from happening. So there are a few points. I would say that there are 6 points that we all need to know in terms of prevention. And first and foremost, of course, we are talking about creating awareness. And when we are talking about creating awareness here, it's actually not about our patient, it's actually about the staff. That's the most important part of the prevention measure. Because if the staff is not able to identify, or staff is not able to help when there are crises in their ward, nothing that we can be done at that point of time. So creating awareness is actually about educating our staff pertaining to the issues, not only about suicide, but any kind of behavior that can be harmful to our patient, and of course can cause problems to the ward management. So creating awareness, number one, is actually about the medical practitioners, means that the doctors, the housemen, the medical officers, the specialists must be able to at least identify the higher risk patient, in which patient can be vulnerable to this kind of behavior. That's number one. Number two is of course our paramedics, because our paramedics will be the one that is actually staying with the patient for the next 24 hours, for the next 1 week, 2 weeks, or maybe a month. And of course, we would like them to at least be more vigilant in terms of identifying any kind of risk factor, any changes in our patient's behavior, any kind of problems that arise when the patient is going through difficult parts or difficult diagnosis that they are having. For example, we know that risk of suicide or risk of self-harm behavior increase with the severity of the illness. And we know that the risk of this suicidal behavior can be due to underlying medical problems, or the emergence of new medical problems or new symptoms such as delirium, or because of the medication that they are taking, or maybe because of the drugs they are using outside, withdrawal symptoms, or any kind of mental illness that was not diagnosed with a higher risk of suicidal behavior, such as severe depression, not only depression, but severe depression, or severely psychotic patient, or patient that has bipolar disorder. That is actually number one, the importance of creating awareness on our medical practitioners and of course the paramedics. The second part of the preventive measures will be the screening, in which I would say that screening is something that we need to do to all our patients that are vulnerable. As I said just now, chronic patient that come in and come out from the ward has been admitted to the ward multiple times due to multiple complications of their illnesses. Patient who has recently diagnosed with severe problems such as carcinoma or organ failure, so they are vulnerable. Patient that has history of mental illness before, and especially patient has not been coming to our follow up for maybe a few months or maybe years, or patient who has psychosocial stressors. These are the patient that we need to be uh, more aware of in terms of their risks. And the next one will be the safe environment. And safe environment, I'm talking about the inpatient setting, in which we know that one of the most important preventive measures that we need to do when we are able to identify patient that's actually at a higher risk of suicide or any kind of self-harm behavior, we need to make sure that the patient is actually as near to the nursing counters as possible. They must be safe. They must have someone that can be with them for the next 24 hours or more. We must have more regular in terms of assessment and also monitoring and also evaluation of the situation. The psychiatric team must be in terms of supporting the primary team in managing the patient while they are in the medical ward or in the surgical ward or in orthopedic wards. So these are the things that we need to do while they are in our care, under our care. And of course, safe environment is including who is actually aware about the patient's condition. People must be aware about the patient condition, including possible of our security officers. They must know which patient is at risk of doing something dangerous. So these are the things that we need to know. And of course, in terms of our building, that is not much that we can do in that sense. But of course, we must make sure that our building is safe enough for our patient most of the time, if not 100%. So the next one, when we are talking about preventive measures, we should be talking about the risk assessment. aside from screening, we must know about risk assessment, and the next one will be the early detection of the situation. We must be able to really pinpoint the vulnerable groups. We must be able to make sure that our paramedics that stays in the ward know when to get help, when to seek help, when to ask for a referral to the counselors or psychologists or the psychiatrists. So we must teach every single one of them in the ward to make sure that they can make sure that the patient is safe while they are under our care. Not 100%, but if possible to the max or to the optimum level that we want. And of course, the last part of the preventive measures is the psychological first aid. And when we are talking about psychological first aid, most of the time, psychological first aid is actually discussed during disasters, such as flood or maybe earthquake or tsunamis. But PFA must also be done when the patient is in the ward, especially when they are just breaking bad news or receiving bad news from their primary team. So we must be able to be there in terms of giving them the psychological support when they are so down, when when they listen to the bad news that they receive from the primary team or any team that actually managing them at that point of time. So what are the inpatient red flags? Because when we are talking about risk assessment, right, we must know what we want to find, or what are the things that we want to know from the patient that can increase the vigilance. And of course, when we are talking about this, it's actually we are talking about the inpatient red flags. What are the red flags that we need to know before we can say that the patient is actually having problem? Okay, there are 5 red flags that we need to know. First and foremost, when our patient is expressing comments such as, "I just can't take it anymore," or "I wish I were dead, there is no way out," or "all my problem will end soon." So these are the comments that comes from patient that is currently is having symptoms, or we call that hopelessness and helplessness. And these are actually the red flags in psychiatry. So when the patient mentioning this kind of comments, right, we must be aware and we must be giving more attention to the patient. Not just stay with the patient, but actually explore more why the patient says that. Because from that comment, we can get a lot of things. Not just trying to dismiss it, but really be there, listen to patient, ask them what does it means when they say that. That's number one. The second red flag will be when patient are always thinking of dying. So when they discuss with the primary team or the doctors or the consultant, they are talking about when or where or how or why or what ways that I will die. So people always talking, the patient always talking about dying. They want to die. They are talking about dying more than the previous days. They are talking about how they want to die, how they want to end their life, how they want to have their final day of their life. So these are the red flags for all of us. The third points will be when the patient are currently having symptoms of MDD. So MDD, major depressive disorder, of course, the 2 important question that we need to ask when we want to ask about MDD will be, number 1, do you feel low or you feel depressed? That's number 1. And the second most important question will be, do you feel like there's nothing that you want to do anymore? You don't have any motivation to do anything. You lost your pleasure in terms of doing anything. So these 2 questions is very important, where we want to really gauge the possibility of the patient is currently having major depressive disorder. If let's say the patient says that yes to any one of these questions, we must go in further in terms of other symptoms of depression, such as worthlessness, hopelessness, helplessness, feeling guilty, irritability, difficulty to sleep, loss of appetite, loss of energy, and other things, difficulty to focus. So these are other symptoms that we need to check when the patient is complaining about feeling low or feeling depressed, or patient is complaining about loss of pleasure, nothing that can makes them happy, nothing that can makes them able to smile or laugh. So these are very important questions. So the fourth points that can be the red flags in terms of inpatient, in terms of how we want to assess the risk, will be when the patient is talking about patient is having death wishes. So patient will be asking to us, doctor, can you allow me to die today? Can you give me something to die? Or can you just let me die now? Or patient will say that, doctor, I want, maybe this will be my last day. So I wish that you can do this and that and this and that. Can you please call my son because I want to talk to them for the last time? So death wishes will be very, very important. So death wishes should send alarms to all of us. It is such a big warning for to all of us to be more vigilant in terms of the symptoms. Oh, and the last one, of course, when suddenly the patient decide that they want to settle all their personal affairs, suddenly they want to call everyone in the family to come, and they are talking about their properties. They are patient suddenly try to do so many things just to wrap things up in terms of their life, trying to tying up all the loose end that they have in their life, and saying goodbye to everyone, to the families, to the friend, and asking for forgiveness, including to the doctors. So even though this might be a very good act in a sense, but when we hear this from our patient, we must be more careful in terms of just managing them as usual, but we need to know why this is happening right now, because even though most of patients actually knows that their this not that as much as other people has, but the most important part that is actually what we want to do is actually we want to make sure they don't have any suicidal ideation or any suicidal plans, not because of they are contented with their life, but we are concerned about the other part of it, the other side of it, which is actually suicidal ideation and also suicidal plans. So how we want to triage our patient when we deal with this kind of issues? So there are three triage of the patient that can come to us or under our care. So the first triage, what we call the blue triage, in which this is considered the low risk patient. What is actually considered as low risk patient? When they have some mild or passive suicidal ideation. So maybe many of you does not know what does it means by passive suicidal ideation. For example, when the patient says that, I hope that God will take me anytime soon as possible. So they are not talking about want to take their own life. They are talking about, God, please take my life. So that what we call as a passive suicide ideation. Or they ask the doctor to give them something to die. So that is actually the passive suicide ideation. And with no intent or plans. So when we ask the patient about do they have any intention to kill themselves or take their own life, they don't have any intention at all. So these are considered a low risk. And there is no history of suicide before, or suicide attempt before, or there are available social support. There are their son, the daughter, or maybe the partners, or the husband or wife, or anyone that actually be with them most of the time. So what can be observed in terms of this low risk patient? So most of them, they are still cooperative to the primary team. They communicate themselves. They complain about things. There is no agitation. They are quite calm in a sense, and they are quite comfortable at their place. And there is generally no irritability without. Maybe there are maybe there is irritability, but there is no aggression. So, and their story is always, I would say, consistent. How they give the story to us, what are the complaints is always consistent. So these are the things that we need to see or we need to measures when we see a low risk patient. So recommended intervention for this kind of group, of course, suicide caution must be there in place, and must be someone to accompany the patient all the time, whether it's the family, the friend, to monitor while waiting, and of course you need to refer to psychiatry from ED, or even as if the patient is in ward, and reassessment of the suicidal behavior is required at least once a day, but we will tell you what to do. So the second group will be the one what we call as the moderate risk patient, or the yellow group of patient, in which patient reported about suicide ideation with some level of suicide intention. Means that they are really thinking about doing something, but they are not very sure what to do. They don't have any concrete plan of what are the things that they want to do. They just say it loosely, maybe I will do this, but maybe I can do this, but this seems to be dangerous. Maybe I want to do this, but I'm not sure. They just say that I'm not sure. But I think suicide is, I think ending my life is one of the options that I have now. That are the things that they will say. And there are currently there is no acute risk factors that can increase the risk of patient do something. For example, patient just receive a bad news about their illness, or there is a recent psychosocial stressor at home, or any kind of loss such as a limb loss, or any kind of pain problems, or any kind of symptoms that they have at that point of time. And of course, patient has history of psychiatric illness and receiving treatment before. So that's the reason why the risk become moderate rather than low. And then observation, in terms of observing the patient is more agitated. There are restless behavior. There are sometimes a disordered behavior because of other medical problems that they have. Sometimes patient can be confused because of delirium. Sometimes patient can show withdrawal behavior, means that they are withdrawn. They don't want to communicate, or there are ambivalence in terms of treatment. So they are not very sure whether they want to continue with the treatment or not. And the recommended intervention in this kind of group will be, number one, we need to really search their belongings to remove any kind of items that could be used for self-harm, including medication that they keep. And number two, if suicide and if indicated, absconding precaution. Not only suicide precaution, but abscond precaution, because sometimes patient can just go out from the ward and do something dangerous to themselves. And to refer to psychiatry and reassessment of the behavior as per required. And the last group of patient will be the high-risk patient, which is actually when patient made a serious or nearly lethal suicide attempt, whether while they are outpatient or inpatient. Persistent suicide ideation or intermittent ideation with intent or planning of doing something very concrete, such as jumping from the high buildings or taking overdose of medication. Psychotic symptoms, including commanding hallucination, when the patient tell us that they are hearing voices to kill themselves, or recent onset of major psychotic syndrome, including major depressive disorder, bipolar disorder, schizophrenia, or drug-induced psychosis, and then has been recently discharged from psychiatric inpatient unit. These are the red flags, or these are the group of patients that is actually considered high risk. So what will can be observed from this kind of patient? Number one, they can be extremely agitated and restless, and they can be physically or verbally very aggressive, and can be confused, and they are not able to cooperate with us and require restraint. So patient is not able to sit still. They cannot stay in their bed. They will be pacing around in the ward, and we need to restrain them. And of course, in this kind of situation, the recommended intervention will be, number one, we need to search everything, their items, their belongings, to see whether there are things that say dangerous for them. Number two, must be an urgent referral to psychiatric for rapid evaluation. You cannot wait for this. And then there must be a staff constantly observing them. And of course, there are security that can help in terms of observation. We must tell our security officer about this, the problem with this group of patients, so they are also aware when something is not right happening to the patient. And of course, in this situation, once they are medically stable, they must be transferred to a ward, because severe suicidal ideation cannot be discharged home. So we need to take care of the patient after this, and we need to administer medication if possible. The psychotropics, anxiolytics, something to really relax them, make sure that they are able to sleep well, to reduce the psychotic symptoms that they have. So these are the things that we need to do, and maybe we need to restrain the patient. So I would say that will be the gist in terms of prevention and management of the patient. And this is how actually we want to help you out in terms of giving you the general idea in managing suicide, especially in ward or inpatient. So I hope that I can talk a bit longer about this topic, because I would say that 30 minutes cannot really do justice to the topic. But I know that today I have only 30 minutes. Hopefully we can see in the future in a more proper workshop, or maybe a talk about suicide prevention and management. And hopefully that you can
All right. Thank you, Dr. Ahmad Rostam, for the interesting delivery of this topic for plenary 6. Do we have any questions, or maybe Dr. Rostam, you want to add anything since we have another 5 minutes for your session this evening?
Thank you so much for our PGMES team.
Sorry, you have to unmute your mic,
sorry.
Dr. Rostam. All right, you can go ahead.
Unmute already, right? Can you hear me?
Yes.
Okay, thank you. I would say that I have tell you in general what are the things that's very important in terms of managing, and also what are the things that we want to see when we see a patient with a risk of suicide in patient setting. And I would say that in that sense, there will be a lot of question when you see this kind of patient, and the best thing to do is actually to refer to us. You should refer to us for us to really assess the patient, even though maybe the reason for referral might be a bit not that strong. But for me, when people is talking about dying, or you are afraid that people is actually thinking about dying, the best thing to do is actually to refer as early as possible. If you are not able to refer to us to psychiatry, maybe at least you need to refer to our in-house counselor in our hospital or in your hospital. Yeah.
Okay. Thank you, Dr. Ahmad Rostam. We wish you speedy recovery. Thank you for joining us this evening. Yep.
Yeah.
All right. So with that, we end our plenary 6, and we now move on to our final symposium for today. So our symposium 6 is entitled Trauma and Rehabilitation. And this evening, we are honored to have 3 consultants to join us. So the first is consultant rehabilitation medicine. The second would be a delivery of speech from consultant orthopedic surgeon, and the last one will be from consultant sports medicine. So I will introduce the first panel, if I may, for the symposium today. So Dr. Saari Muhammad Yatim is currently the head of Medical Rehabilitation Department, Hospital Serdang. He is also the head of Rehabilitation Medicine Services for the Selangor State, and the Deputy Head of Rehabilitation Medicine Services, Ministry of Health, Malaysia. He received his medical degree from University Science Malaysia in 1998, and later graduated from Masters in Rehabilitation Medicine from the University of Malaya in 2006. He completed his subspecialty training in cardiopulmonary rehabilitation in Hong Kong in 2010, and special training in pulmonary rehabilitation in Chonbuk National University, Korea in the year 2016. Apart from that, Dr. Saari is also a certified medical impairment assessor of the National Institute of Occupational Health, Occupational Safety and Health, Malaysia. We are honored to invite Dr. Saari. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And hello everyone. First and foremost, I would like to thank the Regulatory Committee for inviting me to discuss about the role of rehabilitation and issues management of comorbidities. What is rehabilitation? Rehabilitation refers to physical therapy treatment in the pre-operative setting. The goal is basically to reduce post-op complication and reduce the cost of management. The concept is still new and ever-changing in recent years due to many eye-catching studies. The concept has been found helpful for patients caring for joint replacement, cardiac or abdominal surgeries, cancer-related therapies and surgeries. The aim basically to make the patient fit to fight. which to enhance general health and well-being prior to the major surgery by intervening in the pre-operative period to modify behavioral and lifestyle risk factors. The physiological reserve of the patient is enhanced to buffer the clinical stress response. The concept of rehabilitation basically is to improve the patient functions post-operatively. If you look at this diagram, all patients undergoing surgery experience a reduction in functional status post-operatively, followed by a recovery period. That's in line A. And patient suffering a complication may experience a slower and incomplete recovery, threatening longer-term independence. That is B. And if you see line C, pre-rehabilitation patients are better placed to cope as compared to those who are not have been trained during the rehabilitation. And D, should a complication occur, pre-rehabilitation might be crucial to safeguarding longer-term functional status and independence. There are many focuses on pre-rehabilitation, which include pre-operative strength training, inspiratory muscle training, pre-operative educations, anxiety-reducing strategies, increased patient sense of control, and supplementation. It involves multidisciplinary approach, which include surgeons, anesthetists, physicians, therapists, and others personnel that help the patients, surrounding the patients, and manage what are the needs of the patients pre-operatively. This is a suggested tiered approach to rehabilitation intervention. You can see we can divide into three, in which with the wider one, this can see the everyone approaches surgery. This is a universal patient. For those patients who have specific risk factor support, okay, as well as those who have complex needs. So for the universal patient, this is an example of exercise and nutrition support. So you do a screening for the malnutrition as well as the physical inactivities and prescribe accordingly to the patient need. And for the targeted risk factor, specific risk factor support, they will increase, for example, in terms of exercise, there will be a supervised high intensity interval training as well as resistance program and supplementary inspiratory muscle training program for this patient. And for very complex cases, we will prescribe in terms of exercise per se is high intensity interval training in high risk cases with supervision. So the risk factors rehabilitation strategies include, first is physical activity. So all patients should be screened for these physical activities and should be prescribed with the exercise for this patient. So most of the time patient will be assessed, and then we will recommend for the patient to do some exercise at home, especially pre-operatively, or while patient in the ward while waiting for the surgery. This includes have been suggested 150-minute moderate intensity exercise per week or 75-minute vigorous intensity exercise per week, which in the exercise is not only the endurance that we focus, but also the muscle strengthening exercise 2 or more days per week. So the outcome that we need to look into basically is in improving patient aerobic capacity and develop a lean muscle mass. Second risk factors look at in terms of the respiratory muscle, especially the respiratory muscles. So training for muscle training is very, very important for those patients who are going to surgical intervention, especially for those who are going for general anesthesia. So we should consider IMT in intermediate and high risk patient, in which we have a structured IMT program, and we discussed later about this, and develop muscle. Actually, the aim basically to develop muscle of respirations and reduce the risk of perioperative pulmonary complications. Smoking cessation is one of the preoperative goals. This is very important in order to reduce the risk of infection as well as pulmonary complication post-operatively. Alcohol need to be modified in terms of intake, okay, and then in terms of nutrition, is a must basically in terms of need to be assessed by the dietitian or nutritionist, and need to be correct pre-operatively for any malnutrition with support of the exercise training. And we have to look at the psychological factors of the patients, whether you want to screen the patient using the HADS, Hospital Anxiety and Depression Scale, or even in our countries, and that validated one, basically we have a depression, anxiety, and stress scale, basically that can be used in terms of to screen all the patients to look at their psychological status. The goal basically to improve control of anxiety and depression and develop a self-efficacy for rehabilitation and surgery. So during rehabilitations, basically if you look at in the UK, the National Institute of Health and Care Excellence recommended that this intervention should be included in the cardiac rehabilitation and pulmonary rehabilitation. And they have demonstrated a successful patient engagement and adherence, as well as the risk factor modification pre-operative. So how important is lifestyle method to our health? Okay. And what happened to an individual and in individual after having chronic illnesses? This is a scenario that we often see. The patient is always lying down, whether in the ward, and even some of them at home that most of the time are dependent to the caregivers. We tell our patients that bad is bad. That is, I think most of us, we need to tell our patient the bad is bad. So they have to move around, they have to do some activity in order for them to achieve at a higher functional level, as well as reduce the risk of any complications perioperatively or post-operative conditions. With this immobility, it will lead to what we call it immobility syndrome, or previous word that we call it deconditioning. So in the case of immobility syndrome, they will affect so many systems. We can see from the neurological system, musculoskeletal system, respiratory system, cardiovascular system, hematologic, renal, metabolic, skin, and gastrointestinal. All these will make the patients decline in their health status. So therefore, it is very important pre-operatively patient may improve some functional capacity as well as their endurance. So because post-operative that we see just now, in terms of we have some decline in the functional status that will lead the patient into the immobility syndrome that will lead all these complications if not controlled. So if you look at this paper, the relative risk for all-cause mortality is a low fitness for both men and women as compared to other risk factors. So for low fitness, for a man, the relative risk for all-cause mortality is about 2.3, and for a woman is 2.23. So the risk basically for all-cause mortality in both men and women basically is a low fitness as compared to others. Second is a cigarette smoking and blood pressure control, and the latter is a BMI. So what are the benefits of the physical trainings? So they will physical training in terms of exercise, they will improve, will increase the plasma volume, okay, will increase in terms of red blood cells and to increase the total blood volume. So this will increase in terms of cardiovascular response, and this increase the blood flow to all the active muscles. I'm always tell my patients that skeletal muscle is our second heart. So we need to have our first heart. So by pumping, by moving the muscle, the skeletal muscle, especially the big muscle, especially in the lower limb, that again the gravity help the heart actually is pumping the blood throughout the body. So it is very important in pre-operatively that patients need to be mobilized, need to be moved around for those who can be moved around, and do some exercise or some activities while patient waiting for any surgical interventions. Studies have shown that exercise training on the cardiac risk factors. For example, in diabetes, meta-analysis of exercise program in diabetic patients demonstrate the main decrease in hemoglobin. HbA1c is of 0.8%, and for dyslipidemia, meta-analysis of exercise program demonstrated a mean increase in high-density lipoprotein of 2.5 milligram per deciliter. And for the hypertension, meta-analysis of exercise program demonstrated reductions in blood pressure of 3.4 for systolic and 2.4 for diastolic millimeter mercury. And cigarette smoking and exercise program resulted in higher level of abstinence from smoking at 3 and 12 months. And it's also actually reduce in terms of the reduced weight in obesity patients with mean 6.7 kilogram at 1 year, and the program of cardiac rehabilitation resulted in a significant decrease in depression, anxiety, hostility, somatization, and psychosocial stress. So now we talk about the cardiac and pulmonary rehabilitation. There are strong parallel exists between individuals undergoing pre-rehabilitation and rehabilitation in terms of age, comorbidities, profile, and the program offered. So rehabilitation patients are supported in simultaneous multimodal behavior change, include exercise and activity, smoking, and psychological support. Patients attend weekly or more sessions structured around the supervised access program for cardiac and pulmonary rehabilitations. And cardiac rehabilitation demonstrates cost effectiveness and significant patient benefits. There are various studies on this. This includes secondary event prevention, reduced hospital readmissions, improve in cardiorespiratory fitness, and health-related quality of life. Similar improvement noted in exercise capacity as well as the quality of life in COPD patients that are undergoing pulmonary rehabilitation. So how we want to deliver this rehabilitation to our patient with current conditions, with limited resources. Okay, most existing programs are face-to-face interventions. Even until now, in our center, is a face-to-face interventions, which is including recognize that one size may not fit for all, because we need to look into what are the risk factors of the patient that need to be controlled, And most of the time, the activity is tailored to the patient condition, and the patient's for exercise prescription for each patient actually is individualized. 1 in 3 critical patients prefer home-based facilitated self-management rehabilitations, in which patient need to be consulted in the hospital base or face-to-face and prescribe home-based program for them before they come for the operation or any intervention. Issue with travel distance and other commitment as a key reasons why the patient have difficulty to come to the center-based program. And a systematic review conclude that home-based intervention attain similar outcome to center-based model. So the initiative to more widely use digital healthcare intervention and telemedicine or telerehabilitation witness growing internet utilization and confidence among all the patients. So we have 2 programs. Even in our center in Sedang, we have cardiac rehabilitation programs and we have pulmonary rehabilitation programs. By combining these programs in certain diseases, in certain conditions, we can make it as a cardiopulmonary rehabilitation programs. Especially for now, we are combining this program, pulmonary rehab and cardiac rehabilitation program, for those who have a pulmonary disease plus in case of heart patient. What in the cardiopulmonary rehabilitation program that we can basically look into, include the patient with a rehabilitation. They consists of physical exercise training is the cornerstone, and exercise training session may combine aerobic and resistance muscle training session. This is the usual, or I call it the schedule for the patients. And aerobic exercise training can be continuous or interval, whether it is a continuous in which you can put as patient walking exercise, for example, for 20 or 30 minutes, or you can put as an interval training, for example, at the station by station. And they have a resistance training for the upper limb, leg, as well as the trunk exercise. So the component in cardiopulmonary rehabilitation program include aerobic training, resistance training, optimizations of medications, education on a correct lifestyle, breathing techniques, respiratory muscle training, psychological support, then diet and nutritional counseling. This is an example of the outcome measures for the patients that we use to look at what are the benefit of the program to the patients while when they are going for the cardiac and pulmonary rehabilitations. This outcome that include in terms of the obesity, physiology of the patients, and look at the smoking status, blood sugar, lipid profile, angina, dyspnea, exercise tolerance, effort level, and then the other markers that include the psychosocial as well as the of daily living. Not to forget the medication and the compliance of the medication. Symptom-based model for care for providing exercise rehabilitation program can be divided into 2, whether it is asymptomatic patients or patient with additional breathlessness and fatigue. So for the asymptomatic, the primary goal basically is a secondary prevention. The target group traditionally that we do for all the cardiac patients, post-PCI, post-MI, post-CVT. And then those are potential patients that can be included in complicated diabetes, obesity, post-CVA, and chronic kidney disease, peripheral vascular disease, and other risk factors that can expose patients to the cardiac disease. So the key component is high intensity exercise, moderate to high intensity, and the secondary prevention medications. But for high intensity exercise, you need to prescribe this properly, and then basically need the technological to prescribe high intensity. But for low to moderate intensity exercise, basically we can use a performance test to prescribe the exercise to among the patient. For those who have irritation of breathlessness and fatigues. The focus mainly to improve function and quality of life. This can be done in case of chronic lung disease as well as in the heart failure, chronic heart failure patients and other pulmonary vascular diseases. This is basically symptom-based high-intensity exercise training and education. So, exercise need prescriptions. Exercise is medicine. The principle of exercise prescription include these three basic principles should be individualized, effective, and progressively change. It's not at one level. Okay, there are four basic elements: FITT, the frequency, intensity, time, and time. But usually I will add E, that is enjoyment. Okay, the exercise should include the aerobic exercise, resistance exercise, and respiratory muscle techniques that are most commonly used, especially in the patient for rehabilitation and for the cardiac as well as pulmonary diseases. This is an example of the type of exercise, intensity, and also duration, as well as the frequency of exercise that can be prescribed to the patients. There are some exercise that need to be avoided, especially the isometric exercise for those patients with uncontrolled hypertension. Patient is in failure, for example. Basically, the isometric exercise actually is prohibited among this group of patients. So the protocol of exercise need to be followed. First, warming and cooling down for all the patients is a must to avoid any complication. So this is a protocol of the exercise. I mean, the start with a warm up, gradual increase in terms of the heart rate, about 10 minutes, 10 to 15 minutes, and then after that, the main exercise about 30 minutes. At the time we set for the target heart rate for these patients, the exercise target heart rate, and after followed by the cool down about 10 to 15 minutes. For those who have difficulty in terms of calculating, I understand many of us not really experienced in terms of prescribing exercise for our patients, but this is basic correlations. I mean, these are correlations that we can use that approximately that the patient can monitor their heart rate during the exercise. For example, if you prescribe low intensity exercise, that means in terms of rating of perceived physicians, is about 11 to 12 from 20 rate. And basically, if you look at percentage of maximum heart rate on test, is about 50 to 65% from the maximum heart rate. But if you calculate, for example, to get a maximum heart rate 220 minus age, that is maximum heart rate by age. But patient with comorbidity is very high risk. Some patients may have because some patients is already have some medications, for example, beta blocker. So they are all already in the low rate, for example, in 60. So when you calculate by age, they will be higher. That means they can go for low, not, I mean, it's not low intensity, they can go up to high intensity set. That's why this correlation is quite good for those who are not familiar with exercise prescription. For example, if you want to prescribe low intensity exercise, you can add, okay, resting can encourage patients to do exercise and monitor themselves. The resting heart rate plus 10 to 25. That means this is the exercise heart rate zone. For example, patient have resting heart rate about 10, around 60. So 60 plus 10 and 25. That means it's a 70 to 85. That is the, we call it exercise heart rate zone for the low intensity. And for moderate, you can add 20 to 35 from the resting heart rate. Then, for example, just now it's a resting heart rate 60, that means 80 to 95. And for the high intensity, 30 to 55. This is something like a guidance for us in prescribing exercise to our patients. And if we think at beginning of the program, for example, for prehabilitation, we should start at low and go for the moderate intensity. Usually high intensity patients need to be tested, on the exercise testing. This is a Bob rating of perceived decision scale. Also we can use this, but we need to train the patient in terms of this scale, how they differentiate their endurance status. Okay, this is a desirable range of activities. If you use a 15 scale, then 6 to 20, this is 11 to 13, and for 10 scales, about RPE basically is 3 to 5. So warm-up exercise is a light pulse rising activities about 5 minutes, stretching activities about 5 minutes, and light pulse rising activities about 5 minutes. So we can be done indoor as well as outdoor. So we can do indoor activities for our patients, even for the cardiac, pulmonary, and also prehabilitations. Or we can make it outdoor activities by prescribing walking exercise through 6-minute walk test finding. We can prescribe exercise for the patient in terms of the distance, how far they have to walk for certain minutes, for example, for 20 minutes or 30 minutes. And then the protocol itself, cool down after exercise is very, very important to reduce in terms of the muscle fatigue and as well as to reduce the lactic accumulation in the muscles. And then they have to do some like activity for 5 minutes and also stretching for another 5 minutes. These some guide to exercise as well as the activity level. So very light in terms of self-care, washing, shaving, and dressing actually is a very light activity. And then in terms of occupational, for example, clerical work, standing, driving trucks. Some people driving they think is very light, okay. But for the recreational, like for example, the indoor bowls, billiard, archery, golf also is considered very light. And physical condition, basically walking at the level of 3 kilometers per hour. Or the stationary bicycle is very low, the distance that we consider very light activities. And if we go for light, 3 to 5 minutes, I think this is the guided in terms of what are type of activity of self-care, occupations, and recreations, as well as in terms of physical conditioning. So if you want to target for 3 to 5 minute activities, okay, this is about walking about 3 to 5 kilometers per hour. So the patient will walk on the treadmill. We can set in terms of 3 to 5 kilometers per hour. That is considered light, and that is considered low intensity for these patients, as well as light calisthenic exercise, okay, and as well as a level bicycling. This is about 3 to 5 minutes. For moderate intensity, moderate activities, it's about 5 to 7 minutes. For the exercise like walking at 5 to 7 kilometers per hour, bicycling, swimming, that is considered is a moderate intensity of exercise. But you can correlate in terms of their other physical activity in terms of functional as well as in terms of their occupations. What they can do at home, that almost they can go up to the 7 minutes in terms of the activities. This is a heavy, that is considered high intensity, 7 to 9 minutes. This includes jogging, swimming, rowing, using a rowing machine, heavy calisthenics, as well as bicycling. Other recommendation of is a respiratory muscle training, which is the respiratory muscle training. The type of exercise basically is respiratory muscle training. This is very important in order to reduce the risk of delayed in extubation, especially in post-operative condition. And in terms of frequency, should be done daily with intensity 15% to 60% of maximum expected max pressure, and the time about 15 to 30 minutes of exercise. Other recommended exercise modality for rehabilitations as well as we use in the cardiac pulmonary rehabilitation is Tai Chi as well as Qigong, which are benefited for certain group of patients. It's helped to improve balance, increase strength, increase functional mobility, increase flexibility, increase cardiovascular function, enhance sleep quality, reduce fear of falling, and improve quality of life and psychological well-being. Others exercise like swimming, or we call it aquatherapy, and also home-based training with remote monitoring devices. So basically, exercise improve efficacy in both cardiac rehabilitation as well as pulmonary rehabilitations. Okay, they improve ventilation aerations, central blood flow, peripheral blood flow, and active muscle metabolism. These can be enhanced, can be adapt into the prehabilitation for pre-operative condition and management of comorbidities. Only one agent exists with lipid lowering, antihypertensive, positive phenotropic, negative chronotropics, vasodilating, diuretics, anorexigenics, weight reductions, cathartic, hypoglycemic, tranquilizing, hypnotic, anti-depression, and the qualities of life, which is exercise. If the exercise can take as a pill, I think many of us will buy this pill. But exercise need a physical movement. I think by that, thank you very much for your attention.
Okay, thank you Dr. Sa'ari for that enlightening topic this evening. Selalunya kita dengar pasal rehabilitation saja. Petang ni kita dengar sikit pasal pre-rehabilitation dan cardiopulmonary rehab program. Okay, untuk participants dan anyone who has any questions, you can post it and we will address your questions at the end of this symposium. So it is now my honor to introduce you our next distinguished speaker, Mr. Muhammad Azhar bin Abdullah. He graduated from International Islamic University Malaysia in the year 2007 and obtained his Masters in Orthopedic from University Science Malaysia in 2015. He currently is the consultant orthopedic surgeon in Hospital Sultanah Bahiyah, and his topic for this evening is elderly neck of femur fracture pathway from orthopedic perspective. Please welcome Mr. Azhar.
Assalamualaikum and very good day to everyone. First of all, I would like to thank to the chairperson and the committee of PGMES Hospital Sultanah Bahiyah, Ustaz Kedah, inviting me to share the topic of fracture neck of femur. My content of the talk today will include introduction, anatomy, risk factors, classification, clinical features, investigation, management, and complication. For the introduction, typically neck of femur fractures result from low energy impact associated with osteoporosis bone. Most fractures are intracapsular and compromise blood supply of the femoral head. Wherever in young patients typically result from high energy impact and other associated injury are common. In this graph, studied by Greenknop, CG, Jones, and civilians of the neck of femur fracture in elderly. It was published back in 1998. You see the graph, neck of femur fractures is more common in women and it's happened at more than 70 decades. Anatomic consideration in neck of femur. Actually, the neck of femur is a dense bone, which has subchondral region, center of the head, point of the purchase. A neck approach shaft cross section change from circle to rectangular. Neck shaft angle between 125 to 135. If it is less than 125, it's called coxa, whereas more than 135 degrees, we may say is coxa valga. The center of rotation of the hip at the below tip of greater trochanter, if above the greater trochanter, if it is a valgus hip, if it is below the greater trochanter, it is a varus hip. Regarding the blood supply of the femoral head, major contribution is from medial femoral circumflex artery. Some contribution to anterior and inferior head from the lateral femoral circumflex artery. This both medial circumflex and lateral circumflex is a branch from profunda femoris artery or deep artery of the thigh, which is origin from the femoral artery. Some contribution from inferior gluteal artery, and small and insignificant supply from the artery of ligamentum teres. So intracapsular arterial supply arise from ascending branch of lateral circumflex femoral artery and ascending branch of medial circumflex femoral artery. These will form a ring at the base of the neck. Branch of small artery arise from ring, piercing the capsule to become a retinacular arteries. The retinacular arteries supply intracapsular neck and also more than 80% of the head of femur. Neck of femur fractures can be classified into intracapsular or extracapsular. Intracapsular fracture, the fracture happens from the subcapital regions of the femoral head to basocervical region of the femoral neck, immediately proximal to the trochanters. Extracapsular, outside the capsule, are divided into intertrochanteric fractures, which are between the greater trochanter and the lesser trochanter, and subtrochanteric region, which are the fractures happen inferior or below the lesser trochanter, 5 cm distal to the shaft. Classification by location: fracture line, subcapital, immediately below the head of the femur, transcervical, which is the center of the neck of the femur, basicervical, at the base of the neck of the femur. This classification as well can be divided into Gardner classification and also Power classification. The classification according to Gardner classification, most commonly used classification system, based on the degree of displacement. Gardner classification is determined by the AP pelvis radiograph. Classification regarding the Gardner classification, we have a stage 1, stage 2, stage 3, and stage 4. In stage 1, Gardner 1 stage 1 classification, the fracture is undisplaced and incomplete. Whereas in stage 2, the fracture is complete but is still undisplaced. In stage 3, the complete fractures but incompletely displaced. In stage 4 is a complete fracture with complete displacement. For the Power classification, this classification is based on the angle of the fracture line makes in reference to horizontal. Type 1 is less than 30 degree from horizontal. Type 2, 30 to 50 degree from horizontal of the fractures. Type 3, more than 50 degree from the horizontal, which is most unstable. And this is higher risk for avascular necrosis. These are the Power classifications. Risk factor: the neck of femur fractures can happen in Caucasians, female, as we saw in the graph before, patient with neurological impairment, which are high risk for trivial fall, malnutrition, patient with weakness, generalized weakness, impaired lesions, malignancy with pathology bones, or decreased physical activity, where the bone will turn over to disused osteopenia. In young patients, typically it happens with a high energy trauma. Clinical features: post-fractures, patient unable to walk. If it is a pathological fractures, may have pre-fracture pain, limb pain, hip inflection position, shortens and externally rotate. Investigations: X-ray, hip, anterior posterior view and lateral view, as well as pelvis AP view. Tomography might be useful if fracture suspected, no evidence on the X-rays. If doubt, MRI scan most accurate way to ascertain whether a fracture has occurred or not. Management: general condition of the patient have to be stabilized. Of course, the vital sign, hydration status, as well as the metabolites of the patients. For the pain, we can have to control with non-pharmacological, with tractions, and also pharmacological by analgesia. Fracture treatments. The aim of the fracture treatments is pain-free, early rehabilitations, resume back pre-fall functions. Non-operative, observation alone, considered in some patients who are non-ambulating, have minimal pain, and who are at high risk for surgical interventions. For the operative, open reduction internal fixation, fracture in young or physiologically young patients, indicated for most patients less than 65 years old age, and replacements in elderly patient which is more than 65 of age. Treatment: for operative treatment, cannulated screw fixation in undisplaced transcervical fractures in Garden 1 and Garden 2. In displaced transcervical fracture in young patient, considered as a surgical emergency because the risk of avascular necrosis is high. In displaced fracture, Garden 3 or Garden 4, age less than 60 years old, internal fixation can be considered, whether with cancellous screw or dynamic hip screws. Sliding screws or plate with dynamic hip screws. Use 2-hole plates or 3-hole plates, depends. Screw head lie in the center of the femoral head and line within the next axis. 135 angle usually being used. These are the example of 3 partially threaded screw can be inserted in inverted triangle configuration, or 4 screw can be placed in diamond configuration. Significant comminution is present. These are the example of dynamic hip screws with the leg screws in the center of the head of femur together with the side plates. Age more than 60 years old, in certain countries even more than 75 or 65. Cut-off age around 60. We highly advise those patients with good active daily living activity and also independent of daily living activity, and also with community ambulators. We highly advocate this patient go for replacement, whether total hip replacements or hemiarthroplasties. Indication for arthroplasties: comminuted displaced femoral neck fractures, especially in elderly, pathological fractures, poor medical condition, poor ambulatory status before fracture as well. These are the example of hemiarthroplasties which last since 1970s. You can see some example of Austin Moore, Thompson's, and also currently we came to era of bipolar hemiarthroplasty. So there are some guide where they want to decide for hemiarthroplasty or total hip arthroplasty. Brockmark and et al. With their perspective study back in 2018, which was published in Journal of Bone and Joint Surgery. They use this classification, this as a guide for decide whether a patient is candidate for total hip arthroplasty or hemiarthroplasty. If the patient age in between 70 to 80s, the points become 5, more than 80 is 2. In terms of habitat, whether patient is a community or with a home, own home or sheltered home. Patient with variables with walking aids, 1, cane or none, 5 points. With canes or walking frame, 2. How about the mental status? Patients alert, conscious, about 5. Those are slight confusions like patient in Alzheimer's, patient demented. The marks is given 2. A score more than 14 indicates treatment required with total hip arthroplasty. If less than 14, we highly recommended this patient for bipolar hemiarthroplasty. This is an example of bipolar hemiarthroplasty, where the replacement only take place on the femoral parts. Okay. And then but the acetabular component still remain with the native acetabular. These are example of total hip arthroplasty, where the component of the replacement including the femoral component and also the acetabular component as well. So the difference regarding internal fixation and also arthroplasty. There's a pros as well cons regarding the open reduction internal fixated and arthroplasty. Regarding the non-union rate, internal fixation is high, regarding 20 to 30%, whereas in arthroplasty you don't have to worry about union because you already given the patient new hip. Regarding the avascular necrosis, of course, in internal fixator still can happen 10 to 20%, whereas in arthroplasty you don't have to think about that. Regarding the sepsis around the implant, of course, in internal fixation is rare, but it's high because it's a major surgery, 2 to 5%, and the mortality more than 50%, depends. Okay. And about the dislocation, can be avoided in internal fixation, but arthroplasty, of course, there is a risk of dislocation, 4% in hemi and about 10% in total. Regarding acetabular erosion, can be avoided in internal fixation, but for the long term, the survivors in hemi especially, about 20% of erosion. Prosthetic loosenings can be avoided in internal fixation, but about 10% in arthroplasty. Refracture around the implant is rare in internal fixation, but possible in arthroplasty where patient presented with periprosthetic fractures. Reoperation rate, internal fixator need to be conversion about 25 to 30%, whereas in arthroplasty it depends, less than 10% unless loosenings and other associated like infections. Regarding the mortality, early mortality is lower and early mortality in arthroplasty bit higher. Hospitals say most of the time internal fixator is a short stay, relatively. For the arthroplasty, a bit longer, but it's not more than about 3 to 5 days. Cost of treatment, of course, internal fixator is much cheaper in arthroplasty in the expensive side. Regarding the arthroplasty, the hemiarthroplasty can be cemented Thompson's, cemented bipolar hemiarthroplasty, or uncemented, those days using porcelain mold, which is found to produce more typing. That's how they come to the era of hemiarthroplasty, bipolar hemiarthroplasty. For the total hip replacement to be considered in coexistent osteoarthritis, rheumatoid arthritis, or present of damage to the acetabulum, markedly inferior result to total hip arthroplasty compared to open reduction internal fixation. Postoperative management in young, for non-weight bearing crutches for 6 weeks, then for full weight bearing, you want to get the union in the neck of femur, whereas in old, full weight bearing as soon as possible, especially patient with hip replacement. The advantage of hemiarthroplasty over open reduction internal fixation: allow faster full weight bearing, eliminates non-union, osteonecrosis, and fixation failure. Disadvantage: it is more extensive procedure as more blood loss, risk of accidental erosion in active individual. Complication of open reduction internal fixations, osteonecrosis, non-union, fixation failure, infection, dislocation, DVT, and pulmonary embolism is still possible. Thank you.
Thank you, Mr. Azhar. We welcome any questions to Mr. Azhar via our chat box. Now let me introduce our third speaker of today, Dr. Muhammad Fakrusani bin Abdul Hamid, graduated from University Malaysia Sarawak, UNIMAS, in 2010 and obtained his Masters of Sport Medicine from University Malaya in 2019. He has been involved in sports coverage in multiple sports events all over Malaysia. He is a committee of Majlis Sukan Negeri Kedah and Malaysian Association of Sports Medicine. He currently is our sport medicine physician here in Hospital Sultanah, Bahiyah. I invite you to pay our speaker, Dr. Fakrusani, your undivided attention as he indulges us with his expertise on the topic of sports injury and post-surgical rehabilitation. Please welcome.
Assalamualaikum and very good afternoon. My name is Dr. Muhammad Fakrusani bin Abdul Hamid. I'm a sport medicine physician in Hospital Sultanah Bahiyah, Alostar. Thank you, committee, for inviting me for this scientific meeting. So today I will discuss on management of sports injury and post-surgical rehabilitation. So we only have probably around 20 minutes to discuss, and I won't go much into details. And basically, we just to have a look on the overviews on the principle of management of sport injury and also post-surgical rehabilitation. And we have a simple discussion. Since this is the last talk of the meeting, so probably we just go through our very easy session. All right, so basically, okay. This is the overview of the presentation. I will briefly describe on what is sport injury, simple approach and basic management of sport injury, and just going to discuss on the post-surgical management. So mainly what we discuss here today mainly on acute injuries, right? So sport injury, what are the sport injury? So commonly, very common among athletes and also general population, it can occur during sport activity or non-sport related activity such as ACL, tear secondary to motor vehicle accident, something like that, not necessarily due to sport injury. So IOC manual sport injury, they give a description, definition of sport injury: damage to the tissue of the body that occur as a result of sport, exercise or physical activity. Whereas Macno and Kalmus describe as an event occurring during a match or training session that require medical attention, including self-treatment, which cause the player to miss at least one scheduled match or team training session. So basically, there's quite a number of definition of sport injury. But basically, what we accept is when there's a presentation of common sport injury on our side related to sport or non-related to sport, we call it the sport-related injury. Okay, basically, when we discuss on the sport injury, usually we will specify into two, whether it's acute or overuse injury. The latest description that we describe in the other term, but usually what we use is acute or overuse injury. If acute injury, it could be direct or indirect. For example, like you have a direct blow to the injured side, or any contact with the player or equipment, such as hockey players, contact with the hockey sticks, something like that, right? And then when they can have an indirect, such as the ligament sprain or muscle tear, which is okay during sudden stopping or twisting mechanism. Okay, as we go for the overuse injury, mainly because of the repeated overloading or repeated stress to the structure, which cause the predisposed to injury, and also probably inadequate recovery time between loadings, or probably too heavy exercise without proper resting. So that also can predispose to overuse injury. But mainly today, what we discuss, we will go through on the acute injury. So basic classification, this is described in Bruckner and Hunt. We can describe based on the structures and also whether it's overuse or acute. For example, if it's involving the bone, it can present it as fracture or posterior contusion, whereas an overuse injury probably can have a stress fracture. Injuries also can involve articular cartilage, the joint, the ligament, muscle, tendon, sprained ligament, muscle strain, or tendon tear. Okay, basically, when we want to describe the management of sport injury, there's one paper published in 2020, Sport Injury Rehabilitation Update. So they have a very good, a very simple flow of management of sport injury, starting from the rapid assessment up until the prevention. So basically, the first management that we start with sport injury, usually we start with the rapid assessment, which involves our acute management, whereas involving the assessment of airway, breathing, circulation, consciousness, extremities. This is the basic, all we describe is the on-field management. All right. So basically, when the patient comes to the clinic, presented to the clinic, usually what we advise on the immediate treatment. So the first few days or the first 2 weeks, which involve price, police, peace and love, no harm principle. So this which we will describe later on in our presentation. And then we want to know when we want to refer, what type of cases we want to refer. And the last one, we proceed to the sport rehabilitation, where we want to rehab so that the athlete, so that the patient can have a level of activity before the injury. So acute sport injury management, the first aid management is very important. So basically, what we'll call it practice is rest, application of ice, compression bandage, and elevation. And basically, over the past few years, this approach has been evolving a lot. So initially, we describe as RISE, and then evolve into PRICE, become a police, and the latest one is peace and love. What is PRICE? Described in Sport Injury Rehabilitation Update. This is a simple abbreviation, PRICE. All right. So the first one, you want to protect the injured site. Just protect the injury, prevent further damage by probably using simple splint or brace to support the injured joint. Why? Because B is probably we want to allow the early return to function, right? And then we want to rest the injured site as well as rest the injured patient, the injured athlete, right? So the injured athlete should cease activity immediately. So because if you continue to play, probably you can cause more damage. And most important thing, what we do is ice compression. We can crush ice in wet towel or plastic bag. Usually I practice in plastic bag. We can use a sponge with icy water, commercialized cold pack ice application. So usually what we do, we apply around 20 minutes for every 2 hours in acute injury. And usually we advise the patient not to apply ice directly because there's a risk of ice burn as well. So probably around 20 minutes should be sufficient. Basically, we use ice to reduce pain, reduce the swelling, reduce the bleeding at the injured site, and also muscle spasm. For example, if you have a nosebleed, ice very useful in terms of reducing the bleeding. And we do some compression as well. We can apply some firm elastic bandage over the injured site after the ice application. So the compression, the theory of compression, probably we want to minimize the swelling, reduce the swelling, and provide support to the injured part. And we want to elevate the injured part above the level of part to reduce the swelling, again, reduce the pain, and reduce the bleeding. So this is a simple diagram I got it from the internet. PRICE, P-R-I-C-E. Simple advice, we can memorize it, then we advise the patient. This is still practiced even in current practice. But over the last few years, back in 2012, the paper, they want to update the price. So they question whether the price is sufficient. Then they describe as police, P-O-L-I-C-E. And what changes is in these changes they describe is the change of R to OL to become police. which is OL is the optimal loading. So why we want to introduce optimal loading? Because they found out that most of the clinicians, they tend to over rest the injured side. So basically we want to balance an incremental rehabilitation. We want to create a program where the early activity encourage early recovery. Because if you have a longer period of unloading, probably is harmful and produce adverse changes to tissue biomechanics and morphology. And they found out also the optimal loading promotes repair, remodeling, build tissue tolerance and capacity of tendon, muscle, and ligament through the mechanotransition. So basically, we don't want to rest the injured side for too long. So they introduce here optimal loading. So basically, now we tend to ask the patient to start early mobilization, early weight bearing to promote healing. So again, this is a simple description from the internet again. They changed the R here to OL, optimal reading, the simple description as well. While rest may be helpful short term, continued rest may lead to joint stiffness, muscle weakness, and poor balance. So you just do as much as you feel comfortable, but not pushing through pain. So basically, that's what we advise the patient. Right. And then again, from Price, Police, and the latest one back in 2020, they proposed another one, which is they call it Peace and Love. This is published in British Journal of Sport Medicine in 2020. So what is peace and love? Basically, it's more or less the same, but a bit of changes. Whereas the Price and Police, what they describe as Price and Police, they mainly focus on acute management, and they say ignoring the subacute and chronic stage of tissue healing. So they propose the rehabilitation continuum from immediate care, which is peace, to the subsequent management, love. And it also this principle also outline the importance of educating patient and addressing psychosocial factors to enhance recovery. So basically, we just go go through this peace and love. So basically, again, more or less the same. P is protection. We unload or protect the area of injury. We elevate, promote the tissue flow out of tissue. Basically, you want to reduce the swelling. The change that we see is A, where they advise avoid anti-inflammatory and they advise usage of ice. So basically, what their argument is, because they say the anti-inflammatory, yes, it inhibit inflammation using medication, which may negatively affect long-term tissue healing, whereas they argue ice could potentially disrupt inflammation, angiogenesis, and revascularization, delay neutrophil and macrophage infiltration, which is very important in healing. But again, when I read through the reference, they found basically what are their description based on the in vitro study on the animal study. So basically, that's why they proposing avoiding ice. Again, more or less the same. They said you just apply compression, and we educate the patient on the benefit of active approach of recovery. Right. So basically, what now the approach here, we try to educate the patient as well, and then we introduce love as well. We give load, same, more or less the same like optimal loading. We give mechanical stress should be added early as the symptoms allow, so that we can have a healing process started. And optimism, more on the psychological aspect. Vascularization, early vascularization. What they discuss here is early mobilization and aerobic exercise improve physical function, support return to work, reduce the need pain medication in individual with musculoskeletal condition. So basically, what they advise is you have to do cardiovascular exercise so that increase blood supply to the injured area. So basically, instead of doing a focused rehabilitation on the injured side, you want to do cardiorespiratory exercise as well, such as probably cycling, something to improve the blood supply. Right, and then the patient to do exercise to restore mobility, strength, proprioception, and then early after the injury. Again, this is what they propose. PEACE and love is one you can get online. So basically, what are the practice that we practice here? Still practice usage of what a practice is a combination of all. So basically, we are still using ice. It's just that I did avoid anti-inflammatories at the early phase of the injury. Basically, we try to control pain with ice. Most of the patient can cope with ice. But other than that, also we apply this principle as well. So again, in acute injury, we should apply no harm principle. Apply no heat, because if you put heat to the area, can cause blood flow and then increase swelling. That's a theory that we apply. Then we avoid alcohol because it can give inability to wear of aggravated injury, and also increase blood flow to and then swelling to the injured side. Again, no running, no row injury, because early activity also, too early activity can aggravate the injury, and also no massage at the early phase. So probably later on or overuse injury, that one probably massage be beneficial, but in terms of early management of injury, probably we avoid massage. So this is just a simple, again, a pictogram of the no harm principle. No heat, no alcohol, no running, and no massage. Again, you want to know when you want to refer. This is when the patient has unconsciousness, breathing difficulties, abdominal pain, or when you have any injury. The most important thing is if you have any injury when there's a doubt of severity, you're unsure of mechanism, you're unsure of severity, you're unsure of diagnosis, you just refer to get the opinion and proper management for the patient. So we go to the sport rehabilitation. We rehabilitate the patient, the injured athlete. So the process of returning athlete to the pre-injury level or athletic performance. So our aim, we want to patient to return to sport full function in the shortest time possible. So the key component is very important. We want to have muscle conditioning, flexibility, neuromuscular control, sport skill, correction of abdominal biomechanics, cardiovascular fitness, and also the psychology part. So this sport rehabilitation also this is where the component here also is applied in our post-surgical management of sport injury. So basically, if you want to do or you want to advance rehabilitation, you want to know the soft tissue response to injury. You want to know the healing time. So we must understand proper pathophysiology. When is the time of acute inflammation? When is time proliferation? When is the remodeling phase started? That will help in terms of our management or designing the rehabilitation for the patient based on the injury. Okay, so basically we have a few phases, and then these phases have specific goals and therapeutic intervention in each of the phase, and our call it management is goal directed, and we proceed accordingly with each assessment. And the most important thing, as I mentioned earlier, we have to respect the healing tissue. I mean, we cannot go too fast or we cannot go too slow. Otherwise, we cannot get the optimal rehabilitation for the patient. So basically, a simple approach of sport rehabilitation program, which is also applicable in our post-surgical patient. In initial phase, post-op, we apply ice, police principle, analgesic to control the pain, to get the patient comfortable. We want to protect the graft, protect the repair. And then initial phase, recovery phase, we call it recovery phase. We start with range of motion, do some flexibility, stretching exercise, start with strengthening exercise. If patient can do proprioception, balancing, and then we want to maintain the fitness level. And then we proceed with the functional phase, where we more include into the neuromotor component, include the speed and agility training to get back the patient neuromotor control, involve some plyometric or jumping training, and also maintaining the proprioception. And the last one is return to play or return to work phases, where we want to do the maintenance phase, and we want to prevent the recurrence of the injury. So acute phase applicable in our post-surgical management as well. We want to relieve pain. Our aim, we want to relieve pain. We want to prevent the further injury. We want to minimize the hemorrhage or edema. We want to protect the graft. We protect the repair. So basically, what we do, we apply the police protocol, that sort of thing, because we want to control the pain. In phase 2, the recovery phase, we want to promote the reparative process. We want to avoid further damage to the tissue. We want to correct the biomechanical deficit, improve muscle control and balance, and retrain the proprioception. Whereas this is where we start doing the range of motion, as I mentioned earlier, stretching exercises, start with close kinetic chain strengthening exercises, do TNF stretching, and also dynamic strengthening. And again, we can get involvement from our physiotherapist colleague, which in terms of the pain management, to control the pain via ultrasonic therapy, heat therapy, or electrotherapy. Then, if the patient can tolerate with the phase 3, we go into the progress into the functional phase, where we increase the power and also endurance. We improve the neuromuscular control. We work on the kinematic chain. So this is where we try to go a bit more agile or a bit more aggressive in terms of call it training. We include plyometric exercise. We do motion training, multi-plane neuromuscular control. And then in this phase also usually patient already achieve basic strength and also flexibility where we want to maintain. All right, and then some patient or some athlete we do the sport specific training. So let's say if the patient footballer, probably he try to have isolated training with a ball, kicking the ball, dribble the ball, and then later on just progress from there. Then the last phase will be the return to sport or return to competition, whereas the athlete return to play. So basically, after they have completed the phase 3 where we have a specific for tests, then we proceed with the return to sport. So basically what we do, we want to maintain the exercise, we want to prevent the re-injury. So in summary, acute management of sport injury, we have a price, police, and peace handler protocol. Usually my advice, you go on read just familiar with those three and then just combine it together. But probably in terms of, but the most important thing is the immobilization. You probably don't want to immobilize any injury too long unless you see there's a very clear cut where you need to immobilize, right? Do no harm in acute injury, which is no alcohol, heat, running, and also they call it massage, right? Avoid prolonged rest, as I mentioned earlier. And again, it's the sport and post-surgical rehabilitation. We know that each patient is, call it individualized. No one is the same. So you want to design each patient. Probably you have to go different protocol. Not all patients will have a same protocol, right? When you have the protocol, it acts as a guide, and then we just see the goals, and then we progress from there. Again, though, remember, we just must respect the healing tissue. We not go too fast or we don't go too slow. And again, if you are treating rehabilitation, you're a physiotherapist, you are the one handling the rehabilitation. You have to get a good communication with the operating surgeon. We want to confirm the procedures. We want to know what are the injuries, what are the repairs, so that we can design a proper rehabilitation program for the patient. So basically, that's all for the present. For our discussion today was the basic management of sports injury and also post-surgical management. I hope you guys have ideas of what the basic management is. Thank you very much. Again, if you have any further question, then you can ask during the Q&A session. Thank you very much.
Time for this symposium. Okay, so since we don't have any questions from our chat box, maybe we give a few minutes to you, Dr. Fakrusani. If you have any 1 to 2 minutes additional.
Well, I
anything
think,
that you want to say, you can unmute your mic.
Okay, all right. Okay, thank you, Doctor, for giving me 1 or 2 minutes. Otherwise, I think what I presented in my presentation just now, I think it will be just very superficial and just an introduction, basically on how to manage sports injury and also post-surgical management. So in very short period of time, probably around 20 minutes, I cannot go through a lot, but at least we get some of the principle and how to manage basic management. I think it should be okay. Otherwise, thank you very much for the opportunity to involve in this meeting.
All right, thank you, Dr. Fakrusani. Do we have any additional messages that you would like to convey to us, Dr. Sari? Thank you for joining us this evening, all the way from Serdang, Selangor. Yes, please. Can unmute your mic and give us a few words.
Yes, Assalamualaikum. Very good evening, everyone. So I think it's thank you for this opportunity actually for me to share about cardiac rehab as well as prehab, what call it cardiopulmonary rehab. So I hope everyone can learn something about this, especially the prehabilitation, in which that we found that combining cardiopulmonary rehab incorporate with prehabilitation actually have a very good outcome in most major surgical patients. So I hope we can learn more about this, and we wait for further, high impact articles that actually can provide us more confident in providing this kind of services about prehabilitation. I think thank you very much for everybody. I hope you learned something about the cardiac and cardiopulmonary rehabilitation. Thank you.
Thank you, Dr. Sari and Dr. Fakrusani. With that, we end our Symposium 6 for this evening. So for now, for the highlight of the event of the 12th PGMES Biennial Scientific Meeting, I would like to call upon Dr. Joash. Thank you very much.
Thank you very, very much, Dr. Nurul, for chairing the final symposium. It's me again, I'm Joash, Deputy Secretariat. We have now come to the closing ceremony of the 12th PGMES Biennial Scientific Meeting. It has been quite a journey, quite a ride, and I believe I speak on behalf of the entire committee to say that it has been a very interesting, a very exciting 4 months. And the truth is that this Biennial Scientific Meeting was supposed to happen in the year 2020. But we all know how that went. COVID, MCO happened. The society reoriented the focus in helping our frontliners, helping them to get back on their feet, to stay supported, and to provide this hospital with as much services and as much support as we need. And now that we are back here differently in a virtual sense. It's very unusual for our speakers and for our chairpersons to speak to a relatively empty hall, to stare into a screen right in front of us. But we have much to be grateful for. So during this closing ceremony, we will be announcing the winners of our various competitions, from the posters to the oral presentations and finally the popular votes. But before we do that, we have a lot of things to say. So on behalf of the committee, we would like to say thank you to notably a number of people. First and foremost, we would like to thank Web Soho, our team, which comprises of Puan Nadia and Encik Hashim, for their very, very good services provided and their steadfast duty provided to the committee. We want to once again thank our sponsors for their support, for the generosity, and for providing the society with the resources and the speakers to share their expertise. Once again, Takeda, our gold sponsor, Novo Nordisk, our silver sponsors, our co-sponsors, AstraZeneca and Abbott, and also to our other sponsors, which includes Mundi Pharma and Boehringer Ingelheim. We also want to thank our faculty members, both internal and external, the 36 faculty members that made this event possible. There is so much that we can say, there is so much gratitude that we can express, but truly no words could possibly express how grateful we are for them to take time out of their busy schedules to record their various lectures, to come up with the latest updated guidelines, and to look through the evidences to prevent what is truly a very remarkable scientific meeting. And last but not least, most important of all, we want to thank you, all of you participants who are here today, who have persevered, who have been very patient with us as we sort through one audio technical issue, any IT technical issues, one at a time. So for all of you who have stayed to this very point, thank you very much. We are very grateful. And it is our hope that in the 13th scientific meeting, we will be able to meet once again in person. So with no further ado, I'd like to pass the time now to our to our organizing co-chair, Dr. Ahmad Afifi, to announce the winners of our various competitions. Ladies and gentlemen, Dr. Ahmad Afifi.
Thank you so much, Dr. Josh. We finally reached our end of today's session a bit earlier than what we planned. And we certainly hope that you have enjoyed the 3 days seminar, 2.5 days to be exact, with so many tribulations that we feel humbled, and we hope that we and you, of course, all of you as participants will together with us learn and get positive benefits from the whole conference sessions and topics that has been provided. And my job here is to announce winners of our scientific awards. Can I ask for my assistant to share a slide, please? So we have in total nearly 70. Whoops. We have in total nearly 70 submission of scientific abstracts. And after filtering through and adjusting for those who are suitable to be adopted in our scientific sessions for abstract submissions, we finally resort to 65 abstracts to be judged by our scientific team to be selected as oral presentation and remainder of abstract as a poster presentation. So in total, we have 5 oral presentation, and the oral free paper presentation, which was conducted yesterday, was judged by Dato Muhammad Razi Abu Hassan, Dato Dr. Siti Sabzah Muhammad Hashim, Dato Dr. Selina Muhammad Ali, and Dato Dr. Wan Kamizawan Kazim. And we have 5 very interesting, excellently conducted studies altogether presented as oral presentation yesterday, with two-way communication Q&A with the first author who submitted their abstracts. And I'm glad to say that we are very proud to announce the winner, but we can't have any we have showed the first and second, so there's no drum roll. So that is the result in front of you. So the first prize would go to self-reported symptom study of COVID-19 chemosensory dysfunction in Malaysia by Dr. Lee Shen Han et al. And his team. I just have to add a few notes on this study. Dr. Siti Sabzah has withdrawn herself from judging the paper, but the lowest mark from the 5 overall adjudication was added on top of the the 4th marking for this abstract for this oral presentation. And Dato Dr. Razi himself was happy to listen to the presentation, and he felt that that even when this study was just published, it should not be a hindrance to be submitted as part of the oral presentation of our meeting, our biennial scientific meeting in Hospital Surabaya. So the second prize goes to skin prick test reactivity to common allergens amongst clinically atopic patients by Dr. Yap Hui Jin and her team. Let's give her a round of applause. And the third prize goes to spray as we go method versus spray catheter method. Which one to settle for by Dr. Ye Kuan Yao and his team. Another round of applause. And not to forget, the first prize will have the first prize award is 600 ringgit cash prize. Second is 300 ringgit, and the third prize is 200 ringgit. And all of the consolation prize will go to the 2 oral presenter. And let's now go to poster presentation award. Next slide, please. So the judges for best posters are Mr. Johari as a representative from surgical department, Dr. Noor Rafati representing medical internal medicine department, Dr. Taneswari representing obstetric and gynecology department, and Dr. Noor Asmaliza representing pathology department. So it's a multidisciplinary committee judging the poster presentation. So who is the best winner for best poster award? It goes to, okay, so the first prize goes to Efficiency Evaluation and Determining Factors of Thalassemia Care Service by Dr. Nur Shahirin Mohammed et al. And I believe this paper is supported by CRC. In fact, all three papers were heavily supported by our CRC, which shows how good is our CRC supporting research from the hospital. So please extend your hand to the CRC. You need to get them to be involved in your study, and they will certainly furnish you with all the necessary help and assistance. Second prize goes to epidemiological investigation of a COVID-19 community cluster in Kedah, Malaysia by Muhammad Azri Muhammad Swan et al. And his team. Another round of applause to his team. And the third prize, I know her personally because she worked in our ICU. She's a clinical pharmacologist, and I'm very proud to announce this. The third prize goes to knowledge, attitude, and practice of nurses on medication administration through enteral tube feeding in hospital Sultanah Bahiyah, Kedah. Another round of applause for Farida Yusof and her team. Thank you very much, and congratulations to all winners of oral presentation and best posters award. Not to forget, we have another 2 awards. And these 2 awards are created specifically for virtual seminar, virtual congress. Then this is the second award, which is the best graphic award. So this best graphic award is chosen. This poster was chosen by our team of poster judges. And the winner goes to this poster by Dr. Hong Wei Chai, soft tissue, entitled Soft Tissue Augmentation and Phrenotomy in patient with repaired bilateral cleft lip and palate, a rare case report. So this is the best graphic award from our poster display in our virtual congress. And the last award and the best graphic award will have 200 ringgit awarded for the winner. 200 ringgit, yes. And the last award is most popular poster. So we also have this award, and this award is chosen by the participants of the Congress. And based on our voting list, we have a top 5 papers with highest total vote value. Topmost is abstract number 19, poster number 19, entitled Diagnostic Dilemma of Cardiac Sarcoidosis, a case series, which garnered a total of 75 vote value altogether. And let's congratulate the author. Next slide. So this is the poster by Dr. Izzatul Nazira Ismail. That's the whole awards that we have, but I believe most important than this is that you should thank yourself as the abstract submission author, who has done a very good job in preparing your own abstract and submitted your abstract to the Congress. And I think you should be proud of your work. This award are just here to recognize the best achievement, but I believe you shouldn't stop here. You should follow up to submit your paper in a better way, in a more educational way, academic way, by publishing them in a journal or in other meeting or symposium. Thank you very much. I will pass the mic to Dr. Joash.
Thank you so very much, Dr. Afifi, for announcing the winners of our posters. And I believe the scientific committee is very, very pleased with the high quality and the commitment and dedication shown by our participants. So once again, thank you so very much for choosing to submit your work. Now, I would like to invite our chairperson, our organizing chair, Dr. Neil Amri, to come and to deliver his closing remarks for the scientific meeting.
Assalamualaikum warahmatullahi wabarakatuh. First of all, syukur alhamdulillah. Thanks to Allah who allow us to successfully completed this wonderful program. I just want to say a few words. I think much have been said by Joash and also Afifi. I just want to add a few things. First, I think it's a challenge to conduct such a big program like this virtually. But I believe the participants and all of us that we gain so much knowledge and also benefit from this whole wonderful program. This program actually initially was planned 3 or 4 years ago, but because of the pandemic, it is changed a few times from physical to actually a hybrid. Our program today with the pre-congress workshop in combined with some live sessions. I would like to congratulate again to all the committee members. Kudos to especially our co-chair, Dr. Afifi. Applause to him. Joash, Iza, and all my committee members who work tirelessly, putting their effort and also their time to make sure this program is successful. I would like to thank also to all the senior consultants who give their opinions and also their time in involving the program. And also I would like to the all speakers and MCs who also contribute much to this program with their time spent preparing the slides and also sharing their knowledge. Last one, but not least, I would like to thank to the industry's player, our sponsors, who contribute much to make sure this program runs well. To our IT team, Web Soho, also who help us running this program successfully. To all the winners, congratulations again. And the last word, I think the committee members are looking forward to see you guys again in the next BSM. Hopefully, we identify a few fellows who are very have a lot of experience, and also their energy is so much who can contribute much to our future BSM. Last word, stay safe. Thanks to all again.
Thank you so very much, Mr. Neil. Okay, so that's it. That is all for us from the PGMES. Once again, thank you. And a special shout out, a special thanks to our wonderful support services from Hospital Sultanah Bahiyah, from the Pengarah's office, down to the IT team, down to the audiovisual team. You do not see them here. They are the ones manning the laptops. They are the ones all the way behind in the auditorium who are arranging the lighting system. So thank you so much. We would not have been able to achieve any of this without you guys. So continue to stay tuned to our Facebook page. Continue to stay tuned to our PGMES.hsb.org website. We are going to be announcing a number of events lined up, beginning from webinars to a live face-to-face interactive session on communication skills. So the best is yet to come. It's our 25th year anniversary. So stay tuned. Thank you for your support. And one last announcement, for all the announced winners today, please claim your prizes after the 1st of April from our PGMES office. It's not an April Fool's joke, but it's administrative purpose. We will need 10 days to clear finances before you can come and claim it. So once again, after the 1st of April, please head over to the PGMES office at the Pejabat Pakar. That's all from me. Signing off. I'm Joesh, Deputy Secretariat. Thank you, everybody, and see you next year.